You are live now, ma'am.
Hello and good morning, everyone. I'd like to extend a very warm welcome to one and all who have chosen to be part of the state meeting. Just to give you a brief introduction, this is an annual meeting wherein we have a state competitive session in every state, and the winner of each state then represents the state at the conference, which is now going to be held in Delhi in the month of October, on the 4th, 5th, 6th of October. I truly would like to appreciate the students who have been courageous enough to participate, and equally all the mentors who have joined hands in supporting the students in preparing for their presentations, as well as actually being there today to support them should there be any questions that arise. Gives me great joy and an immense sense of pride to state that we've got almost the largest number of participants in the country. We've got 20 participants from a total of 10 colleges from all around Maharashtra, and I can't thank you all for being part of this enough. Without any further ado, let's move to the next talk. Dr. Mohita Sharma, who's going to speak to us about where we are today and what's the way forward, is going to join us shortly. Tanvi, I hand over to you now to bring in the next speaker and start with the next presentation. Just before I do so, I'd like to know that we will be starting the first competitive state session at 10:10 in the morning. Over to you, Tanvi. Let's get this rolling.
Thank you, Dr. Subira. Good morning, everyone, and a very warm welcome to this exciting session of our residency. We are thrilled to have all of you here as we dive into what promises to be an insightful and competitive round of presentations. I am pleased to introduce Dr. Anjali Mehta.
Video on.
Recording in progress.
Hi, sorry for the connection issues. Just 1 second, I'm sorry. Dr. Anjali Mehta is an ex-army ophthalmologist who has worked and taught in several institutes. She currently practices in Dwarka and also heads a charitable trust that works for the marginalized. She works on social issues and is a GHMS alumnus of medicine, Sans Frontiers, and a diploma holder in tropical medicine and hygiene from London. She holds an Indian patent for a biodegradable material to replace plastic. Dr. Anjali, we welcome you to the session and ask you to begin your talk.
Good morning, Dr. Suvira, dear colleagues, and of course, the future of ophthalmology, our lovely residents. I wish you a very good morning. It's a very special feeling for me because I also studied at Maharashtra, AFMC Pune. So it's lovely to be with you all. And I'm just going to close my eyes for a few seconds and say a prayer for the parents of our colleague who died in Kolkata. It is my pleasant duty to introduce to you Project Archana. And I'm going to take you through 4 headings very fast. What is Project Archana? What do we do in this project? How we conceived it? Why did this project come about? And a little advice for young residents. So Project Archana is basically deals with a medical legal crisis, right? And what is a medical legal crisis, just to tell you, is something like, let's say somebody accuses you of negligence, or you're sitting in your workplace and someone perceives that you haven't done a good job with them, and their relatives come and attack you. Situations like these come under what we call a medical legal crisis. There's also a sub part, when, let's say, a patient of domestic violence comes to you, or a road traffic accident, that also comes under medical legal cases, but that is different. Those are medical legal cases, dealing with patients. And we are talking about a medical legal crisis that can be a workplace challenge for doctors. So basically, how we came about this was, you would remember that maybe 2 years ago, in Rajasthan, one doctor committed suicide. Now, she was an excellent professional, very competent, had good distinction, and there was a high-risk patient. And the patient died because, we deal with life and death. Our colleagues deal with life and death, not so much ophthalmologists. And that's not our fault. But the local politician decided to exploit the situation and did a dharna outside her hospital. He also lodged an FIR in the police that she's committed a murder, which is actually not allowed. And she was a very simple doctor who didn't know about, legal ramifications. So she got scared that I'll be arrested, and she committed suicide. Now, I'd like you to know that, nobody can file an FIR against a doctor because there is no intent to murder. It, happens accidentally, or it happens in spite of our best effort, right? And the thing is that one of the reasons she committed suicide, she didn't know there's a proper process, there are a lot of safeguards for doctors. So Dr. Mohita and other people in the board, colleagues, they said that no ophthalmologist should be in this situation where they don't know of their rights and they get panicky and they get scared. So that's how this Project Archana, dealing with the medical legal crisis, came about. Lovely initiative of WOS. Now, what do we do exactly in this project? In this project, we have webinars and we have sessions at our annual WOS conferences. And these sessions, basically, they deal with 4 aspects. One is the individual aspect, where the doctor who's facing a medical legal crisis, say you're at work and suddenly people come to attack you, or hello, can you hear me?
Yes, ma'am.
Yeah. Or suddenly there's a case filed against you. So what do you do as an individual? People want to make sure that you don't panic. So there is one section of the panelists which tells you that, instead of just getting frozen in shock, how to calm yourself. They tell you breathing techniques. They tell you mental things to think, that you've treated so many cases successfully. Don't preoccupy yourself with this one case. So there are a lot of mental and physical techniques to keep the individual calm. The second aspect of the panel deals with getting immediate help. Because when you're in a crisis, some of your work has been interrupted and there are other things you have to do in future. You need help. You can't handle all of it when you're, dealing with all these problems. So how to enlist help from your staff, how to train them, how to enlist help from the people around you, your colleagues around you. Now in hospitals, you have this code violet and somebody will come and run and help you. But for individual private practitioners, it's very difficult. So how to set up self-help groups and things like that. The third part of the panel deals with institutional help. That is fine. You've taken care of the situation immediately. But what next? So it tells you how to, connect with bodies like maybe AIOS, DOS, IMA and all that. So third part is institutional help. Fourthly, and most importantly, is your legal rights. So we always have people who know the law, either we call legal experts or our own ophthalmologists who've done law. And they tell you that there are so many, and in fact, it's very reassuring to attend this session because they tell you a whole lot of laws and procedures. The procedures are long. I want to tell all the residents that there's nobody in the world who can come and catch you today. Aapne galti kari. No, it's a proper process. Another professional has to look at it. You have time, you have enough legal safeguards, so don't worry. And lastly, at the end of each session, we leave a discussion period. In this discussion period, people who've been the unfortunate, at the receiving end of any negligence cases or have been attacked, they share their experiences. They share things like, is it better to have lawyers through insurance? It is better to, hire local lawyers. Is it better to go to state bodies? So practical advice like that is shared, amongst us. Now, the fourth aspect I'd like to tell you is that right now we are having webinars and conferences, but what are we thinking of in the future? So right now, this is not fully established, but Dr. Mohita is in the process of establishing perhaps a legal cell in future where you can take advice, maybe pro bono, maybe, on a little payment, where they can give you advice if you have some legal problems. And also the same cell may have a support staff who can direct you to the various, depending on the sort of help you want, they can direct you to agencies, to institutions, guide you nicely if you don't have help, right? And now lastly, I'd like to take all this and how does it apply to residents, right? How can you stay out of a medical legal crisis? Well, of course, the first and foremost thing is that you have to be professionally very sound. And nowadays, I think there's a lot of emphasis on studies. There's so much material available, so many conferences, so many opportunities, workshops and all that. There's no reason not to be up to date and fully qualified. So your best safeguard is being, very good in what you do. The second is being very courteous and humble. I realized that if you have a lot of humility, you realize your limitations, you refer patients which you can't handle, you speak courteously to patients, the chances of your getting, caught in, sort of litigation become very low. Because in their hearts, everybody understands that a doctor is not a god. Sometimes mistakes do happen, circumstances do happen. If every result was assured, then nobody would be praying outside a doctor's, operating room. Anybody goes for a surgery, people are praying outside. So if the outcomes were assured from before, people wouldn't be. So in the heart of hearts, everybody knows that. But still, humility goes a long way. And I would like you residents never to let down each other, right? Because if you support each other, you were not there when the surgery happened. You don't know what the, complications the surgeon grappled with. Maybe the complications were so extreme and yet the surgeon did a fabulous job. Maybe not 6x6, but 6x12. Under those circumstances, the surgeon would have been brilliant. You can't judge because you were not there. So never run down each other. Be very supportive of each other. And if you're kind and supportive of your colleagues, you'll find that the litigation towards the community in general goes down. You can, guide each other, tell each other quietly, but don't, try to make the patient more anxious, because what has happened has happened. If you try to run down colleagues and magnify the problem of the patient, you're harming both. First, the patient will become full of anxieties and worry and all that, and spoil their life, and you will also tamper with the reputation of your colleagues. So my bottom line to all of you is that work hard, study hard, be friendly and supportive of each other. And as this Calcutta case has taught us, the most important thing is solidarity. When we are in any sort of trouble, like this person was attacked, or if we are in a crisis, what is it that all of us really seek in the bottom of our hearts? We want solidarity. We don't want to fight our battles alone. So just remember that and put yourself in everybody's shoes. Always support each other. And lastly, right now, while the cell is being set up and before we have a formal, entity in WOS where you can address your complaints, please feel free to mail me if you have anything relating to a medical legal challenge at your workplace, right? And I'll definitely pass it on to Dr. Mohita, and we'll try our best to help you. Have a lovely day and all the very best to all the young, enthusiastic participants. I'm sure all of you will do well. Unfortunately, only a few have to be selected to Delhi. I wish all of you could have been selected and come to Delhi, but the very, very best.
That was a brilliant talk. Thank you. So as of now, that was going to be my question, the one you answered right at the end. would you suggest that if we have any issues, we can directly email you, however small, however minuscule, and however insignificant it may seem to us? You would encourage us to connect with you, right? Anjali,
Yes, I
ma'am?
would. I would highly encourage you to connect with that with me, because of all these sessions and all that we have a network of people we've been inviting. So one has their numbers, one has their contact phone numbers and everything. So depending on your thing, I would be able to sift out that who will be able to help you best and will be able to connect you with them. So that would be a very useful help, I think, to the students.
Yes. I mean, because really till now we've had nothing. There was no go-to person or go-to place where we could come and discuss our issues. So this, I think, and given with what's going on in our country now, there's nothing, the need of the hour is to have this kind of support so that no one needs to shy away from coming up with things that they may be facing at their places of work. Because that's how we are conditioned to grow up, to be able to accept and to be able to, even things like bullying and things like that, So I think it's a fabulous initiative, and I'm so proud of you heading it and taking this kind of care of all the female ophthalmologists everywhere in our country. It's exceptional work, and congratulations. Let's ask the audience if there's anyone who would like to discuss any particular aspects about this with you. It's open to anyone in the audience or any of the speakers would like to ask or speak about anything, please. Let's do that.
Hi, ma'am. Can I ask a question?
Sure.
Hi, ma'am. Ma'am, so the project which you have, I have heard it from, quite a few years. It's been around 2-3 years, or probably more, ma'am.
Yes.
Yeah, so have you had such people coming up front and actually coming up with their issues? Or do you feel that people are still hesitant among our community of people?
No, in fact, when we have these sessions at WOS, there are very lively discussions at the end, even in the webinars. And people actually who are facing a situation, they exchange information that, did you have? So some people are very helpful, and they, despite the fact that they've gone through a lot of trauma in a medical legal crisis, they share with others that this is what I went through. These are the difficulties I faced when I approached the state authorities. These are the difficulties I faced when I approached the National Medical Commission. So there's a very lively discussion at the end, and people always help each other. Then people will exchange numbers and all that. So it's that
So
beautiful
that
network.
goes forward. That goes forward for them to take it ahead and help the person who's actually still going through or has gone through.
Yes. People give them inputs. They'll say, instead of trying this, try this. These are your other options. Or this is a very good lawyer I can connect you with. This is an ophthal specific lawyer. This is a person who's actually sat on the board and adjudicated cases. So he would know.
So, ma'am, are you catering to only ophthal people or general specialists, also females affected in other specialities of our this one fraternity, or only ophthal?
So that's a lovely question, because this help by WOS is available to women ophthalmologists, because that is our jurisdiction. But we've invited so many people, like there are gynecologists, for example, in Dwarka, who've created very successful self-help groups. So we've invited them to our ophthal conferences, to tell us how they did it. We've invited lawyers, bona fide lawyers, to tell us about our legal rights. So there's a huge amount of interaction with other specialities, because this could, affect everybody. As an individual, I help women all the time in any sort of social or domestic crisis. But the jurisdiction of WOS is to help. We are obliged to help our young colleagues or older colleagues. But as a person, you can just help anybody outside the.
Yeah, of course. Thank you, ma'am.
So good morning, everyone. So I would like to take a few minutes of you. So AIOS has a legal cell as well as the AIOS Adverse Event Committee also. So if any consultant or any ophthalmologist having any problem like TAS or endophthalmitis or even cluster endophthalmitis, so we take care of all that thing. So our team goes there at their center and they do all the basic investigation there, and then we put it to the AIOS headquarters. So we are with them, even we provide them legal assistance also if needed, irrespective of their gender.
Thank you so much, sir. Is this assistance free of cost?
Yeah, free of cost. Absolutely. For all the AIOS who are the members. So it's free of cost for all of them.
Good morning, Dr. Moira.
Yeah, very good morning, Dr. Suvira. Good, so good to see you.
I know, lovely to see you, even if it's virtual this time. So who do we contact if we have an issue and want to reach out to the AIOS team?
Yeah.
And it's brilliant to know. I really didn't know that even if we are facing an end of, because it just paralyzes you, something like that for
Yeah,
no
they are
fault.
for every one of you, right? For every
Yeah.
one of our
One of
members.
us.
So on the AIOS website, so you will go into the presidential committee, and then there is AIOS Ocular Adverse Event Committee, and there is a link. So you can go there, you can click there, and you can fill that small form is there, and the rest will be taken care by us. So we are visiting all parts of India. If any of our friend is having any problem, and
Right.
we have the best of the labs, so we are getting the consumables
I'm not
tested.
quite sure, but have you had any kind of a webinar wherein people can be invited to understand all their options in cases like this?
Yes,
Maybe
we
we could
did.
do something or a
Yes, we are doing it in the state these annual conferences, and now in September we will be starting 10 modules, right? Most probably every Tuesday, 8 to 9:30.
fantastic.
8 to 9:30 p.m. So you can get the certification course also. It's only 1,000 rupees. So all the modules will be taught to all our friends.
I think that's really fantastic. Please do
Yeah.
share the link so that we can
Yeah,
spread
it
it
will
all
come
over
as
our
mail,
individual
and
states.
no problem. I will put in the all the means WhatsApp groups also. No problem.
Fantastic.
And
Thank
I'm
you.
convener and this program director of that module.
Oh, very nice.
Yeah.
Thank you. And
Yeah.
I'm glad to have heard this. Is there anything else, Dr. Anjali, you'd like to add on in the finishing touches of your talk? Is there any more pearls or any more key take homes that you want everyone who's attending to just to just be mindful of, that they remember that this is our go-to place as well? Please let me know.
Yeah, the last word would be, I think what in the cases who actually unfortunately did sort of end up in the courts, the one thing that has sort of sunk a lot of people with the best intentions and outstanding work is lack of documentation. That has
Okay.
become a very very strong legal point. If you're well defended with your documents, so in every case there should be a system of good documentation, and especially in cases where you have some problem, just make sure your documentation is superb, because doctors who are going to be judging the case understand the medical risks and all that, and are very likely to understand your perspective and go soft on you, seeing your years of good work. But if your documentation is bad, then the lawyers find a loophole to catch you. So excellent documentation is what I would emphasize on.
And where do we find the guidelines? I mean, I'm talking for the students as well. If they want to know exactly, how everything needs to be meticulously mentioned, date, signature, findings mentioned, so they don't need to be tampered with later on. Is there any guidelines somewhere as well that residents on their path of actually getting forward as being practicing clinicians can be taught how to maintain? But I guess we do have NABH that does a pretty good job with the guidelines. Anything else you'd like to suggest? And then we will close this topic.
So there are two additional things. One is, of course, your informed consents. So the AIOS, again, as you know, the AIOS is a wonderful fallback and go-to for everything. They have this superb book on the perfect, they've made those forms, consent forms for each and everything. So that most of us are using. It is so carefully and so beautifully documented after years of inputs. I can't find a better document. The other thing is, when you are conducting research trials, then again you have to inform the patient properly. And what we do is we keep two sets of the consent. One you hand over to the patient, which describes all the things, procedure, and what, why you're doing the study, etc. And one you get them to sign and keep the copy with you that confirms that yes, they received a copy. So two parts. One is actually handing them their copy and keeping a signature from them that you've kept your copy. And
Fantastic. Fantastic. Were you going to say a third point as well? I'd love to hear
no,
that.
not at all. Not at all. As a
That's it.
third, what Suvira already said, that the NABH and other agencies also help
Yes.
keep tabs.
Thank you so much for taking your time on enlightening everyone here about the project that you're taking care of. I thank you on behalf of WOS, and thank you on behalf of Maharashtra and all its participants for being part of this with us. Thank you,
The
ma'am.
pleasure was all mine.
Thank you. Thank you.
Bye, Suvira.
Tanvi? Okay, bye-bye. Dr. Tanvi, I now hand it over to you to start the state competitive session number 1. We are on time. We start at 10:10. Thank you.
We thank Dr. Anjali for this insightful talk, and we now begin with our first round of competitive session of the Maharashtra chapter of the Residents' Meet. But before we begin, it's my pleasure and privilege to introduce this esteemed panel of judges for the first competitive session, who will guide us with their expert insights and feedback. Our first judge is Dr. Surbhi Dutt. Dr. Surbhi is a senior cornea surgeon from Delhi with over 15 years of experience. She's completed her fellowship in cornea at Dr. Shroff's Charitable Eye Hospital, and she specializes in keratoconus, chemical injuries, and severe dry eye. She's currently affiliated with Synergy Eye Care and the AK Institute of Ophthalmology. We next have Dr. Professor Arvind Kumar Maurya, a distinguished additional professor and head at AIIMS Hyderabad. Dr. Maurya has received numerous accolades, including the Ophthalmic Star Award and the AIOS International Hero Award for 4 consecutive years. His pioneering work spans artificial intelligence in diabetic retinopathy and glaucoma. He has over 600 presentations and 100 publications, and also serves as on the editorial board and has been a faculty member at various prestigious international conferences. Our next judge is Dr. Gitika Srivastav. She's an assistant professor of ophthalmology at LG Hospital in Ahmedabad with over 11 years of experience. She has published over 10 research papers on topics including rose-K contact lenses and eye donation awareness. She's an active member of several societies such as the Delhi Ophthalmology Society and the AIOS, and recently participated as a panelist at the Gujarat Conference of Ophthalmology. Finally, we have Dr. Rajvinder Kaur, professor and head at Adesh Institute of Medical Sciences, Bathinda, Punjab. She's the managing editor of the Adesh Journal and holds key roles in state ophthalmological societies. Her research contributions have earned her awards in various conferences, along with the IGO Platinum Award for the Cosmic Study. Her primary interest lies in retina research, and her work is published in various index journals. Good morning, judges. We are now ready to begin the competitive session.
Very good morning.
With Dr. Alisha Ranga, whose mentor is the distinguished Dr. Naina Poddar. Dr. Alisha, the stage is yours.
Good morning, everyone. I am Dr. Alisha from Nair Hospital, and I'll be presenting a case of old ground syndrome today. It's a form of vertical strabismus with limited elevation of eye in adduction due to mechanical restriction of superior oblique tendon trochlea complex. We present to you a case of 42-year-old male with downward deviation of left eye since birth. Patient had no history of any ocular trauma, diplopia, or any known systemic illness. On examination, head posture was normal. Patient had left eye hypertropia in primary gaze with limitation of elevation in adduction more than abduction. Now presenting to you the 9-gaze picture of the patient. Patient had 25 prism diopters of R by L with 5 prism diopters of exotropia in the primary gaze. So if there is elevation in adduction, limitation of elevation in adduction, and FDT is found to be negative, then Brown's is ruled out. But if the FDT is positive, it could be Brown's, orbital fracture, or endocrine myopathy. But since there was no history of any ocular trauma or any known systemic illness, the latter two got ruled out and a diagnosis of severe congenital Browns with amblyopia was made, and left eye superior oblique tendon expansion procedure was planned for the patient. On isolation of superior oblique on table, it was found to be thick and bulky. So split tendon lengthening was performed for the patient as follows. Here you can see exaggerated FDT of Guyton was repeated on table after retropulsing the globe, which showed a tight superior oblique in the left eye. Now superonasal peritomy was done to hook superior rectus, as you can see, and then superior oblique was then hooked from superonasal quadrant itself. Superior oblique was then split into two segments. Here you can see a beautiful diagrammatic representation. Two sutures were then passed, one in the upper nasal and one in the lower temporal quadrant. Superior oblique tendon was then cut and the ends were tied to get 8 mm of elongation, as you can see in the video. Post-op FDT was repeated, which was free and negative for the superior oblique. Conjunctiva was further closed using 8-0 vicryl sutures. Now you can see the post-op 9-gaze picture showing central corneal reflex with improved elevation in adduction. It is the pre-op and the beautiful post-op 2 weeks picture of the patient showing central corneal reflex. Now the other options can be superior oblique tenotomy plus IO recession, but as in our case, the superior oblique tendon was thick and bulky, we decided to go for split tendon lengthening. In superior oblique tenotomy plus IO recession, the advantage is there is less risk of superior oblique palsy, but it can lead to significant undercorrection as well. The other procedure can be silicone expanders of superior oblique, but this procedure is difficult to perform, and since we are putting a foreign material, it can lead to inflammation, and the extrusion of implant is also possible. Another technique which can be used is superior oblique tendon spacer with chicken suture, which has the advantage of being easy and controlled. So superior oblique split tendon lengthening is a quantitative, controlled, and reversible procedure with no added expenses and foreign body reaction, since there is no use of any foreign material, with excellent preservation of functional arc of the muscle. It yields a satisfying outcome for the treatment of Brown syndrome with long-lasting results. Thank you so much.
Thank you, Dr. Alisha, for this excellent presentation. We will now begin the discussion for your case. I'd like to invite our esteemed judge, Dr. Arvind Kumar Maurya, to lead the discussion.
So
Dr.
Alisha,
Arvind, please share your insights with us.
Alisha, very good case,
Yes.
this unique case. So how you differentiate between the congenital or the acquired cases in relation to the downshoot and adduction?
Sir, in congenital cases, since there will be a long-standing history, there will be downshoot present during the adduction movement.
Okay.
But in acquired cases, that might not be so. But also, congenital cases, if it is severe, then there will be hypertropia in the primary position as well.
What about the head posture in such cases?
In severe cases, you can get the head posture as well, which will be the head posture would be towards the affected side. There might be a chin tilt present as
Very
well,
good,
sir.
very good. And how come this binocular single vision is maintained in most of these Brown syndrome patients?
If it is congenital, sir, usually they acquire head posture and the chin lift for the binocularity. If there is diplopia present, then that is a short indication for performing surgery in such patients.
Although there is means amblyopia is there in few of the patients, but the BSV is maintained. And what about this CSSM, central steady contained fixation?
The given eye, which amblyopic eye might be suppressed by the patient.
Okay. And regarding the surgery, how the surgical modalities are different in congenital as compared to the these acquired cases?
Sir, usually in acquired cases, which might be because of inflammatory conditions such as rheumatoid rheumatoid arthritis or an SLE. We can also go for injections of steroids instead of going for the surgery first. These steroids are given near the trochlear tendon region, and they can be repeated monthly if the patient is not willing to go for the surgery. But in congenital cases, if the patient is having severe case of Brown syndrome and there is significant hypertropia present in primary position, we can go ahead with the surgery. If there is no diplopia as well, we can go ahead with the surgery if patient want cosmesis. Otherwise, if patient is not willing, then we can go for injections as well.
Okay,
Yes.
that's great.
Required case.
And what about how you manage the amblyopia in such cases?
We can just prescribe them the best corrected vision for now, sir. There is, sorry, I'm not sure about
Okay.
that, sir.
Dr. Naina, you would like to take this question?
Sir, in this case, good morning to all. Sir, in this case, since the patient was quite old and the amblyopia had, grounded, his vision was 624, we couldn't help much. He wanted a cosmesis, so we aimed for that and didn't go ahead with any amblyopia management.
So there was this same case, aged 56 years. So we first did the surgery and then we removed the cataract surgery. And then we started with the orthoptic magnocellular stimulator and the patient vision increased from 6/18 to 6/6 part after 12
Excellent.
visits. Yeah,
Oh, we don't have that facility here.
yeah. So
So
it's
that
just
is why
for
we
the
couldn't
sake of
proceed.
everyone's,
Yeah.
it's
Yes,
just for the
yes.
sake of everyone's knowledge.
Yeah,
So,
yeah. Heard
yes,
about
thank
it,
you.
sir.
Thank-
Yeah.
Yeah.
Thank you.
Thank
Yeah.
you.
Okay.
Can we move to the next case? Thank you, Dr. Moria.
Thank you, sir.
We request the judges to please note down their marks. And we will now hear from Dr. Sanskriti Sulbhevar, who is mentored by Dr. Twinkle Choksi. Dr. Sanskriti, the floor is yours.
Good morning, one and all present here. I, Dr. Sanskriti Sulbhevar, second year resident from Nair Hospital, Mumbai, under the guidance of my mentor, Dr. Twinkle Chokse, is here to present on the case Ultrathin DSEC. Thinner the graft, clearer the vision. Over the years, endothelial keratoplasty has seen a significant transition from penetrating keratoplasty to DLEC, to DSEC, and currently to DMEC. Now let us understand what all these terms stands for. In DMEC, the graft thickness is 14 to 20 microns with lesser rates of graft rejection and lesser rates of IOP elevation. In DSEC, the graft thickness is more than 150 microns with less steep learning curve and easier technique. With ultra-thin DSEC, the graft thickness is 50 to 99 microns with faster visual recovery and less induced astigmatism. So now, why are we doing ultra-thin DSEC? It offers us best of both the worlds with lesser learning curve, easy tissue preparation and graft handling, lesser tissue losses, and lower rates of rebubbling. Let us understand now the step-by-step surgical approach. It starts with donor preparation. It can be done using manual technique, which is an inexpensive technique, but offers us irregular donor tissues. It can also be done using microkeratome, which is little expensive, but offers us more uniform donor lenticules. It can also be done using femtoseconds. It gives us irregular cut, and it's quite expensive. Now, how to prepare an ultrathin tissue? A donor tissue is mounted on an artificial anterior chamber. A 400 micron partial thickness incision is made. A lamellar dissection is initiated using a crescent blade. Further, the dissection is continued using straight and curved lamellar dissectors up till the limbus. Anterior cap is cut and reflected. Further, the graft is rotated 180 degree to undergo the second pass. After the second pass, another lamellar dissection pocket is initiated using the crescent blade. It is further continued using crescent blade to avoid perforation due to shearing forces, and then continued with lamellar dissectors to reach up till the limbus. Now, the stromal tissue is cut and reflected partially. The tissue is then marked, and the anterior corneal layers are put back. Now the tissue is ready for trephination. Corneal trephination is done using corneal trephines, and the tissue is ready to be loaded on a 2.8 mm Busen glide. Next comes is the donor insertion techniques. It can be done using IOL glide push techniques, Busen glide pull through technique, and endoglide and endo insertion can be used. The above video shows us the Busen glide pull through technique used for donor insertion. After that, last comes up the air bubble management. The air bubble, initially a full chamber air bubble is instilled, which is later on decompressed to the size of 2/3 anterior chamber, and the patient is advised supine position. These are the day 1 and day 2 post-op bubble pictures. Now, in which patients are we doing ultrathin D6? It is mostly used in patients with multiple iris defects. Here shows a graft thickness 73 microns with 1 month post-op BCVA 612 parts. In patients with one eye with BCVA of 612 parts at 2 month post-op and graft thickness 66 microns. It is also has shown significant improvement in patients with CHED with 6 weeks post-op of 618. It can also be used in patients with vitrectomized eyes and hypotony, which gives us amazing results of 660 vision post-op 2 weeks. Now, what is the take-home message? A tailor-made approach should be made on the basis of corneal decompensation and complexity of the eyes. Here, ultrathin DSEC offers us a minimal hyperopic shift, has given us comparable visual outcomes to DMEC, has a easier tissue handling techniques and easier learning curve, and can be considered for complex eyes. Thank you.
Thank you, Dr. Sanskriti. Thank you, Dr. Sanskriti. I'd like to invite Dr. Surbhi Dutt for the discussion. Dr. Surbhi. Ma'am, your audio is muted.
Oh, sorry. Thank you, Sanskriti. So the case presentation as such is all right, but the question which I would prefer to ask as a junior who is actually beginning, would you prefer to do DSEC or would you prefer to do ultra thin DSEC? It would be my first question to you. Second, what is the rate of the comparison between DSEC compared to ultra thin with the incidences in the published papers? If you can first tell these.
Ma'am, as a junior starting with the residency, I would prefer to go with DSEC because it has a lesser learning curve and it will be difficult for at my level to undergo or to achieve a graft thickness which is required for an ultra thick DSEC. And if we consider ultra thin DSEC and the DSEC we undergo routinely, the graft thickness ultra thin DSEC offers us relatively clear as the graft thickness is lesser as compared to DSEC. It offers us clearer vision and has greater visual rehabilitation. And incidences, I'm not very sure about, ma'am.
Okay, so basically, if I have to tell for the whole podium, the incidence of complications obviously are comparatively lesser with ultra thin, but when you're coming to DMAX, the complication rates are more with DMAC,
Yes.
like you said, right? But when you have to see the outcome over a year, we're not thinking of 2 months or, a month or so. The outcome, in fact, is equal compared to DMAX and ultra thin D6. So as such, if you have to understand, you should be able to do, you should have done at least around 50 to 70 cases of, all the spectrums of DSEC and ultra thin. And then you gradually go to at least start doing your cases after that. So basically that is important. Now, if you have to see for the complications, how much is why is it comparatively lesser in your DMAX? If you know the theory and the pathology and also the corneal anatomy, if you can just share it with us.
What are the complications in DMEC?
No, so why is it comparatively lesser in this DMAC?
Why are the complications lesser in DMEC?
Yeah.
Ma'am, it offers us, as the thin tissue is cut in DMEC.
Okay. I'll put it in, a slightly easier way for you. If you have to see for the layers that are involved and, the part which is getting transplanted, the DMAC part is obviously thinner,
Yes.
right? And the ultra thin is more thicker, right?
Yes.
It's roughly around 100 microns, and the DMAC is roughly around 50 to
Yes.
15 to 20 to 50 roughly. Okay. Now, why would it help us more? That is my question. Converting ourselves as specialists, as surgeons, shifting from DSEC, why would someone want to shift to DMEC? Is my question. Just think out of it. It's not a very difficult question I'm asking you.
30 seconds more for the discussion, please.
Okay. Okay. So the thing is, DMEC does not have any stroma in it, right?
Yeah, correct.
So the risk of complications is obviously going to be less. The corneal integrity, the corneal contour is going to be maintained better. Okay. So that is why we encourage people to shift over. But of course, the complication rate for seniors is going to be obviously lesser. Juniors starting off would be more. So
Yeah.
that is where the thin benefit of having ultra thin is important. Okay, thank you.
Thank you.
Excellent presentation and discussion. Well done, Sanskriti. Tanvi, over to you.
We now invite Dr. Sarah Wangdi, mentored by Dr. Naina Poddar, to present her case. Dr. Wangdi, please begin.
Sanskriti, you may need to
Stop
unscreen
sharing,
share.
please. Yeah,
Thank
stop
you.
sharing. Thank you.
Good morning, one and all. Today, I shall be presenting the topic Key to the Ophthalmology Abode, a Nasty Surprise. I'm Dr. Sarah Wangdi, second-year resident from Nair Hospital, and my co-authors are Dr. Naina Poddar, Dr. Madhi Bijlani, and Dr. Madhav Shah. Case presentation. A 20-year-old male presented to the emergency services of our hospital with alleged history of trauma to the left lateral side of the head with a metallic foreign body, penetration of a key, within 12 hours of the occurrence of the incident. Patient was allegedly walking down a staircase, twirling his bike keys when he tripped and fell on his keys, with the key getting lodged firmly on the left side of his head. He complained of pain on the left side of the face, swelling and discoloration over the left eye, a subconjunctival hemorrhage, and restriction of extraocular muscle movements. Here are two images of the patient taken in the frontal and the lateral view, showing the key lodged firmly on the side of the head. On general examination, he was conscious, cooperative, and oriented. Vision of both the eyes was 6/6 on Snellen's eye chart. Tension of both the eyes was digitally normal. Extraocular movements of the right eye were full and free in all directions, while the left eye showed mild restriction on the lateral gaze. Left eye showed a temporally located subconjunctival hemorrhage with lid edema and ecchymosis. Rest, bilaterally, anterior and posterior segments were within normal. On CT brain plane and 3D CT face, a metallic density foreign body was seen extending from the left temporal fossa, traversing through the anterior wall of the left middle cranial fossa and through the posterior part of the left lateral orbital wall with a 7 mm protrusion of the foreign body key into the orbital cavity. The foreign body measured around 6 cm and was seen deforming the left lateral rectus muscle. Optic nerve was medial to the tip of the foreign body with at least a 2 mm distance between the foreign body and the optic nerve. No large orbital hematoma was observed. On the left, we have a coronal section of the CT brain plane showing the foreign body around 7 mm protrusion into the left orbital cavity with the tip around 2 mm away from the optic nerve. And on the right, we have an X-ray film showing the foreign body protrusion. Here, we have a three-dimensional CT face showing the foreign body lodged into the left side of the head. Treatment. This case was managed by a multidisciplinary approach involving neurosurgeons and oculoplastic surgeons. Patient underwent lateral wall orbitotomy and burr-hole craniotomy with foreign body removal under general anesthesia. He was started on intravenous antibiotics and anti-inflammatory medications and regularly followed up. On postoperative day 10, his vision was 6/6 on the Snellen's eye chart, and a subconjunctival hemorrhage with edema and ecchymosis resolved by 15 days with normal extraocular muscle movements. Here are intraoperative videos of the same, with the video on the left showing a lateral wall approach, and on the right, a burr-hole craniotomy being done. Here is the successful retrieval of the key, with the image on the left showing the removal of the key from the site of injury, and on the right showing the key. Here are day 15 post-operative 9-gaze photos of the patient showing full and free extraocular movements with resolution of the subconjunctival hemorrhage, lid edema, and ecchymosis. In conclusion, patient was fortunate that despite such a disastrous injury, there was no effect on his vision. Post-trauma patient's vision and extraocular muscle movements have been preserved without infection, inflammation, and no residual damage due to early intervention by neurosurgeons and oculoplastic surgeons, leading to the best possible outcome. Thank you.
Muted. You're not muted, right?
Thank you, Dr. Sarah. We now invite Dr. Arvind Kumar Maurya for the discussion.
So very nice case. You have presented very well in such a less time. So which investigation modality must not be done and why in such kind of case?
Yes, sir. So,
Can you tilt your laptop a bit? Yeah.
Is this better, sir?
Fine. Yeah, perfect.
Yeah. So, since this is a metallic foreign body, one of the main investigations which we will avoid will be an MRI. Considering that MRI is magnetic, so it will cause shifting of the foreign body and thereby increase the damage leading to the surrounding areas.
Great. And any orbital lesion you are having, so which examination you are doing? What are the 6P? 6P.
Sir, 6P.
Yeah.
So,
Pain.
during the examination.
One is
Yes,
pain.
sir?
One is pain.
Pain.
Hmm.
So pain, and then when we ask the patient, when we check the extraocular muscle movements of the patient as well, there was only some restriction on the lateral gaze.
That is
However, the
progression.
patient,
That is progression, right? What else?
so we check the pupils as well of the patient and checked, they were both reacting to light, sir.
Any proptosis, pulsation, palpation?
Sir, there was only lid edema, sir, no proptosis as such. And pulsation, there was no pulsation, sir, at the time of examination when we did.
Okay. So means these kind of cases, they require multidisciplinary approach to treat. And
Yes, sir.
it's the great result you achieved in this case. So congratulations. Yeah.
Thank you, sir.
Any other take home, Dr. Moria? We still have a minute. Is there anything else you'd like to discuss with everyone attending in cases like this? If they were to present a case like this, what would help them score more? I think that would be a very useful point for a minute.
Yeah, so examination is a must. So all these 6P that I'm talking about, any orbit, any means injury around the orbit, so you need to ask for the pain, progression, right? And then pulsation, palpation, that we need to, periocular changes. What are the periocular changes? And now the 7P has been added. That is the any previous such kind of history that has also been added. And which investigation modalities to be done is such kind of cases. So you rightly said MRI must not be done. That will aggravate further the injury, right? And so we need to be careful which investigation modalities to go for. And then multi-prong approach to manage surgical approach in such kind of cases.
Yes.
Fantastic. Thank you very much and
Thank
well
you,
done,
sir.
Dr. Sarah Wong.
Thank you, sir.
Well
Yeah.
done.
One point I would like to just say
Sure.
is that usually the foreign body which lodges, they are projectile. Here the head was projectile and that dense key went in. So that is why we wanted to present this case.
Very, very interesting.
Thank
Hats off
you.
to you,
Thank you.
ma'am. It was such a
Yeah.
unique case and you managed.
Yes, and the patient was tad lucky that the optic nerve was missed by just 2 mm. So
Oh,
this was very interesting with
yeah.
no residual damage. Thank you.
Yeah.
Thank you, sir.
Thank you, sir.
Thank you. We can now move to the next case.
We will now hear from Dr. Kea Sahani, who is mentored by Dr. Manjari Natu. Dr. Kea, please take the stage.
I think you're muted. You want to unmute yourself, please, and start again. We will start the timer at your beginning again. Thank you. Start again, Beta.
You're still muted, Dr. Kea.
We are still unable to hear you.
Good morning, I'm Dr. Kea Shahani, presenting Honey, I Stung the Corneas, a case of bee sting endothelitis. A 55-year-old male was brought in a semi-conscious state with multiple swellings all over his body. His relatives gave a history of him being attacked by a swarm of bees. Initial resuscitative measures were taken and ophthalmic evaluation was done. In his right eye, he had a vision of finger counting up to 3 meters. There were multiple bee stingers embedded in his lids and his conjunctiva. In his right eye, he also had a PCIOL, rest was within normal limits. In his left eye, he has a vision of finger counting up to 1 meter, lid edema. There was ovipistus, that is stingers embedded in his conjunctiva and in his lids. In his cornea, he had dense stromal edema, DM folds, and epi defect, and 4 ovipisters embedded in the limbus around 4 o'clock position. In his left eye, he also had a fully dilated pupil that was not reacting to light. He had a dense cataract that was hazily seen. The stingers were removed from the lids as well as from the conjunctiva using forceps, and special care had to be taken while removing the stingers from the limbus in order to avoid retention. He was started on antibiotics, lubricating eye drops, iotim eye drops, and D-panthenol ophthalmic gel. After 8 days, the epidefect healed completely, and he was started on 1% red acetate eye drops 8 times a day, tapered over 10 days. You can see the OCT, B scan, and the clinical picture shown over here. The result. Unfortunately, there was very little decrease in the corneal edema and the vision remained the same. After 8 days, he was started on oral steroids, that is oral prednisolone tapering. The right eye significantly improved. Unfortunately, even after oral steroids, there was very little improvement in the corneal edema and the vision remained the same. He was discharged and referred to a senior cornea specialist who started ripasudal eye drops. Interestingly, there was a decrease in the corneal edema and clinical picture. However, there was little to no improvement in his vision because of a now appreciated dense cataract. Oh, sorry. The patient was advised cataract surgery after 1 month, and there was a significant improvement as seen over here. This case sparked interest among all of my colleagues, and in the department, we discussed several questions that came to mind. Some of these are shown over here. Now, how common are ocular bee stings? A review of literature has identified 36 previous publications with 57 reported cases. 51 were corneal and 6 conjunctival. There are no clear guidelines for the management, and every case is different. Is it safe to remove the stingers? Because of the orientation of these lancets, some part of the stinger might be retained in the cornea, causing further inflammation. There's a controversy regarding the removal of the stinger. Some authors describe retention of the stinger as manipulation may cause severe inflammatory reaction. A previously published case by Gilboa et al. Showed the stinger left in place for 28 years. Vischer et al. Stated that the bee stinger should be removed as quickly as possible, as delayed removal causes increase in the dose of venom. Goodiseva et al. Stated that 40% of the cases in which the stinger was retained were all right. Now, how does the bee sting cause endothelitis? There are mechanical, toxic, and immunological factors that come into play. There are amines, histamine, and dopamine that cause toxic effects. What other toxic effects can we anticipate? Melatonin causes membrane disruption, loss of erythrocyte structure, leading to cataract and zonular lysis. Apamine causes NMJ block, causing internal ophthalmoplegia, pupillary dilation, and optic neuropathy. Histamine can cause the toxic effects of chemosis. Now, why did ripasudal make a difference? The mechanism of action of topical ripasudal includes suppression of angiogenesis. It also inhibits inflammatory cells and blocks their attachment on the site of the endothelium, preventing cell adhesion, migration, and hence decreases the edema. Thank you. And these are my references.
Thank you, Dr. Kea. We now invite Dr. Gitika Srivastav and Dr. Surbhi Dutt for the discussion. Doctors, the floor is yours.
Yeah, very nice presentation. Dr. Kea, can you please tell me what is the reason for zonodialysis if you get in any patient?
Zonodialysis is caused because of the toxic effects of the apamine, which sort of
It's proteolytic.
hello.
Yes, we can hear you. Please go ahead.
Yes, ma'am. It's a, sorry, I'm not sure.
So basically it is a proteolytic enzyme. It causes protein lysis, and that leads to damage of the zonules and zonular dialysis.
Okay. Did you get any cataract formation in this case of BSC endothelitis?
We did have cataract formation, but later appreciated once the edema decreased.
So which type of cataract can be there?
More commonly, there'll be an anterior subcapsular cataract.
Right. And because of?
Because of the reaction in the anterior chamber and direct injury to the cornea.
Right. Okay. Fine. What is the management for this case? Suppose a patient is coming to you with these things.
Tanvi, please, when this discussing is finished, please say over to you for your questions.
Sorry?
Hello?
Hello? Yes, ma'am.
So,
Initially, we had to research the patient, and later on, because there was an epithelial defect, we did not immediately start prednisolone. We started with lubricating antibiotics and lubricating eye drops, basically. Once the epithelial defect healed, we wanted to start aggressively steroids, topical steroids. Once that did not work, we wanted to start oral steroids, which still did not work. Finally, we also started ripasudal eye drops.
So is there any chance for endophthalmitis in this case?
Yes, there is a chance of endophthalmitis because of the toxins released. There was dense stromal edema, and we were actually very worried that the patient will go into endophthalmitis.
Okay, fine.
We did a B scan and...
Right, okay. Dr. Surbhi.
Over
Thank
to you,
you.
Dr. Surbhi, for the discussion.
Here are two questions. When the patient had come, did you do a complete staining? I mean, that the first initial check which was done, did you see the surface as a whole, the ocular surface?
Yes, ma'am, we did.
And how was the health of that? Was that affected?
The cornea, of course, there was a huge epithelial defect.
Yeah, that's fine.
The fingers were present in the conjunctiva as well as the cornea. It was stain positive, but
Okay, so the
not
conjunctival area,
Yes.
conjunctival area, the bulbar was affected, right?
Yes.
Yeah, so in cases of, these kind of toxins which are released, the primary role is of topical steroids. I understand you have a epi defect which is there, but you can start a mild low dose steroid which should be started and kept on a close follow-up. Second thing, why wasn't oral steroid started on the first day itself?
Initially, we wanted to start off with topical steroid to see if it works. We started it aggressively. It was every hour for 8 days.
No. You told me that you did not start topical steroids in the starting, right?
Oh,
You
yes,
waited for the 3 days after the
Yes.
epi was on, and then you started the topical steroids. But initially, why oral steroids? Was the patient had any high risk or anything?
The patient was already admitted in the ICU.
Okay.
Although after the first day, he was stable. We were avoiding anything systemic initially.
Okay. The second question of mine, do you know or have you read about the difference between a sting of a wasp and the sting of a bee? What is the difference?
The sting of a wasp and a bee has similar effects, actually.
There is a difference between the two. Are you aware of that? Have you seen the articles or anything of that?
Case study on both of them that stated it was similar. I'm not sure of the name right now. I can.
Okay. So just to brief the whole, the meat and to get a good one, the sting of a wasp is not as toxic as the sting of a bee. But a bee sting, once it's done, even the bee actually does not have its sting. So it actually perishes. But a wasp can repeatedly sting a person. Okay. The second point, the wasp sting does not lead to such severe complications like endophthalmitis. It is the bee sting because it has a very strong penetration. And it's not just the penetration, it is the toxins which are actually there. That whole slide you showed, right? Melittin, the epamides and all that, that is more in the bee rather than the wasp. So even if a patient has only on the lids, we would prefer to start oral steroids, even if the cornea or the eye is not involved internally, because systemically it will keep on happening. So we want to settle it down.
That's a brilliant point.
Thank you.
Are we done with your discussion? Because Dr. Moria would like to add a few words. Thank
Yeah,
you.
so-
Excellent discussion. Here, over to you, Dr. Moria.
Yeah, so I got to remember the famous quote by Muhammad Ali, fly like a butterfly and sting like a bee. So there are 32 Rho kinase inhibitors. So this ripasudil, we did a head-to-head clinical trial, me and Dr. Samar Basak. It has no role in reducing the corneal edema and inflammation. The only Rho kinase inhibitor that has role in reducing the corneal edema as well as in the corneal endothelial regeneration and reducing the inflammation is the molecule Y27362. Right. So ripasudil is just acting like a placebo. Thank you.
Yes, yes.
Thank you.
I agree to that, sir.
So with this, we end this case. Then we over to you for the next presentation. Thank you very much, discussants. Thank you.
We next have Dr. Anisha Wagh from Pravra Loni, mentored by Dr. Shubhangi Nigvekar. Dr. Anisha, we invite you to please present your case.
Good morning, everyone. I'm Dr. Anisha Wagh, and I'm a second-year resident at Pravra Institute of Medical Sciences. Today, I will be presenting a case on the surgical management of sebaceous gland carcinoma, a novel technique, under the guidance of Dr. Shubhangi Nigvekar ma'am and Akshay Bhandari sir. So, a 69-year-old male, farmer by occupation and resident of Gunjurwadi, presented to our outpatient department with the chief complaint of a recurrent mass on the left upper eyelid since 6 months. The mass was painless and gradually increased in size. The patient denied any history of recurrent swellings at any other site on the eyelids, chronic redness or foreign body sensation, or exposure to radiation in the past. The patient did give a history of a similar lesion at the same site 2 years ago, for which he had undergone a surgery, but the details were not available and no further treatment was taken for the same. There was no other significant medical or surgical history. Family and personal history was not significant. General examination and vitals were normal. There was no pallor, icterus, clubbing, cyanosis, edema, or lymphadenopathy, and we specially palpated for the preauricular and the submandibular lymph nodes. Systemic examination was also within normal limits, with special attention being paid to the examination of the respiratory system and the per-abdominal examination. Head posture, facial symmetry, and ocular position was normal, and extraocular movements were full, free, and painless in all directions of gaze in both the eyes. The best corrected visual acuity with myopic correction was 624 in the right eye and 618 in the left eye. Intraocular pressure on GAT was 14 and 17 millimeters of mercury in the right and left eye respectively. The eyelids of the right eye were normal, while the left upper eyelid showed a mass measuring 1 by 0.5 centimeters on the lateral aspect, and it involved both the anterior and posterior lid margins. There was a distortion and loss of cilia noted, and the conjunctival side showed a cauliflower-like lesion with yellowish deposits. There was no ulceration or telangiectatic vessels seen. On palpation, the mass was firm, non-tender, with ill-defined margins, and the overlying skin was freely mobile. The medial part of the upper eyelid was normal, and the lower eyelid was also normal. The adjacent conjunctiva in the left eye was normal, and the rest of the anterior segment and fundus findings in both eyes were normal. Based on the patient's age, presentation, and clinical findings, a provisional diagnosis of sebaceous gland carcinoma was made. The patient was subjected to routine blood investigations like the CBC, LFT, RFT, and urine routine microscopy. We also did a chest X-ray and a USG of the abdomen and pelvis, which were all normal. The patient then underwent a biopsy, which histopathologically confirmed the diagnosis of a sebaceous gland carcinoma of the left upper eyelid. The patient then underwent a full thickness wide local excision with 4 millimeter margins, and the upper eyelid was reconstructed using the ipsilateral conchal cartilage as well as ear skin graft in the same sitting. As we can see here, the area to be excised was marked out, leaving a 4 millimeter margin. The excised tissue was sent for an intraoperative frozen section, which confirmed the tumor-free margins. The eyelid defect was measured. The same sized conchal cartilage graft and a 10% larger ear skin graft was harvested from behind the same side ear with the help of our ENT surgeon. The orbicularis muscle was then sandwiched between the two grafts and they were sutured in place. As we can see here, these are our patient's results on post-operative day 1, which showed that the patient had a good structural and functional outcome. We are yet to follow up the patient to know the long-term effects of our surgery. Those were my references. Thank you.
That's an excellent presentation.
Thank you, ma'am.
Dr. Rajendra Kaur, we now invite you for the discussion.
Dr. Anisha, very nice presentation and
Thank you,
documentation.
ma'am.
So, in your case, what were the factors which led to that you should suspect sebaceous gland carcinoma?
Ma'am, so the patient came with a history. First thing that caught our attention was the specific history that he had a similar lesion at the same site earlier. But some surgery was done, but details he was not sure of. On examination, also we noted that on the conjunctival side, it had a cauliflower-like lesion with yellow deposits. There was characteristically a loss of cilia over the lesion. And also, ma'am, both the lid margins were involved, which is what got us, and it was the upper lid. So all of that pointed more towards sebaceous gland carcinoma. The patient was also in his mid 60, 69-year-old. So the age was also corresponding to one where we should suspect sebaceous gland carcinoma.
So, what are the differential diagnoses when you should suspect that is sebaceous gland carcinoma? Do you have any differential diagnosis, the recurrent lesions?
Ma'am, first and foremost, what comes to mind would be a recurrent chalazion. But in that case, ma'am, the patient it would be a painful lesion. As against here, the patient, it was painless and non-tender. The history of a surgery in the past did get us to consider that initially, but the loss of cilia and the yellowish deposits went against it. Ma'am, in addition to that, if there was inflammation and it's unilateral, we could suspect a blepharitis-like picture, blepharoconjunctivitis. Ma'am, and of course, we can't rule out other common malignancies like a basal cell or a sebaceous or squamous cell carcinoma also. But again, the characteristic features of that, such as the basal cell carcinoma being more common on the lower lid, with rolled out margins, ulceration, and it being a rodent superficial ulcer. Ma'am, those features were not seen in this. And ma'am, in squamous cell, the keratinization was also not present, but we did consider all of those.
Why it is more common on the upper lid?
Ma'am, the most common origin for sebaceous gland carcinoma is the meibomian glands, and they are much more in number in the upper lid as compared to the lower lid. So that is why it's more common in the upper lid. Other than that, it could also arise from the glands of Zeiss and very rarely from the glands of the caruncle also.
Okay. So is there any role of radiotherapy also?
Ma'am, so radiation therapy, the articles I read, we would strongly consider, especially if there was any conjunctival involvement or if there was lymph node metastasis. Ma'am, in our patient, we had examined the lymph nodes clinically and we did not find any involvement of the lymph nodes. So we did not consider this patient for radiotherapy. But of course, if surgery is also not an option, if it's a very advanced stage of sebaceous gland carcinoma, where one would consider excision or even that would not be possible, then of course radiation and chemotherapy should be considered.
So which investigation is done usually to confirm the diagnosis? Incisional biopsy or excisional biopsy? And what is the difference between these two?
Ma'am, we can do an incisional biopsy also, but I think best if you're clinically quite confident, it's better to do a clearing of the margins and a full excision of the mass. And histopath will confirm our diagnosis. As we can see that there'll be multilobulated structures with the cells showing vacuolated cytoplasm and hyperchromatic nuclei with pleomorphism. Ma'am, I think personally, I think excision biopsy is a good option because it removes the scare also of handling a tumor is always a dicey situation.
Great. Thank you. That's all from my side.
Thank you, ma'am.
Dr. Suvira, you can continue. That is all from my side.
Hi. So we have a few minutes more. I'd like to request Dr. Arvind Kumar Moria to give all the students a few tips over the next 3-4 minutes on how they can excel and do even better in their presentations during the exams. Thank you, Dr. Arvind.
Yeah, so all the presentations were really good. But whenever you are making a presentation, so the font size and the background and the brightness that needs to be taken care well, right? And when you are presenting, so one of the speaker, we were not able to see her, right? So your headshot means the passport size headshot that needs to be visible. That shows confidence. So you need to tilt accordingly the laptop screen according to that. The font size minimum, I think 18 to 20. 20 is better. And then it must not be bright, very bright. That creates a lot of problem. And not to repeat the caps, all the letters in caps. That also creates confusion for the audience as well as for the judges. And to more the algorithms are there, right? So that you need to keep it, how to manage such kind of a case, because that simplifies the whole paraphernalia. So that helps in understanding your whole thing. Right. Images, good quality images, good quality videos that adds value to your presentation. And you all were really great. So you all are winner from my side. Now coming to that AI based, the study that we had done first time in world, that was the first AI based, that portable smartphone based offline annotating the 15 means ocular biomarkers in posterior segment. That was done first by our team, a very big team of 52 people, and it got published in clinical ophthalmology also. And now we are working on this handheld, means just like Remedio, it's better than Remedio, with a chin rest. So, and much lighter and much flexible, and there is S technology. So it's, even if it is offline, even if a nursing officers or an optometrist is working on it, so they can diagnose means any diabetic retinopathy or glaucoma is there, and which cases to send them for referral at higher centers. So this we are doing with the help of Ministry of Information and Technology under the Government of India program, that is Netra Antyodaya. And I'm happy to take any questions from all the students.
Are there any questions for Dr. Arvind Moria regarding this topic? Do any of the students wish to clarify and to understand a little bit more? Please speak now.
Or you can want to be part of our study, most welcome.
I would. Thank you.
Yeah, we will and all, because I will be heading the whole India, so I need multi-centers. So most welcome, most welcome.
Thank you. Thank you.
Same
Thank you,
here.
Dr. Moria.
All the cases were very good and they were managed very appropriately. So that makes the session very interesting.
Thank you. Thank you, ma'am. Thank you for being part of it. And thank you, all the judges, for your most invaluable insights. They'll help the students go a long way. Tanvi, over to you.
Thank you. Thank you.
We now have a talk on Project Shakti by Dr. Jimmy Mittal. Dr. Jimmy Mittal is a senior consultant and head of Department of Ophthalmology at the Vivekanand Hospital in Lucknow. She has pursued advanced training along with IOL glaucoma training along with IOL training at Arvind Eye Hospital, Madurai, and has been actively involved in academia, teaching DNB and optometry students, and also co-guiding various theses and presentations. Dr. Mittal is also the secretary of the Awadh chapter of the Women Ophthalmic Society and the joint secretary of the Lucknow Ophthalmic Society. Dr. Mittal will now give us a talk on Project Shakti. Dr. Mittal, the floor is yours.
Yeah, so good morning, everyone. Am I audible?
Yes, ma'am.
Okay, good morning, everyone. So at the outside, I would like to thank Suvira ma'am, Mohita ma'am, and of course, Dr. Shweta for organizing this kind of, very interactive session for residents as well as all of us. So I'll share my screen first and then we'll start.
After the Dr. How can I be? Call her.
Is my screen visible to everyone?
Currently, I can see you, not your screen. So would you please mind sharing it?
You are visible, ma'am.
My screen is not visible.
The screen is not visible. We can see you, but not your.
Okay, I'll just check.
I call again. So give me Sharmishta's lecture. Write up on me. अभी मैं क्या बोल रही हूँ बोलूं को? Yeah, that seems to be working well. Thank you.
I hope now my screen is visible. Is my screen visible to everyone now?
Yes, ma'am, it is. Please continue.
Okay.
Yes, yes.
So I would like to thank once again for organizing this meeting. And I'm here to talk about a very important ongoing project of WOS, which is Project Shakti. So it deals with the identification of workplace harassment and workplace challenges and how to go about it. So yes, workplace harassment and challenges do exist throughout all types of workplaces. From simple bullying to outright discrimination, it's important to understand that yes, workplace harassment is there and you can deal with it and you can avoid a hostile work environment and have a comfortable and a safe environment to work. So how does harassment affect an individual? It not only affects an employee's productivity at work, her comfort level at work, and safety at work, it also has some long-term effects in the form of physical and psychological effects, health effects, and financial effects not to miss. It is important to understand that it can expose an organization to legal liability if the organization is not able to handle any harassment complaint made to it properly. So what are the types of harassment or challenges which we can face at our workplace? Well, the most basic types of harassment are the verbal, the psychological, and emotional trauma. There are also some very serious forms such as physical and sexual abuse or harassment. So we should remember that any type of workplace harassment is illegal in nature and it should be reported ASAP. So this is a major scenario showing various kinds of harassments. First of all, we'll talk about like sexual harassment, which is actually we are fighting for it since the past few weeks. Cases are coming to us very, now more frequently. Other types of harassment which a person can face is in the form of psychological harassment, third-party harassment, discriminatory harassment amongst your colleagues, personal level harassment, physical harassment, power harassment by your superiors or your seniors, and cyberbullying also comes under it. So what constitutes workplace harassment? Now, according to the Equal Employment Opportunity Commission, harassment can include offensive jokes made at you, slurs, epithets or name calling, physical assaults or threats, intimidation, ridicule or mockery, insults or put downs by your colleagues or your seniors, offensive objects or pictures shown to you at your workplace. Anything which is actually interfering with your workplace performance is actually harassment or challenge for you. So why reporting workplace harassment is important for you? Now, you should understand that it is important to report any kind of workplace challenge which you are facing because there are chances that there might have been others who have already reported similar offenses by the same person or the group of people in your institution. He might be a repeated offender. So your complaint will only strengthen the previous complaints. So many organizations have formal policies for reporting workplace harassment. And whenever you're getting employed at a new place, please make sure to check your employee handbook and ask your HR department as to how to go about in such a scenario if it arises in your workplace. So it's time to speak up not only for yourself, but also for others in your institution who are actually facing such kind of a problem. Now, Garvin, who is a social activist, has rightly said, if you know someone who is being harassed at work, you cannot simply lose your job by reporting it yourself. Not only you are protected by law from the person who's harassing you, but you're also protected from your employer by failing to protect you. So it's a moral obligation of the employer to protect you at the workplace. Your legal liability is there. So he cannot just refuse ki it's not my responsibility. So what should you do if you feel harassed? Now, we should understand that workplace harassment is a very serious issue with a lot of gray areas. So we need to tread very carefully. So if you witness a crime or experience harassment in the workplace, it is a moral obligation to report it. If you're worried about losing your job in retaliation, remember that you're always protected by workplace harassment laws. So there should be proactive steps taken to identify and prevent workplace harassment. Companies, hospitals, and institutions should have a person of contact who is easily approachable so that victims or witnesses can approach to him and share their problems, just maintaining the confidentiality and anonymity in place. So how to report workplace challenges or harassment? First of all, you need to decide to speak up for yourself. You need to take up the issue with your family members, discuss freely with your family members, your mentors at work, your professional seniors, your senior ophthalmologists. And if the matter is a very serious one, you can also approach a lawyer or a psychologist. Now, be firm and very specific with your approach. Now remember, sometimes you are the employer, and an employee might just walk to you and say about some unprofessional conduct or inappropriate behavior. So please ask your employee to describe the conduct more specifically in a detailed fashion. Keep detailed records of every indiscretion which has happened to you. For example, the people who were involved in your harassment, what was said or done to you, where and when the abuse had occurred. Document each incident in detail to bring it on record later. The date, the time, and the place of the harassment should be preferably done through emails or written applications. This is important because in the court of law, written evidence has much more value, and oral or verbal communication or complaint has no value at all. So you should keep your documented details in written form. It is important to understand. Then share your problems with authorities. You can send them multiple mails, your colleagues, the HR of your hospital, and Vishaka committee, which is very, very mandatory in all the private and in government setups. And now you have WOS for all of you. Evaluate your workplace policies at least once in a year to ensure they're up to mark in case such a situation arises. This was what to do. Now, what you should avoid when facing a workplace challenge. First of all, you should not retaliate or, speak back in anger or shout back at the person. Retaliation can escalate the issue and will often make the matters more complicated. For example, if he's your senior and you start shouting or misbehaving with him, he can just say that you were being, very indisciplined. So instead, you should escalate the issue very properly through a proper channel and let your HR professionals handle things from there on. Secondly, do not complain to your co-workers and co-colleagues because your colleagues are sailing in the same boat. They do not have much power to change anything in the scenario and will likely to water down your version of events if they're asked to testify against the senior or a other member who is doing it. And last but the most important one, do not keep quiet and suffer in silence. You have to decide and speak up for yourself. And there are many harassment incidents which should be, they go unnoticed because people don't want to speak up for themselves. So we have for you Project Shakti, which has an important expert panel committee which incorporates panel of senior female ophthalmologists and male ophthalmologists, a lawyer, a human rights activist, and a member of the National Women Commission on board. And we also have a psychologist on board. So what do we do when we receive a complaint at our email ID? We actually take the complaint very seriously and investigate every complaint in an unbiased fashion. We share and discuss the situation with our expert panelists, maintaining the confidentiality, sensitivity, and even the anonymity of the person is maintained. We should not, the person who's making the complaint should not be very sensitive about the issue. We try not to make any credibility judgments based on the reputation of the person complaining or the person accused of harassment. We'll not assume that the person making the complaint is being oversensitive or over-emotional, and we'll not leave it to both the parties to work it out. We'll actually intervene in a way. And once the complaint has been verified by our expert panel and found to be genuine, we'll take up the issue with the concerned hospital or the institutional authority, requesting for a formal inquiry to be done and required action against the harasser. We'll also decide if any psychological, legal, or professional help is required in the matter. And if yes, we'll help the person connect with the one required. So WOS encourages a zero tolerance harassment policy at every workplace. Now, why is it important? Because an anti-harassment policy, if it is there, it will be a deterrent to future such issues. It will outline the methods of use when such a scenario arises. It will raise awareness of your intolerance towards such behavior. It prevents legal liability and also strengthens your complaint once we have a policy in place. So remember, yes, we all deserve a very, very important and a very important safe workplace. So please feel free to report any workplace harassment challenge which you are facing at iwosindia@gmail.com. So we at WOS are here for you, and together we can and we will make a difference. Thank you very much for your patient hearing. And I was just wanting to, take a lot of questions because we are having such a ongoing burning topic and the events which are going on in the entire country, and we are having a lot of protests. So this was all about that. And so Dr. Suvira and all the experts here would comment on that, and we can discuss about it for a few minutes so that it becomes more important for everyone.
Yeah, absolutely. I think one of the biggest challenges I feel at a very basic level is as students or as women, ophthalmologists, I can speak for, practicing doctors, there is always a fear to speak up. There's always a fear कि ठीक है शायद ये चला जाएगा शायद मैंने I have understood it wrong. People maybe will try to just keep things under the carpet just for want of bringing it up. And most importantly, for the fear of bringing it up. What are going to be the consequences if I speak up and say that my senior because generally the bullies are to be either seniors or other staff that have been there a lot longer than the students. And there's such a great fear. So, Jimmy, ma'am, I'd like to ask you that, how could you encourage the students attending this program at the Maharashtra and at the all India level, that how should they be fearless and know that when they come up with a complaint like that, they are going to be in a safe space. They have nothing to fear from their seniors or anyone else from which towards which they may want to lodge some kind of complaint, that because there's so much of anxiety we hear of suicides, and now of course there's this burning case which I'd like you to dilate upon after answering this question. We still have another 9 minutes for your session. Thank you.
Sure, ma'am. Thank you so much for the important question, because even I have residents working at my institution. So first of all, we as seniors are seniors, and if we think about our scenario when we were residents, we had a great gap between our senior professors and everything, and we were not able to communicate with them very clearly and very openly. So I would request all the residents to have a good rapport with your, HODs or your female senior ophthalmologists who are easily approachable. And we as senior, you can say HODs or professors, can actually call them once in a while and ask them about their well-being. Ask them to, we can break the ice so that they are comfortable, they're in a comfortable zone when they come to you, and they can share even the things which they might be in their hearts and they're not able to speak up. So the onus lies on us also as seniors, that we break that ice and we make them in a comfortable space, that yes, we are there for you. Apart from academics, we're also there for you as a guardian. We are not.
I think it's a very, very important point, because students to bolne ko tayar bhi honge, but how are we as seniors,
Exactly. Because ma'am,
completely
our generation, luckily, all of us who are in our, at our position right now, we are more open to hearing them. And we have a better, we try to understand what I have felt from all these sessions, which I have been doing since past 4-5 months, that residents are now opening up because we are ready to listen. It's not that they have a lot of things to say, but previously, even today, if I call up my professor, I cannot talk to her very freely. That's a very, I still have my reservations. What will ma'am say if I share about my family problem? What will she say if I say कि मुझे समझ में नहीं आ रहा, मैं क्या करूं? I have a professional threat. So now the things should change from us changing for them. And definitely, कोई भी चीज एक दिन में नहीं होती है, मैम. It happens over a period of months and weeks. And the female needs to understand, or any person needs to understand the behavior of a person towards her or him. कि ये behavior है, normal तो नहीं है. If somebody is making some kind of, approaches towards you, you can just very first instance without fear say कि ये, sir, I am not comfortable in this kind of this rapport. I can't, you just have to say no in the very first instance. You can't wait for it to pile on. Because first time, if you can't say no, then the person gets this thing कि नहीं, ये इसके साथ में कुछ भी हो सकता है, right? She is vulnerable. So
so establishing boundaries as a student also. We have to be able to posture ourselves, even as students, to be able to say that this didn't seem okay.
Ma'am, you can be very, very firm and be very polite.
Ma'am, can I add a small point?
Please, that would be lovely.
Actually, if I go back and, think of my days and think of the colleges and think of all the professors, think of us as a team of, juniors and seniors, people training.
Yeah.
I'm always feeling every specialty, we have this fear and we have a lot of turmoil. It's not just an ophthalm I'm talking about. I'm just talking about a general medical college.
Yeah.
And I feel personally that we could start with something as basic as having a counseling session for the doctors, the upcoming, budding doctors, because it goes a long way. The mental agony a child goes through.
We are actually
their parents, they've gone to college. And there's a lot of turmoil which happens. We never had that. But I feel seeing what's happening in this scenario of times of our, changing trends and the things that they're going through, is a lot more emphasis on mental health. And I think a counselor will go a long way. which a doctor does not even think about. They just think of psychologists, think of patients, ki patients ka karna hai, patients ka treatment dena hai. What about the health of the doctors, the upcoming people? Where does that go? Person
Yes.
can come and face you, person can share it with you. But what happens with the
It's not
peers?
closing.
They actually joke about it कि तुझे तो problem हो रही है, कुछ ऐसा है नहीं, ये है. All these things come cropped up. So if you have a session, then all the people in that fraternity understand that this is happening, and it's not wrong for a person to approach. That's very important.
Yeah, because even even mine is an academic institution. So what we have planned with our management is that when we are inducting a new batch of DNBs, we are now planning to have a session of, they need to know each other, they need to know us, and we'll give an induction batch, just a touch about what is good touch, bad touch in that scenario in a medical fraternity, and counsel them that yes, you have a Vishaka committee in your institution, you have a proper female, you can say a group, a help group whom you can approach if you face any kind of problem. It is only not only for females but for male doctors also. They also have problems. They also have, they are not very open about it, but we have seen
Absolutely.
people suffering in silence. Even the male doctor residents also face. But the problem is they have the stigma of being a male ki main kisse bolu.
That's your hospital, man.
Yeah.
But I
We
feel
need to start take care of from our own home, right?
Exactly.
Our own institute.
Yeah,
Right.
that's what I
being,
said.
being,
one
being
individually
senior,
has to do it.
being senior, we need to have good ears, empathetic towards the residents, the juniors. So this one thing I would like to share with you that is what happening at my institute. So there are 3 units,
Okay.
right? And in my unit, they are exposed to means good clinical OPD and surgical exposure. But I talk to all the residents in the evening. We have an informal meet for 10 to 15 minutes every day. So I asked them how many OPDs you have seen, how many surgeries you have done. No. And they answered that we are not getting much surgical exposure. So I'm telling those unit head, I'm requesting them, I'm telling them being head that kindly give them surgical exposure, but still they are not doing it. Then I told my residents that you can come forward, you can give me in writing, then I can work in a much robust fashion for your, in that way I can help you more. But they are not willing to come up. I think why they are into their shell, they are not able to speak up for their rights.
Sir, for generations, students have not had the courage to speak.
So we have
There's
not been
such a
taught like that. We have
deep-seated,
been
yeah.
taught to just listen and you can say yes sir, yes ma'am. We have not been taught to, say and what you're feeling. We just need to break the ice. That's what I said.
Yeah.
Be
And
obedient.
even a single question in if you meet your resident and say kaise ho, how did your day go, anything, sab theek chal raha hai ki nahi, that very sentence itself agar kuch hoga, they open up. That's what I do with my residents.
Okay, it's going to be Mohita Sharma. What is her topic
So
called?
that
Somebody
is one
give
thing
me.
which we should, let our juniors express. Sometimes
yeah,
not about academics. We have to go beyond academics to have this kind of a success story. And we have
we
to.
must know a little bit about each one of our residents,
Sir, unfortunately, even our generation doesn't know that Vishaka committee is a mandatory committee in every institution, be it private or government. So किसी को
Yes.
पता ही नहीं है कि विशाखा
Yeah,
के
they
क्या
don't
करती
know. I told my residents that when they were on a strike recently, that you need to means these salient points from the Vishaka committee, and then they were asking me, sir, can you narrate those points? मैंने कहा, that's very unfortunate.
So
that,
in this upcoming annual WOS, we will be having an entire session on Vishaka and Project Shakti. It will be telling about the guidelines. We'll have a boardroom meeting.
Dr. Suvira, I would request you to please share that link and day and
The email ID
so that I
also.
can share with my residents.
Sure,
Yeah.
that'd be really nice. Thank you.
Even the email ID, Dr. Suvira.
Yes,
Which ma'am shared at the end.
yes. At the end, we'll share all of this so
Yes.
that people can spread it around, that where all they can get their
It's a burning
access
thing.
to.
Yeah.
It's a very
Thank
big
you.
one. It's a very
Yeah,
big
yeah.
one. Thank you so
Yes,
much
thank
for your
you.
most inspiring talk. Thank
Thank you,
you.
ma'am.
Thank you very much.
Thank you so much.
And we're just going to have a slight change in the program now. I'd like to, with all my heart, soul, and every soul of my being, like to invite Dr. Mohita Sharma now, next, who's the brainchild of WOS and who's been the leading force in guiding us all in taking all our issues as female ophthalmologists ahead. I'd like to invite Dr. Mohita Sharma, who's going to talk to us about WOS and the way forward. Dr. Mohita, over to you.
Good morning, Dr. Mohita.
Dr. Moria, you can speak to us for a few more minutes. Dr. Mohita is about to join.
Okay, regarding these, it's a very pertinent topic to discuss. So what is happening, even regarding the safety of the male residents also. The patient attendants, they are so aggressive. So means we need to streamline the whole system. Right. So the CCTV installation along with audio also means enhance the number of female security guards 24/7.
Exactly.
And who knows the SOP, who knows the drill. If such kind of things are happening, what they need to do. Right. And they must be well equipped. If in the European medical colleges, if in the American medical colleges, if in the Singaporean medical colleges, the security guards have these kind of spray. They have that stick. They have this electric shock guns. So why not?
Which they have, tasers and
Yeah, why
sprays
not
and-
this Indian security guards can be equipped like that? Right. So all these things, and then well lit means the corridors, galleries, and the separate means the restrooms for the female residents, for the female staff. Right. So that is a must, I feel. It is missing in a lot of medical college. I visit them as a NMC inspector. So that is missing in most of the medical college. Sorry to say, it's very unfortunate. And when during the emergencies, when the residents are called, so only the ambulance goes there, not along with the security staff. So when any female resident has been called for any emergency duty, then minimum 2 security female guards must accompany her, and then again to drop that female resident. I think these kind of small things we can start initiating from our own institute, and we can work. Means we can all go ahead in the right direction.
Exactly, sir. Very, very true. Very true.
Where is it? All right. We have Dr. Mohita Sharma with us here. I've already given you a grand introduction. The brainchild behind WOS, the one who holds our hand and leads the entire country and all the women ophthalmologists ahead, is going to now speak to us on WOS, where we are, and the way forward. Welcome, Dr. Mohita.
Good morning, Dr. Mohita.
Good morning, ma'am.
Let's just give it a couple of minutes. I think ma'am's just joining. Jimmy, till then in the chat, would you like to add the email ID where we can all contact you?
I'll do that, ma'am. I'll just do it. Yeah.
Dr. Mohita, thank you. Ma'am, are you muted? We can't hear you.
Good morning. Good morning, everybody. Can you hear me now, Suvira?
All good. Thank you very much.
Good morning, Dr. Mohita.
Good morning. Good morning,
morning,
Dr.
ma'am.
Arvind. Good morning, Jimmy. Nice to see everybody on a Sunday morning. And thank you, Suvira, for putting this webinar together. And thank you, Dr. Shweta, for supporting always for any of the resident activities. So, so welcome everybody to this webinar. And I will just take you through a short journey about Women Ophthalmologists Society. Most of you are now familiar with Women Ophthalmologists Society and its activities, but every year we try to keep on adding new things and we keep on changing our focus depending upon what is the need of the hour. And I think Dr. Jimmy, you have already talked about your project, Shakti. So that's the current need of the hour, and Dr. Jimmy is activated fully with Project Shakti. to empower each one of us. So there are already a few things that WOS is working on, but as and when we come across different situations and what our members need, we keep changing accordingly. So whenever we talk of women, we talk about something called glass ceiling. So I tried to look in today morning itself as to what this glass ceiling means, because everybody talks of only two things: work-life balance and glass ceiling. And since we have the young crowd here, we want you to introduce to you to some of these concepts which will soon come into your life. You may not be so much aware about them, or you may be tending to think this is not for me, but this is something which is inevitable. It has to come, and so we have to get over this barrier. So whatever pictures I looked into for this glass ceiling, I found that below the glass ceiling, I always found majority were women, or there were only women, and above the glass ceiling, I found that there were men. So as a metaphor, our internet is talking about glass ceiling as something which is for women, and this is something which they have to break. And so the question is, does this glass ceiling actually exist? And the answer is yes, it exists. And breaking this glass ceiling is not difficult at all if we are all in it together. We all know that we all have universal professional challenges, and this is because of the leaky pipeline. At this stage, when we are residents, we are all doing well and we are all equal. But as we go further in our path, we realize that there are certain inevitable breaks because of which challenges come, and we go two steps backwards in our career. And today, when we say that majority of the residents are females, we also realize that even if majority are residents, even if it was 100% women as residents, the challenges remain the same, and challenges don't change, and we have to get over these challenges. And what WOS does is that it tries to give you opportunities with which you could overcome these challenges. Today's program is one of those opportunities where we want you to present, we want you to develop more in your confidence, and we want you to realize that the mentors who are mentoring you are important for you, and they will be there for you all your life. So thank you to all the mentors also. So some scientific data which has been showing that the representation of women is definitely lower compared to men in various places, whether it is leaderships, whether it is chairs in conferences and inaugurations, whether it is in authorship, whether it is in partnering with industry, and even remunerations at few places. So WOS was established in 2015 to help you break this glass ceiling. Today has, in fact, almost 3,000 members. There are 22 state chapters, and 7 annual conferences have been held, and we have activities all throughout the year. And the WOS is all about making you extraordinary in your profession, and you don't have to be a part of the crowd, because this will make your soul suffer. And the day you join WOS, probably that's the day where which is written in the stars, a date with destiny, where you meet so many people, so many women ophthalmologists who are accomplished and who are ready to support you, that it is actually going to be a different experience and a game-changing experience in your life. So everything in WOS is based on mentorship. You are not alone in your professional journey. There are mentors, there are role models who are ready to help you and support you. So this was how it all started with the first mentorship program. And since then, everything is based on mentorship. There are a lot of speaker opportunities. Today's program is one such example of giving you a chance to speak. When you speak on the podium, you develop your confidence, you read more, you learn how to present and give an effective and a good presentation. You learn from whatever others are presenting, and you get more connected to your mentor. So these are some of the photographs which I'm sharing of various activities that keep happening throughout the year. There are around 20 to 25 activities that happen throughout the year. And these are all mentored, including our life surgeries, which are many a times mentored. And that's the only society where mentored life surgeries are also conducted. These are some of the post-graduation sessions. Now, our conferences are based on clinical as well as life skills. So you will find that the conferences also 50% of the program is clinical, which you otherwise also get an opportunity to hear in rest of the conferences. But 50% of program is also related to life skills, which are also important for you to be successful. There are state chapter meetings which happen throughout the year at every state level, and with the focus areas this year and last year were skill enhancement, women's health, finance management, and research. Project Archana being looked after by Dr. Anjali Mehta. And this is a new challenge of dissatisfied patients, angry patients, violent patients, and mobs, which we have not learned in our curriculum, but we are having to face. And this Project Archana is teaching you how to overcome all this. Project Shakti, Dr. Jimmy already talked to you in details, and this is about how to deal with the challenges at your workplace. We have a women in research group. We have our own ethics committee, and these are some of the photographs of the website of Women in Research, where various national and international opportunities are there for you. And these are all those photographs. There is a rare eye disease group, or the RED group, which is working on registries of rare eye diseases. And this is the RED pilot project, which is going on, where anybody can be an investigator. There is a WOS care being looked after by Shweta Walia. Again, and this is to do with short-term fellowships and short-term trainings. And last but not the least, a Women Ophthalmologists Worldwide Network, which again was found by some of the core members of WOS. And this is a network with 29 countries. And once you are a member of WOS, you automatically become a member of WOW also. And this was the first conference of WOW that was held in India in 2022. And a lot of activities are happening at WOW also, WOW at the level of WOW 2. This is the last annual conference in 2023 at Varanasi. Some of the photographs. Your very own Dr. Sonal and Dr. Ragini spoke very well, and they are like two of our very important role models for all the women who are there in WOS. So you're very lucky that they belong to your own state. Now, these in 2024, these are some of the examples of WOS sessions that are happening in various conferences, the resident programs like this one happening at the state level. So this is the whole plethora that you have of WOS, which is available for you all. And with this, we welcome you to the annual conference of Women Ophthalmologists Society in Delhi from 4th to 6th October. You can still be a part of it, of the as I said, on the right side, the clinical ICs, the non-clinical ICs, as well as in the center, the SSTC, Surgical Skill Transfer course. So finally, WOS is an opportunity where all ophthalmologists can become extraordinary in their profession. Thank you. Thank you.
Thank you so much, Dr. Mohita, for giving us this overview on what WOS is all about, the way we are taking it forward, and all our activities going on every year. Just personal note, I'm very proud to be a part of it and to take care of my state in whatever way and encourage my state in whatever way possible. Thank you, Dr. Mohita. Thank you very much.
Thank you, Savina.
So with this, we come to our next talk. I'd like to warmly welcome Sharmishta Raja, who I consider a family member. I'm not sure whether a younger sister or a daughter of mine. Sharmishta believes that the magic happens when our passion meets our purpose. Her purpose is to build a tribe of fearless and inspiring leaders who leads with their head, heart, and hands, with the view of propelling changes and creating history. For over 14 years now, Sharmishta has had a thriving career in the leadership developing facilitator and as a coach in the tech industry. She has delivered numerous leadership development programs for various global leaders and coached high-performing individuals and leaders as well. She's a proud founder of a consulting, which is called the Cassiopeia Consulting Agency, which offers leadership training, programs, and coaching to anyone who may be interested in upping their game. She's also a proud mother of two and a wife, and she lives in Calcutta with her family. I'd like to now invite warmly Sharmishta Raja.
Thank you so much, Dr. Suvira. Quickly checking with everyone. Am I audible?
Loud and perfect.
Fantastic. Thank you, Dr. Arvind. Firstly, to the WOS committee and organizing committee and all the esteemed judges, doctors, participants, residents. Thank you so much for having me here today. What an opportunity. And, I was talking to Dr. Suvira and I'm like telling that I've spent 14 years working with IT professionals and corporate leaders and studied leadership and taught leadership, designed leadership journeys, and how do we enhance individual and team performance. And this is the first time I'm addressing such an august gathering of doctors, skilled intellectuals, superb in their craft. And how is it that I can add value to already existing knowledge that you have and propel your growth in a direction that you want? And this reminded me of my experience back in Amazon, where we started recruiting leaders from the multi-veteranity, voluntary retirement, they want to pivot careers and join corporates. So Amazon had then started this project of hiring veterans. Now, I was responsible for the onboarding and assimilation of the veterans into the Amazon way of working. So they had two challenges. One is moving from a non-civilian to a civilian life, typical corporate setup, and more so in Amazon, which is a very peculiar organization. My experience of working for 2 years with the veteran community, of course, was a great learning in terms of how we can transition their learning from the field, from the battlefield to the corporate floor, and what are the uniquenesses that they bring in that can add value to corporate. And in that journey, not just teaching and helping them, I grew and I helped a lot of leaders in their own journey. But again, that helped me being a better coach and facilitator. What I learned is this, and it's very simple and clear. People are people are people. And the reason I bring this is that, and I'll refer to us, we as the non-medical community, is the community that all of you serve. So the medical community, non-medical community, if I can call us as civilians, it'll just be easy reference. So when I say civilians, is the non-medical community. Often we make, and we have a view of doctors as close to God. Because of course, we come to you when we're in trouble and it's to do with our life, with ourselves, our family. And the only person at that point that we have hope from are our doctors who support us. And putting you at the pedestal of being a God at that moment. And it so is. It so is. But with all of this that has been happening, and especially the epicenter of the whole movement right now in Calcutta, we need to acknowledge the fact that doctors are human beings first, with the same challenges, with the same fears and insecurities that any other human being will have when it comes to their own safety and protection. And while the medical community is doing so much to support each other, what is it that we can do to start that communication, that narrative? And in these conversations that were happening in and around Calcutta, I happened to meet one of the resident doctors in Arjekar. And she said, Sharmishta, imagine the plight of an 18-year-old sitting in a hostel with a mob outside. 18-year-old. Though Dr. So-and-so is the name, but an 18-year-old child, adult, young adult. And that sparked a conversation in our communities that what can we do to make it more safe for the medical fraternity? How can we control the behaviors around us when we see an angry mob or angry patients around us? It reminded me of my experience in AIMS in Delhi when I went for my daughter. She has progressive myopia, lazy eye, and an eye condition. So when I was going from doctor to doctors for my daughter, I saw how things were and how helpless I was to find a good doctor for my child, and the frustration that kicked in, but also how the patients were also dealing with the doctors. So my intention today is, how can I bring the learnings, or how can I bring in the support to help you introspect, reflect, and design the life that you want with intention and purpose? How can I bring in the learnings from the corporate world and my own journey to help and support you to design your life? So that is basically going to be the objective of this presentation. Let's keep it interactive. I think the chat is open, so you can, I'll be sharing a few links with all of you. Please feel free to acknowledge and share. And if you have any questions so far, we can take that at the end. But let's start with the first question that I have for all of you. My topic for the day is pathway to holistic success. So what does success mean to you? To each of you, what does success mean to you? I'm just checking with Dr. Tani if I'm on the spotlight as a speaker so that everybody can see me, and the presentation that I will shortly share. So just let me know. Thank you. All right, Dr. Anamika says happiness, peace of mind, that defines success. Job satisfaction, yes. Okay. Work-life balance. Dr. Surabhi, thank you so much. Loved your inputs that came in with Dr. Jimmy's presentation. What else? What else? How do you define success? And specifically, this question is for not just our participants, but also our senior doctors and professors who are at that stage in their life where they've probably achieved everything. And, so whatever success has been defined by society externally, maybe you've ticked all those boxes. And if you still feel something that is missing, this is also a question for you. How will you redefine success for you now? So satisfaction and passion, value in service, great insights. Fantastic. So the first thing that we want to understand is that each of us defines success differently. And we must. Of course, there are some tick boxes that are there for a particular skilled community, that these are some things from a technical competence standpoint that we should be able to achieve. And you are all there from a technical competence standpoint. But beyond that, how do we want to define success for ourselves? Now, completeness, beautiful, beautiful completeness. And Dr. Arvind will come to that piece on completeness with a model that I have to offer. I'm going to be sharing my presentation now. Please do let me know if you're able to see it. It's called Pathway to Success. Can we all see the first slide?
Yep, we can see it. Yeah.
Okay, fantastic. So when I started my journey, and the one good thing that worked for me is that I was very clear of what I really wanted to do in life. And I think, and I sense that anyone who gets in the field of medicine also starts with that, okay, this is what I want to do. There is a very deep yearning of, this is what I was born to do. And then we pursue that. Most of us start the journey. Some of us actually make it, the ones who don't find other ways. But today, let's acknowledge the fact that if you set out to do what you're doing today, you're a very small population who's actually realized their dreams. So take a pause to first acknowledge that there must have been so many with this dream of being a doctor, so many with this dream of doing what I'm doing here today, but very few of us were able to make it. So that's the first thing. When I go back and see that the challenges that I faced, the roadblocks that I faced to be who I am today were all required and needed to be the person I am today in my profession. And my self-discovery journey, or my self-realization journey was in a way blessed, because being in the field of personal development, leadership development, building teams, working with people, coaching, also pushes you to do the same work. So we have to do that work for ourselves before we preach and before we support other leaders. It's a parallel journey. So each coaching conversation, each training session that I would do, there is a lot of research and a lot of work that I need to do first to bring that value in those conversations. And by the nature of the work that I did, there was a lot of realization, there was a lot of introspection that happened. And I was very blessed to find my why. Why do I do what I do? And I'll tell you where it came handy for me. Of course, it was also a part of a very important phase of my life. This was my interview in my job application for Amazon. And Amazon, as we know, has a very rigorous hiring process. This went on for about 5 months, the interview process, and I think 8 rounds, out of which one was a trial round where they actually see how you train. And these were global leaders across different regions, and was virtual, and some person in the room. And so it was a hybrid model. But this was the last interview, which is called a bar raiser round. Now, the bar raiser has a veto power. If the bar raiser says yes and inclined, then the person is selected. If the bar raiser says no, then it's a. Of course, there's some deliberation there, but bar raiser is a key stakeholder in the interview process. This was my bar raiser interview, and this was the question that I was asked. And I still remember this because it was a pivotal moment in my life. So he says, okay, Shamishta, great, you've come this far and all of that, said all of those bits and said, okay, in a world like today where, anyone can learn anything online at their own pace, at their own comfort, like my daughter's learning Mandarin from an app, where learning has become so easily accessible, free, and comfortable, convenient, why should somebody come in your training room? And I am sitting in a tech company, interviewing for a tech company. And this is what I said, that no platform, no app, no virtual training, no virtual assistant can give you the human experience of innovation, interaction, communication. It is through human interactions that innovation happens. Of course, my answer wasn't as polished. It has taken me 4 years to say the story again so many times, but whatever I said, it worked because I got the job. So what helped me think of that answer at that point in time, where someone is literally questioning the existence of my job? Why should someone come into your training? What helped me is knowing my why. This is a very famous model and a book called Start With Why by Simon Sinek. Have you heard of it? Anyone who has read it? It's quite famous.
Yes.
Yeah. Anybody? Okay, just let me know in the chat pod. And Dr. Sriva, you've heard it. Yeah. It's a very simple model. As you can see, it's a golden circle. What Simon basically kind of indicated that the people who really make the difference in other people's life or in the world don't really sell what they do. Don't sell how they do it. They talk about why they do it. And he gives the example of Apple and other such tech companies as to how they are so different from others. Their why is very clear. They believe in breaking stereotypes, thinking differently. It's their belief. Apply the same model to yourself. Why do you do what you do? Why are you in this noble profession of medicine? What drove you? What were the reasons? Is it family? Is it tradition? Is it because we were an A student? Whatever it is. But think deeper, because when you think deeper, there will be a very, very clear, conscious voice telling you, this is why I wanted to be where I am. Do what I wanted to do and be here today. My why was very clear. That God has given me a talent, has given me some gifts. My job is to hone that talent, is to work on my gifts, sharpen it, and then teach it to others. And my modality was communication, but again, the topic was leadership. So the leadership starts basically with us. Right? How do we lead ourselves? How do we lead our lives before we have the privilege of leading others? And anyone in the position of a leader, even in your fraternity, you're a professor, you're a mentor, you're a leader in different organizations. Apart from being an expert in your field, you're performing those roles as a leader. The concepts of leadership, the fundamentals of leadership remain the same. Remain the same. Why do you do what you do? This is what distinguishes you from others who do the same stuff. Why do you do what you do? Take some time today to think about and reflect that when did you make the decision to take such a challenging career, which is definitely so demanding, right from the word go. I'll take a pause here if there are any comments, and I'm just seeing the chat. Why is more important? Yes, Dr. Arvind, Dr. Ashmi, yes, yeah, for my team, and how can I be taught? Yes, a lot of times, and I see this with mid-senior management levels in corporates that, and very pompously, they will say that, we've been leading teams for 20 years. What is it that a training program can teach what we don't know? And the great thing was in my session that the programs that I used to do, we used to have a lot of the senior folks coming in, and one of them actually very boldly said that, Shamishta, all due respect to you, I'm sure you're great in what you do, but what is it that I can learn? I've done this for 20 years. In the end of the program, the 3-day program, this is the same gentleman came and said that, thank God I came in. Thank God I came in. Now, I appreciate this gentleman for 2 reasons. One, he acknowledged that, yes, I think I acknowledge the fact that I knew everything, and the fact is I don't. I needed to revisit. And two, willingness to learn more. So somewhere in life, as life happens and, marriage, kids, career, your clinic, and all of those things happen, we somewhere miss the fact that maybe we want to revisit the younger self, to relearn, rekindle the child who had that curiosity. And that usually comes in the phase, in the mid and senior state in your career or age, however you might want to kind of define that. But have the willingness to be open to new opportunities, to be open to new challenges, to rediscover yourself. I'm going to move on to the next one. And when we start with why, and it's a lot of introspection as to why I do what I do, it comes to a critical point is, who am I? Who are you? Are you your name? Are you the representative of your family, religion, gender? Who are you? You are none of this. All of this that you see on the screen, that's you. That's you. The question we have is, do we have answers for all of this? Some of that you may have answers for, like your purpose, your values. Yes, I know my skills, my talents, my competence, maybe my fears. I know a little bit of all of that. But that isn't enough. You are more than what you think you know. And when we start with this question of who am I, it's a philosophical, spiritual, whatever kind of question you might consider it to be. But why is this important is because your why will only come in when you start your discovery of who am I. Who are you first to yourself, and then who are you for the world, for the people that you're with, your family, your friends, your community, your office. And how is it that you're impacting the lives of other who am I's, other human beings? A lot of our suffering comes from not knowing who we are, not knowing a lot of things about our personality that might affect others, consciously or unconsciously. The question is, how do we do this? Yeah, do you have a question? How do we do this? Shamishta, you've told, okay, who am I? How do we do this? Yes, on networking commissions of, okay, one path for others, team, family, friends. Yes, who we really are. And you know what the truth is? You will not, when you start this journey, everything will not be hunky-dory. Everything will not be the good stuff. You will also be faced by your vices, the things that are not so good about you. So do we have the courage to face it? Do we have the courage to answer it? That yes, I am. This is something about me. And you know what? That's the brilliant part. The minute you have the awareness, you already start working on the solution. The minute you have the awareness. This is a very deep topic. And of course, for the time that I've been given, can't really deep dive into it. But here's how we do it. And honestly, in some cultures, we already do it from the time we are born. For example, our Kundli, our horoscope, our astrological placements. That itself is our first assessment or first report that comes for us is our Kundli. So one of the projects that I really, really loved and love doing, and I still do, is a lot of psychometric assessments that we ran for our leaders. So these are on emotional intelligence, and these are their leadership styles. And there are a lot of assessments available in the market. And I was given the project to study these assessments and recommend them to our clients and our employees of which one kind of they would want to work with for themselves and their teams. And in that journey, I said the first report we have is our Kundli. So what used to happen is I used to test all these assessments, by the virtue of which I have got free reports for myself, which people have charged dollars for. So I had this wealth of reports telling me stuff about things I'm good at and not so good at. And then I said, I'll take it a step further. So I took it with my Kundli and I said, okay. And one of the gifts that I have is joining the dots, connections. Okay, this says this probably is showing in this report. What experience can I think of where I face the challenge here? That's our job. Help is available. Assistance is available. You have professionals who do this kind of work. But in the end, when you're sitting with that wealth of knowledge, how you join the dots and introspect and say, okay, this is where I think that this is where my behavior was incorrect. This is what I should have done differently. And that journey made me the person I am today. And it continues. It continues. I take a pause. Again, look at the chats to see how it's going. Not to get too serious, though, keeping it light. Sure, Dr. Swangi. Thank you. Yes, face them eye to eye. I love that reference. Thank you, Dr. Arvind. this work that we do with our leaders is well drafted in, in terms of their learning journey and all of that, and the setup is corporate, but I'm keeping it a little generic here for the medical community, is that how can I make this easier for you? Why would you want to do this? Why would you want to start your journey of introspection? Who am I? Finding your purpose, all of that. When each of you is unique, why should your journeys be common? Why should it be common? And look at all your professors and look at all your seniors and mentors. They've had such unique experiences and journeys of their own. So purpose-driven career, discovering what your essence is, what makes you you, carving your own path of holistic success. What does success mean to you? I'll give you an example here. The same lady I was talking to from Arjekar said that, we were talking and she's 21 and and I'm 40. And so there was a huge, in terms of generation and in terms of learning, it is a gap. But then I was so curious to know more about her. And she said, I'm going to marry. And I said, okay, tell me more about it. She's like, I'm learning cardiology. I'm going to be a cardiologist, a surgeon. And it's a very demanding job. And you know what? I don't feel the need to get married. This itself gives me a lot of happiness. I said, this is what you say today. Are you sure? And she's like, okay, wherever, but I'm very clear. It's going to be my job first. And I said, how about children then? I said, I'll adopt. Now, what struck me is that how aware she was about her choices. How certain she was that what is her priority at 21, 22 years old. Certain about her choices. Because coming in already being, in MBBS and studying, they know it's a demanding career and all of that. But then still going a step ahead and saying that this is where in my life I will have to probably step back because I have to push further in career. It's all right. It's also all right for another friend of mine who studied medicine, became a doctor and chose to be a homemaker. And all of us were zapped. We were all like, she was the smartest in our class, the ranker and all of that. And she says, it's a choice I made. I wanted to enjoy to be a mom and take care of my 2 kids. And we were shocked and people judged her as well, but then fine. And today she's teaching. So she kept her passion alive in some way, but without compromising what was her priority. And that's fine too. Especially as women, and all due respect to the gentlemen here, but especially as women, we need to be more conscious about the choices we make. And this reminds me of an example that was shared by Indra Nui. And she's one of my role models, one of the women leaders I look up to. And she very openly said this, and it's in recording. There are videos on this, that I don't think my daughters think I'm the best mother. And it is very difficult to be Indra Nui's daughters. It is a hard thing to say for a mother, but she did it. And she knows the sacrifices she made, that she couldn't spend that much time with her children because there was a higher calling. Some might judge her, some might not. But she was bold enough to take that decision. I can tell you from my personal experience, I'm in that stage right now as a corporate professional, as someone who loves what they do, and there's a calling, and then they have children and other responsibilities at home. How do I balance it, right? That's the word we use. In my experience, there is no balance. There has to be harmony. There has to be harmony. One flows into the other. So be more conscious about the choices that you make. If you're not able to find an answer today, that's all right. But start thinking about these choices, because life will give you those opportunities to make these tough choices. And what will help you at that stage is knowing who you are. And I'm going to share some resources with you in terms of links that can help you in that journey. As I said, revisiting and redesigning your life for the senior professionals here. Take the time to also take a step back and revisit, because we still have a lot of life left. And today at 40, I'm redesigning and rethinking the rest of the life that I have left with the wealth of knowledge and experience that I've got. It has led me to a spiritual path, and therefore the next one is spiritual evolution. How can I be better? How can I serve more? How can I serve more people, and how I can serve better to them? Which is actually the joy that we feel. Eventually, all human beings were made to come here, learn what they need to learn the lessons, help others not to make those mistakes, build a community of human beings that are more evolved. And the story continues. We all do it in different ways. We do it as doctors, we do it as teachers, we do it as military personnel, and all of that comes as the karma, right? But the eventual intention is to build a better human society, which right now, sadly to say, the state of affairs is in question. Here's a concept of framework, and I'm going to share that link in the chat. It's called Wheel of Life. It's a free assessment that all of you can take. It's very simple. It's a free assessment. It'll ask you some questions. Answer those questions. Immediately what comes to your mind, just answer and rate that. It will give you a chart like that that says you the wheel of, that talks about the Wheel of Life. Now, ideally, this should be in balance and harmony with each other. But if there is a huge gap in what you want and what you are at currently, that gives you an indication of, is this a priority for you and if you need to work on it? So be it career, money, health, relationships, personal growth, fun and recreation, physical environment, and spirituality. These are deliberately thought of and kept in the wheel because this is holistic life. This is your life. It's not just one aspect of it. There are a lot of doctors, and I was a part of a mentorship program. There were a lot of doctors who came in those mentorship programs. One of the doctors said, I'm skilled, I have, all of that, but I'm just not able to make money. And we all were like, we were like, doctor and no money, how is that possible? Money blocks, mindset. That was a challenge. So it is not just what you do, not just in your career, what you do, it's how you approach it. It's your mindset. It's your outlook towards life. It's how you're taking care of yourself. So health will here mean not just physical, but mental health, which this 22-year-old doctor told me that you must talk about mental health, especially for students. You have the environment. Your professors, mentors are working towards creating that environment for you. Your contribution to that is, how are you first supporting yourself? How are you processing what is happening, and how do you then use communication and your skills to kind of get the help that you need? So your work is more here in this case. And we have to start voicing this now for ourselves and for others. You have the ecosystem. I was so happy to see Project Shakti in the presentation by Dr. Jimmy. And this is a prerequisite in most of the industries. Of course, in the corporate industry, it's pretty watertight. But I know the challenges there, that yes, it's easy to say that speak up, but really, can I? My question is, till you decide that you need to speak up, what are you doing from the time an incident has happened to you till you report it? What is happening in that duration? You're processing what has happened. And you have help for it. You have people, mentors, friends, parents. You have the support. You have professionals like myself who are willing to offer that support as well. So please understand, the Wheel of Life talks about all facets of your life, not just one. And if there's something that has been said, there is a slight dip somewhere, it is something for you to ponder over. Here's a surprise. My intention for this talk was to give you a glimpse of what the journey of self-discovery is and how is it that I can support and contribute to the medical community, especially as a woman, to others. And I'm offering an absolutely complimentary session, a one-on-one session for each of the participants here for this activity, this event today. I'm going to share the link to the calendar where you can book your complimentary session with me and discuss whatever you wish to discuss at this point and the help that we can support you with. Especially for the winners, there'll be 2 sessions. For all the other participants, there'll be 1 session. I'll just take a pause and take a look at the chat. Okay, I'm going to thank you so much. Thank you, everyone. I'm sharing this resource here, which is how do you start your journey of self-discovery? These are some really good questions that you can start with. The next is the free assessment. This is called the Wheel of Life assessment. Please do take the time and take it. I don't know if we have, how much time do we have now, Dr. Tanvi? To kind of
We've got about 3 or 4 minutes. We need
3
to
or 4
wrap
minutes,
up.
okay. We may need some more time for that assessment, so I will leave it here in the chat. Does everybody have the link to the Wheel of Life? And then there's another assessment after that is in terms of your personal values. I'll recommend you take the personal values assessment as well. It gives you a glimpse of, a lot of times we take decisions and we don't understand why and how we took those decisions. And the question is that, how do we find out, right? All the decisions that we've made, all the choices we've made in life come from our core values. This assessment helps you find out what that core value is. For some, it could be passion. So for me, it was passion. Communication. My core value was service, right? All of that. And it keeps changing with life. So this helps you find your core values that help you take those decisions in life. So please go ahead and click on those links. I'm going to quickly share the link to book your session with me. And it says one-on-one coaching session with Sharmishta. I'm going to put that here in the chat. This is my humble, small way of giving back to the medical community, I also want to take the opportunity to, I don't know if I want to do this or, if it's appropriate, but also say, apologize and say sorry on behalf of us for not having seen doctors as human beings first and not empathizing enough. So sorry for the ones who don't do this. They don't know better. But we who know better, my promise is to continue this conversation with the non-medical fraternity and see how we can support you. And in the end, say thank you for your service. In the military program, everybody said, it's our job, Sharmishta, it's our job. Yes, it's your job, which you may have to pay with your life. So no amount of thank yous are enough. No amount of gratitude is enough. So to me, after the military community, the medical community, what drives you to do what you do? Hats off. So thank you for that. Thank you deeply for that. For the hours that you put in studying, for the hours you put into research, for the hours that you put into service of others, which you could have used parting, which you could have used doing something for yourself. Thank you for doing that for us. In the end, this is one of my favorite lines. We are not human beings having a spiritual experience, but are spiritual beings having a human experience. I hope my spirit was able to connect with your spirit through this human experience, and hope I've been able to add value to you, add given some motivation and a space for you to think and ponder, to design and redesign your life. All of you help people see the outside world. I hope I helped you see your inside world. On that note, thank you, everybody. Thank you for your kind patience. And over to you, Dr. Suvira.
Thank you, Sharmishta. That was such a brilliant talk. Everyone would have woken up and everyone would be charged now after this to think about why and how they take their life in the direction that they do. I hope to have you invited to many such talks, and thank you so much for your invaluable contribution to our webinar, Maharashtra. And it's so sweet of you to actually consider giving 20 times 30 minutes of your time just to encourage these students who have taken the time and the effort to participate. I mean, I can't thank you enough. I know you told me this on your own, and I was so touched with this gesture, and I'm sure it'll go a long way in just guiding them as well. Thank you so much for being part of this, Sharmishta. Thank you.
You help with vision. I help with vision in my own way. So I hope it helped. Thank you so much. Thank you, everybody.
Thank you so much. Bye-bye. Bye. Thank you. With this, we now start the second competitive state session. Tanvi, over to you to take this ahead.
Thank you, ma'am. We are now ready to move on to our second session for the day. Before we begin, I'm pleased to introduce our new judges for this session. First, we have Dr. Bhavani Raina. She's an additional professor in the Department of Ophthalmology at AIIMS Vijaypur in Jammu with over 15 years of experience. She specializes in anterior segment surgery, including cataract surgery, LASIK, and glaucoma management, and has a keen interest in community ophthalmology and retinal diseases. Next, we have Professor Rajiv Gupta. He is the professor and head of RIO RIMS and director and CEO of RIMS. With a distinguished career, including 52 publications in indexed journals and numerous presentations at national and international conferences, Dr. Gupta has made significant contributions to diabetic retinopathy and corneal grafting. We next have Dr. Rashmi Jain. She's a professor at Yenapoya Medical College in Mangalore. Dr. Jain is recognized for her expertise in comprehensive ophthalmology, medical education, and clinical ethics. She has received multiple awards and has over 40 publications in peer-reviewed journals. And finally, we have Dr. Manpreet Kaur. She's an associate professor at RP Center for Ophthalmic Sciences at AIIMS, New Delhi. Dr. Kaur is noted for her achievements in cornea, cataract, and refractive surgery, with numerous awards, including the APAO Achievement Award and the ISCKRS Young Achievers Award. She has over 200 publications and serves as an editor for several prestigious journals. We are now ready to begin the competitive session. We begin with Dr. Iti Jain from KEM Hospital, who is mentored by Dr. Avinash Ingole. Dr. Iti, the stage is yours.
Thank you, ma'am. Good afternoon, everyone. Today, I'll be presenting a case of delayed presentation of keratoconus cavernous fistula.
We'll be discussing about our unique case presentation, what is cavernous sinus, and finally, what is cavernous fistula. So let's begin our case discussion. We have a 23-year-old male patient who came to us with chief complaints of left-sided sudden onset and painful diminution of vision, along with bulging of eyeballs since 15 days. Past history of road traffic accident 3 months back, which led to aortic transaction, para-aortic hematoma, and splenic laceration. On further systemic evaluation, his CNS and RS evaluation were completely within normal limit. So he underwent CT scan outside, which suggestive of orbital cellulitis, for which antibiotics and steroids were given, but it did not improve at all. So he came to our center, where ophthalmic evaluation was done, and here left eye vision was finger counting 3 meters with axial proptosis, periorbital edema, pulsations were felt over the superior medial aspect, corkscrew vessels were seen, extraocular muscles were restricted, and intraocular pressure were raised to 24 millimeters. On exophthalmometry, left-sided was 35 mm. Along with it, the swelling was compressible but not reducible, and on auscultation, bruit was heard over the superior orbital notch. Pupils were fixed and dilated. Rest anterior segment was completely within normal limit, and the posterior segment was also within normal limit. So, patient underwent CT scan. Did you notice something? Okay, let me point it out for you. Here in this picture, you can see there is dilated superior ophthalmic vein. So we did DSA for the patient, and it suggests of direct drainage from internal carotid artery to the cavernous sinus. Hence, the diagnosis of delayed onset direct type of CCF was made. Ophthalmologically, we managed the exposure keratitis and raised intraocular pressure, and interventional radiologists managed it by transvenous balloon-assisted endocoiling. We have a post-op day 2 presentation of the patient as given below. Patient didn't have bruit and intraocular pressure was reduced. So actually what happened? What is cavernous sinus? What is cavernous fistula? Let's study them one by one. Cavernous sinus is a dural venous sinus lying in middle cranial fossa having important structures like internal carotid artery, cranial nerve 3rd, 4th, 6th, and 5th. While CCF is a dural AV fistula, which has high pressure arterial blood flows to the low pressure venous area. On the basis of communication, it is of two types, direct type and indirect type. Barrow has also classified them into type A, B, C, and D. Type A is a direct type of communication where blood directly flows from internal carotid artery to the cavernous sinus, while B, C, D are indirect, where meningeal arteries flows to the cavernous sinus. Direct is much more common as per literature and most common causes trauma, while indirect are mostly spontaneous. So what do we do ahead? How will we proceed? The clinical pictures. The dandy stride is a classical clinical picture. It has pulsatile exophthalmosis, bruit, and chemosis. Along with it, patient can also present as ophthalmoplegia due to the involvement of cranial nerve 3rd, 4th, and 6th. We should do radiological imaging for the patient, CT angiogram, which suggests of dilated superior ophthalmic vein along with proptosis and enlarged muscles. In DSA, we can see the exact drainage of carotid artery to the cavernous sinus, and in MR angiogram, we can see enlarged ophthalmic vein. So how should we manage the patient? Type A is an emergency case which should be managed surgically, while indirect should be managed accordingly. So what did we learn from this case? In our case, patient was presented to us with orbital cellulitis and man was managed by antibiotics and steroids. Instead, if they have taken proper history and they would have seen the patient, bruit was observed, they would have come to a diagnosis of CCF even without radiological imaging. So take home message from my presentation is you should take proper history and examine the patient properly. Thank you.
Excellent presentation.
I'd like to invite Dr. Rajiv Kumar Gupta to lead the discussion.
Okay. It was a very good presentation. I want
Thank
to
you,
know
sir.
that in what age group usually you will notice the CCF. What
Sorry,
is the
sir?
age group? What is the age group?
Sir, CCF can be seen in young patients and elderly also. In young, generally seen in males after trauma, and in postmenopausal females who has connective tissue disorders, it can also be seen. But the patient who are young are
they mostly have direct kind of CCF, and the patient who are generally female and older age, elderly females, it is mostly indirect kind of CCF.
Okay. Wow. Which eye is usually more affected, whether it is unilateral, bilateral? What
So
is the
mostly it
incidence?
is unilateral, and in some
Okay.
cases it can be bilateral because cavernous sinus has a direct communication.
Okay. What will be your differential diagnosis?
So my first differential would have been orbital cellulitis, and thyroid ophthalmopathy can also, active thyroid ophthalmopathy can also present similarly. Superior ophthalmic orbital apex syndrome, superior orbital fissure syndrome can also be my differential diagnosis.
Can you tell me what are the risk factors in indirect type?
So hypertension, atherosclerosis, connective tissue disorders, generally postmenopausal females having hypercoagulable states, pregnancy is also a risk factor.
Diabetes, what about diabetes?
So diabetes is
What
also a risk factor, but it is more commonly seen in hypertensive patients as compared to diabetic patients.
Okay, right, right. So what is the principle of treatment?
So treatment is based in direct type. There is a direct communication between internal carotid artery and the cavernous sinus, which is very high flow. So we should manage it surgically by embolization. So via arterial, venous, or transverbital course, we can directly go to the artery or the via venous structure, and we can embolize the fistula. While indirect, we can just give carotid massaging, and in 60% of the cases, it spontaneously closes.
How you do immobilization?
Sorry, sir?
How will you do immobilization?
Sir, embolization can be done by balloon-assisted endocoiling or by using stents, and there is liquid embolization also there. There are two materials, onyx, and the other one is N-butyl cyanoacrylate group.
Okay, fine. What is the role of ophthalmologist?
Sir, as an ophthalmologist, we should take proper history and should have done proper ophthalmic evaluation, basically proptosis evaluation. While examining any case of trauma, we should always palpate the orbital rim, not only for fractures, but also for observing the pruning. So, and also, patient can also develop, as a complication, patient can also develop glaucoma because of raised intraocular pressure and can also develop CRVO. So, we should manage the patient accordingly.
When will you refer the patient to neurologist or neurosurgeon?
Sir,
What
I'll
time of
refer the
time?
patient to neurosurgeon and interventional radiologist.
Just
And
30
what is the
seconds
role?
more for discussion, please. 30 seconds more for discussion.
Okay. Any other member, any other judge will like to take questions?
Just one question. What are low flow and high flow fistulas?
Sir, ma'am, high flow fistula is a direct type of fistula where directly internal carotid artery drains into cavernous sinus, and low flow fistulas are the indirect kind of fistulas where meningeal branches of the internal carotid artery and external carotid artery drains into cavernous sinus. Thank you, ma'am.
Okay.
All right.
Thank you.
With this, we come to the end of Dr. Iti's presentation. Well done, Iti.
Thank you, ma'am.
We next have Dr. Bisma Ansari, also from KEM Hospital. She is mentored by Dr. Anamika Agrawal. Dr. Bisma, the floor is yours.
Yes, ma'am. Good morning, everyone. I am Dr. Bisma Ansari. I will be presenting a case on ocular surface squamous neoplasia. OSSN is usually a tumor of the elderly and is usually misdiagnosed. It is the third most common conjunctival malignancy worldwide. Histopathologically, it can be conjunctival dysplasia, intraepithelial neoplasm, and invasive squamous cell carcinoma. The risk factors include smoking, xerophthalmia, vitamin E deficiency, ultraviolet D light, human papillomavirus, light hair and skin individuals, HIV virus, exposure to petroleum products, and P53 mutation. This is a case report of 57-year-old gentleman scrap dealer by occupation who came to our OPD with complaints of redness, watering, foreign body sensation in the left eye since 1.5 years. Patient has been in multiple hospitals but has no relief. He is a known case of HIV and on treatment.
General examination was all within normal limits. Ocular examination, vision with his own glasses, then both eye was 6/9. The right eye examination was all within normal limit with PCIOL. The left eye, conjunctiva showed diffuse gelatinous white mass-like tissue encroaching the cornea over limbus for around 8 limbal clock hours with mild vascularization, keratin deposits, and rose bengal stain, highly suggestive of OSSM. Rest all were within normal limits. In investigation, ASOCT was done for the patient, which showed abrupt conversion of healthy epithelium to abnormal epithelium without any stromal invasion. A provisional diagnosis of left eye ocular surface squamous neoplasia in a known case of HIV was made. Patient was started on topical treatment of 0.04% MMC drops 4 times a day for 4 days in a week with a 3 days break period. This cycle was continued for 2 months, and at the end of 2 months, patient complete resolution of the OSSN was noted. Patient is kept on 3 monthly close follow-up to detect any recurrent lesion. Let's discuss in brief about this topic: management, diagnosis, and clinical features. Clinical features, it is located at the limbus. It can be diffuse and flat. It can be nodular, circumscribed. It can be nodular ulcerative, which can mimic PUK. It can be leukouric acid in the whitish lesion in the picture. It is usually non-pigmented, but it can be pigmented as well. And it shows intrinsic vascularity with feed of acid. The most important key features in diagnosis is the location at the limbus, keratin, intrinsic vascularity, and the rose bengal stain positive. Investigation done in such cases are ASOCT to rule out corneal and cell involvement, and HIV CBC to rule out any immunocompromised state. Other investigations done to rule out intraorbital extension and gonioscopy, USG scan, CT scan, and ultrasound biomicroscopy. Treatment options available are surgical, medical, and in few cases combined. Surgical options for small tumors, there are complete excision with cryotherapy. Tumors which are invasive can be treated by partial thickness keratectomy with amniotic graft, and large tumors, incision biopsy with adjuvant chemotherapy is preferred. Coming to medical treatment, the literature says options available are in topical and subconjunctival interferon alpha 2B, topical 5-fluorouracil 1%, topical mitomycin C, and others which are less commonly used are anti-VEGF, topical subconjunctival retinoic acid, pseudofluid. The conclusion: traditionally, surgical excision has been the mainstay treatment for OSSN, but it comes with recurrence, corneal scarring, limbal cell deficiency, symblepharon. In order to potentially avoid these risks and treat the entire ocular surface, medical treatment alone has been in increasing popularity. This case highlights the fact that the treatment of OSSN only with topical mitomycin Z has shown 100% cure rate. However, recurrence rate cannot be commented as of now, as the patient is still under follow-up. These are my references. Thank you.
That's an excellent presentation, Bisma.
Yes, ma'am. Thank you.
I'd like to invite Dr. Bhavani Rena to discuss your case.
Hello, ma'am.
Ma'am, your audio is muted.
Everyone, am I audible now?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am.
Excellent presentation, Dr. Bisma. So your patient was
Thank
a
you, ma'am.
57-year-old male who was already
Yes,
diagnosed as a
ma'am.
case of HIV.
Yes, ma'am. He was
Yes.
on treatment.
Apart from HIV, is there any other virus which can cause this type of condition?
Human papilloma virus. Yes, and most commonly human papilloma virus.
So human papilloma virus can also cause OSSN.
Yes,
Another thing
ma'am.
I wanted to ask you was that what are the various DDs for this type of condition? Because I don't think when a patient comes to you initially, you will think on terms of malignancy immediately. You will first
Yes, ma'am.
think in terms of certain common conditions.
The differential diagnosis in such a case can be a pterygium, a pingacula, a Salzmann nodular degeneration, which is usually a limbus, and uh, yes, ma'am, and yeah. Pterygium pinguicula.
If I see clinically, pterygium is a very common condition.
Yes,
And
ma'am.
sometimes this pterygium might get misdiagnosed and we may think that an OSSN is actually a pterygium. So what are the certain points that we should look in a case which we think is a case of pterygium and then decide whether it actually is a pterygium or maybe some other condition?
Ma'am, pterygium is a classical fan-like fan and triangular structure which has a head, body, and tail, and it comes from the periphery to the cornea. And second thing, it will not show any interesting vascularity. Third thing, it will not show any rose bengal stain positive because it does not contain any dead tissue there, so as in OSSH. And yes, ma'am.
So normally you will have in case it is an OSSN, you will normally have a sentinel vessel and anything about the location because pterygium mostly is nasally placed.
Yes,
But if you see a pterygium on the temporal side and there is no history of any other kind of trauma or something like that, which you can suspect may be a case of pseudopterygium, then it should raise your alarm bells and think maybe this is something else and not only pterygium.
Right.
Right. Another thing I wanted to ask you was that apart from your anterior segment OCT, is there any other method that you can use initially to come with your diagnosis?
Yes, ma'am. Ultrasound biomicroscopy can be done to rule out any intra-orbital invasion, etc. Because it locates the limbus, so it's high chances it can penetrate.
What about impression cytology? Because that is something very easy
Yeah,
that we can
impression
do within
cytology and
our OPD.
exfoliative cytology also. Both of them can be done when we are starting medical treatment. These two options are very good in proving ourselves that it is an OSSN and we are treating it with medical medications, topical medications.
What is the definitive method by which we can determine that it is an OSSN?
Histopathology, ma'am. Histopathological.
Incisional or excisional,
Depending upon the size of the tumor, incisional and excision.
What can surgery cause commonly? Complications due to if you go for a surgery, what is the commonest complications that can come with the surgery?
Ma'am, the commonest complication is corneal scarring, limbal cell deficiency. If more than 4 to 5 limbal trocas are involved, it can cause limbal cell deficiency, which can later cause dryness and corneal abnormalities. And symblepharon also. If there is limbal cell deficiency, there can be symblepharon. And yes, ma'am.
30 seconds more for discussion, please.
Okay. Just one thing more.
Recurrence, ma'am. Ma'am, recurrence.
Recurrence, right. What about mitomycin C? We are very afraid of using it, many times. What is the commonest complication that
it comes with a lot of side effects, but literature says that it is one of the most effective drug in OSSN, apart from fluorouracil and interferon alpha B. It is very easily available also. The most common side effect with it is dryness, allergic conjunctivitis, and punctal cyanosis. For that, we usually we try to give punctal plugs, or at least we can tell the patient to occlude the punctum and then put the drop for at least 5 minutes, and like to keep occluded punctum so that the drug does not cause punctal cyanosis.
Thank you, Dr. Bisma.
Yes, thank you so much.
Doctors. I'd now like to invite Dr. Basavkiran Patil to present her case. Doctor. Dr. Basavkiran.
Yes, ma'am.
All right.
Good afternoon, everyone. I'm presenting a case of young female with vulnerable proptosis, cavernous syndrome of orbit. My auditor is Dr. Smita Gavade, ma'am. I'm from K. Samaya Hospital. Patient demographic is patient name, Dabisa Arvind, 25 years female, housewife, resident, chief complaints, chief of the forward bulging of the left eye since 6 to 7 months, with left eye blurring of vision since 6 months. The history of present illness, onset and progression, forward bulging of eye was painless, insidious in onset, gradually progressive in nature, negative history, no history of redness, watering, trauma, no history of foreign body sensation, no history of diplopia, no history of blackouts, photophobia, discharge. Past history मध्ये no history of diabetes mellitus, hypertension, thyroid disorder. Personal history makes diet normal bowel bladder habits. Family history was not relevant. The general and systemic examination was within normal limit. Ocular examination of right eye vision was 6.6, left eye was 6.12, no improvement. The right eye ocular examination was within normal limit. I'll proceed with the left eye findings. The position of the head was normal. Position of eyeball was 15-degree exotropia with axial proptosis. Extraocular muscle movements were present in all cardinal gazes. Lids were normal. Lacrimal passage, rhoplast negative. Conjunctiva was normal. Cornea was clear. Sclera showed an inferior scleral show. Anterior chamber was normal in depth. Iris had normal color pattern. Pupil was round, central, reactive to light. Lens was clear. On Hutton's exophthalmometer with base 112, there was 24 mm of proptosis. Intraocular pressure of left eye was 14 mm Hg. The vertical fissure eyes were 13 mm. MRD1 was 5, MRD2 was 8 mm. LP section was 15 mm. There was no lead lag and no lag of thalamus. Color vision was within normal limit. The axial length of left eye was 22.38 mm. The change in proptosis and Valsalva minor was absent. The pulsations were absent. Fundus examination, the disc was, margins were blurred, blood vessels, torches, coronal folds were present. This is an image showing the Nabziger sign where the left eyeball appears to be proptosed. The investigations, routine blood tests were done, thyroid function test, chest X-ray, CT scan of orbit, axial 2 mm cut section. The CT scan of the orbit showed large round to oval, well circumscribed homogeneous intracorneal mass. On CT scan, the mass was iso to the bone and hypo to the fat. The differential diagnoses are left eye cavernous hemangioma, schwannoma, neurofibroma, solitary fibrous tumor. Treatment, a left eye excision of the intracorneal mass using medial orbitotomy approach was done using a cryoprobe therapy under general anesthesia. Successful surgery was done. The left eye intracorneal mass was sent for histopathology. The measurement were 42 mm into 38 mm into 10 mm, suggestive of the cavernous hemangioma. The excised mass was sent for histopathology. The findings were large vascular spaces lined by endothelial cells, stroma separated by the septum. Final diagnosis, right eye within normal limit with left eye painless non-pulsatile axial proptosis due to cavernous hemangioma of the orbit. The post-operative finding, this is a picture of the post-op day 1 with left eye with drain in situ. The post-op normal color vision, pupillary reaction was normal, the full free extraocular movements were present. On post-op day 30, the patient had vision of 6.9 improving to 6.6. Discussion, diagnosis, correct diagnosis of cavernous hemangioma of orbit can be made using imaging techniques. Treatment, surgical excision using appropriate orbidotomy approach is treatment in case of symptomatic patients. Asymptomatic patients can be observed.
Thank you, Dr. Basavkiran. I'd like to invite Dr. Rajiv Kumar Gupta to commence the discussion on this case. Sir, your audio is muted.
Now I am audible.
Yes, sir, you're audible. Thank you.
Okay. I want to know that what is the incidence? What is the incidence of cavernous hemangioma?
So cavernous hemangioma is the most common brain and orbit tumor and a rare vascular tumor. It accounts for 4 to 7% in all cases of orbital tumors.
And what are the other sites apart from brain or brain stem where we will get cavernous hemangioma?
Hello, sir.
Apart from brain or brain stem, what are the other structure where you will get this hemangioma?
Cavernous tumor of the retina.
How does it look like? Cavernous hemangioma, how does it look like?
The appearance is like reddish mass.
Okay.
Histopathology.
Okay. Other judges to ask any questions?
Are there any more questions that any of the other judges would like to ask?
Okay. Okay.
So are we good? Yes,
So
sir.
what
Please
is the
carry on.
treatment? What is the treatment which you have told that excision? Any other treatment?
Needle orbidotomy was done. So we can use other approaches like lidal orbidotomy. Then in case we can use CO2 laser, gamma knife.
Usually it is asymptomatic. When it bleeds, then you will get symptoms. Okay. In what percentage of case you will get symptoms? You got my question?
Yes.
You got my question? Usually it is asymptomatic. It lives for a longer duration. But when it bleeds, then it gives symptoms. So in what percentage of case you will get symptoms?
So more than like 50% patients like
No,
prophylaxis
no.
present. So
No.
Would you like to answer the question, beta?
It is 1 in 10. It is 1 in 10. 1 in 10. It is like that. So is it hereditary? Is it hereditary?
Sir, do we end this discussion then?
Is it hereditary? Hereditary aspect is there or not?
I think with that, we come to the end of this presentation.
Okay, ma'am. Thank you.
Thank you so much, sir, for your valuable
Thank you.
insights. Tanvi, over to you.
Okay, thank you.
Thank you. We now invite Dr. Tanvi Ajmera, also from KJ Somaiya College. She's mentored by Dr. Sania Sayed. Dr. Tanvi, please.
Yes,
start
ma'am.
the presentation.
Good morning, ma'am. I'm Dr. Tanvi Ajmera, presenting the case of unveiling the uncommon, a rare
Sorry
case
to
of
interrupt, but I
anterior
think you
distal
have
syndrome.
two devices
Patient of 4
simultaneously
years
open
male
somewhere,
informant his
so
mother
it's
came
causing
with a
static.
complaint of progressive painless blurring of vision in both eyes. The mother reported that her son has been bumping into objects, unable to recognize the people, finding difficulty in grasping objects since few months. There was no past history. There were no complaints of any systemic illness, no history of any consanguinity or hereditary disease in the family. Personal history is not significant, and birth history is full-term normal delivery. The patient was examined in the OPD. Child was conscious and oriented. The vision was uncooperative. Anterior segment showed persistent pupillary membrane, shallow AC, essential iris atrophy. And in the left eye, it showed stretch high holes in the iris and shallow AC. Lens showed subluxation of lens. The decision was then made to conduct a thorough and meticulous examination of the patient under general anesthesia. The examination under the general anesthesia showed in the right eye there was correctopia, polychoria, essential iris atrophy, shallow AC with persistent pupillary membrane. And in the left eye, it showed stretch holes in the iris with shallow AC with essential iris atrophy. There in the lens, it shows microspherophakia with subluxation of the lens. So this is the right eye examination, which showed shallow AC with persistent pupillary membrane and stretch hole, correctopia with stretch holes. And in the left eye, it showed stretch holes with shallow AC, and subluxation in the lens was present in both eyes. Then fundus examination was normal in both eyes with no evidence of any glaucomatous changes. Then we did IOP measurement also under general anesthesia, and both the eyes intraocular pressure was within normal limits. Specular microscopy was done, which revealed normal endothelial cells, and there was no light reversal appearance. The differential diagnosis was Axenfeld-Rieger syndrome, Ice syndrome, and Peters anomaly. This is a spectrum of anterior chamber syndromes, which includes posterior embryotoxin, Axenfeld anomaly, Riger anomaly, iridoconio dysgenesis, posterior keratoconus, Peters anomaly, and the entire spectrum of anterior cleavage syndrome. The management, the above findings were confirmed by the team of ophthalmologists, includes the glaucoma specialist, pediatric ophthalmologist, and retina specialist, and the comprehensive treatment plan was formulated for the patient. We planned for clear lens extraction with anterior vitrectomy with surgical aphakia. Then further intervention was secondary lens implantation to be scheduled once the patient reaches the age of 6 years. Interim care, we gave refractive rehabilitation to the patient until the secondary implantation was done, and 3-monthly follow-up for glaucoma evaluation has been formulated. This is the picture of the anterior vitrectomy along with the clear lens extraction done to the patient. Then in post-operative, day 1, the cornea was clear, there was surgical aphakia and a red reflex was present. Intraocular pressure in both eyes were within normal limit, and post-operatively, we gave antibiotic and steroid drops to the patient. Then after 2 weeks, we prescribed aphakia glasses, and intraocular pressure was also examined that time, which appeared to be within normal limits. And the child has been asked to follow up 3-monthly for glaucoma evaluation. This is the post-operative picture of the child 2 weeks after the operation. We will discuss about the topic. Anterior segment dysgenesis encompasses a heterogeneous group of congenital eye disease. There are varying degrees of abnormalities, including in the cornea, iris, and the anterior chamber.
Sorry, Deja, you need to end up now quickly. Thank you. Please finish. Get to your conclusion, dear. Go back to your conclusion. Please conclude.
Yeah. The anterior segment syndromes involves the Axenfeld-Rieger syndrome, which includes ocular features of posterior embryotoxin, iris abnormalities, and glaucoma, which is present only in the 50% of the individuals. Then iridocorneal endothelial syndrome includes 3 variations: the Chandler syndrome, essential iris atrophy, and iris nevus syndrome. In this case, the patient exhibits essential iris atrophy in both eyes. So we can consider the patient to be an eye syndrome also. And Peters anomaly includes the development defect in the eye where there is central corneal opacity, iris adhesions, and lens involvement. The patients in this case report highlight the complexity of the iridocorneal syndrome, where necessity individualized treatment plans should be made. Tailored involvement of both surgical and medical interventions is crucial to address specific abnormalities effectively. Thank you.
Thank you, Dr. Tanvi. I invite Dr. Manpreet Kaur to lead the discussion in your case presentation.
Thank you, Dr. Subira and Dr. Tanvi, a very comprehensive presentation. So I have a few queries. One, in the differentials, you mentioned Peters, eyes, and Axenfeld-Rieger. So tell me one point, why is it not eyes?
Ma'am, because in this, first of all, in the eyes, there is corneal involvement, which shows there is change in the endothelial,
my dear, you already mentioned it in your differential that one is eyes. So you have already considered that there are some points in favor, which is okay. What is the point that is pointing against eyes syndrome? Presentation of eyes, what is the point that excludes eyes? Even in your conclusion, you mentioned it may be eyes. What's the point against eyes? Presentation, age and laterality. I'll give you a hint.
Yes, ma'am. One is the patient has bilateral presentation, which is against the eyes because eye syndrome has unilateral presentation. Second point is, ma'am, the specular microscopy showed that the endothelial cells were normal, which is also against the eye syndrome. In the eyes, there will be change in the composition of the specular microscopy. Third,
what's the age of your
patient? There can be. The age is 4 years, ma'am.
When does eyes present? Is it congenital or acquired?
It is present at the age of around 20 to 50 years.
Yeah. So therein,
It will not present at
unilateral
the age of 4
presentation
years.
in 20 to 50, ICE syndrome is ruled out there and then in a congenital acquired bilateral syndrome. Second differential, Peters anomaly. Why is it not Peters? 1 point against.
Ma'am, it cannot be Peters because in Peters there will be central corneal opacity, which is not seen in this patient.
Yes. And
So,
again, what is
would not-
characteristic of Peters? How do you describe the association, the interaction between the cornea and the lens? What's it called?
There is adhesion between the cornea and the lens, and there will be central
Central or
corneal opacity
paracentral?
with
Yes, yes.
central
So
corneal
central or
opacity with
paracentral?
leukoma. Central corneal opacity with leukoma.
Yeah, so central or paracentral corneo-iridic adhesions leading to a central corneal opacity. So you have ruled out Peters as well in this case. What was your third
Yes.
differential?
Third differential is Axenfeld syndrome, Axenfeld-Rieger syndrome.
So one, in a case of 4-year-old, maybe ICE syndrome has no role in the list of differentials itself. And
Yes,
when
sir.
you're concluding, you have to rule out the others and maybe remain with only one differential in itself. Then your management plan. Why did you opt for clear lens extraction? What did the patient gain?
Ma'am, the patient had microspherophobia and there was subluxation of the lens. Already the
Define
lens was
subluxation
dislocated.
extent. I could not see any dilated picture with the extent of subluxation. Neither could I see it defined in the case. So can you tell me what was the extent of subluxation? Whether it was an anterior-posterior displacement or a displacement in the same place as the lens to one
Ma'am,
side, temporal nasal.
It was the picture did not show that clear, but in the slit lamp, we had seen that there is this anterior subluxation of the lens. Ma'am.
Could you see
So that
any
is why
edge where the zonules were absent?
the there was shallow AC anterior subluxation of pen, and superiorly there was absence of the zone. So we planned.
Was there?
Another 30 seconds, please, for the discussion. Thank you.
Okay, so one, in a compromised eye in which already the endothelium is going to be compromised, maybe clear lens extraction is not going to benefit you much in these dysgenesis cases. Often they are better left alone rather than intervening if there's not no touch. Did you evaluate fundus and follow-up, EUA, cupping, or the disc status?
Ma'am, yes, ma'am. We evaluated the fundus. The fundus appeared to be within normal limit, and there was the CDR was also within normal limit. There was no glaucomatous changes within the fundus.
Okay, thank you. Important to
This
mention.
ratio was 0.8.
We'll end it.
Thank you. Thank you very much. With that, we come to the end of this talk.
The next presentation is by Dr. Shruti Madhani from KJ Somaya College. She's mentored by Dr. Vrunda More Patil. Dr. Shruti, we invite you to please present your case.
Good afternoon, all respected. I'll start my presentation in a few seconds.
Stop the slide share.
Is my screen visible? Is my screen visible? Okay. Good afternoon, everyone. My name is Dr. Shruti Madhani, and I'm from KJ Somaya Hospital. My title is Unilateral Sudden Vision Loss in a Young Male, Case of Eales Disease. Just give a brief introduction about the Eales disease first. Eales disease is an idiopathic peripheral retinal vasculature wall inflammation which leads to peripheral retinal ischemia and neovascularization, and it's usually seen in young. It is common in Indian subcontinent. The etiology may include associated with a mycobacterium tuberculosis infection, or it may be immune response to tuberculin protein, but mostly it has idiopathic cause and an unclear etiology. The pathology of Eales disease includes 3 stages. First is the inflammation stage called as retinal phlebitis. The second is the ischemic or the proliferation stage. And the third stage includes the complications like neovascularization or the recurrent vitreous hemorrhage. And to start my case now, a 26-year-old male whose occupation was a factory worker came with the chief complaints of sudden painless diminution of vision in the right eye since the night before. He had no history of trauma, foreign body sensation, or pain, and no negative history about any prior tuberculosis infection. The ocular examination was done, and his right eye shows vision of 636 with no improvement in pinhole. Intraocular pressure and fundus findings include a dull glow with a sclerosed vessels, retinal hemorrhage, perivascular sheets with periphlebitis, and a monstrous hemorrhage. In left eye, the vision was 6.9 improving to 6.6. Intraocular pressure, anterior segment findings, and the fundus findings were within the normal limits. This is the image of this is the image of the right eye fundus photograph of the patient showing an hemorrhages with a superior temporal zone in with perivascular sheets with periphlebitis and vitreous hemorrhage. Network. Yes, the investigations done was the fundus fluorescein angiography, Monto test, complete blood count, ESR, chest X-ray, and the TB gold test to rule out TB. The results were here. The fundus fluorescein angiography showed hypofluorescence that corresponds to the vitreous hemorrhage in the fundus photo, and the hyperfluorescence was seen in the late phase of the angiogram, showing a new onset leakage due to new onset neovascularization. The left eye FFA was within normal limits. CBC showed raised eosinophils with lymphocytes and raised ESR. Neither the chest X-ray and the Monto test was negative, but the TB cold test turned out to be the positive for this patient. The diagnosis and initial treatment, the diagnosis was made as a Eales disease of the right eye. The treatment was initiated and anti-tubercular treatment was started by the respiratory medicine physicians. Steroids were started, oral as well as the topical, and anti-VEGF injection, Avastin, was given in his right eye, and later on, laser therapy, scatter laser photocoagulation was given. This was the intravitreal injection Avastin given in his right eye. The outcomes in the follow-up after 1 week was the visual acuity in right eye was improved from 636 to 624 with pinhole improving to 612, and the left eye was same as before. The intraocular pressure was normal, and the fundus examination showed a great response to the intravitreal injection, and it showed a few hemorrhages. The outcome and follow-up after 1 month include visual acuity, which was both eyes night. Fundus examination showed improved fundus findings with focal laser treatment of new vessels was performed. The evaluations are the favorable with regression of new vessels, complete recovery of visual acuity, and was seen in this patient. Follow-up, we advise the patient keep monitoring evidence for recurrence of new vessels and possible involvement of the left eye. So let's discuss about Eales disease. It was named after Henry Eales, which was first described in 1880. The noted recurrent retinal hemorrhage was seen. Etiology, as it is uncertain and it is multifactorial, it is likely heterogeneous, associated with Mycobacterium species, and it causes retinal autoimmune response. Associations and risk factors include tuberculosis test, positive in 64% of the patients, and HLA typing. These are the differential diagnoses I want to like to mention: non-inflammatory and inflammatory. Non-inflammatory will include the PDR, VRVO, and non-inflammatory would include tuberculosis, syphilis, sarcoidosis, and Behçet's disease. The diagnostic focus here was the Eales disease primarily affect veins rather than arteries, which was seen in this case. And the treatment options here was proliferative stage. The peripheral laser scatter photocoagulation was done, which is contraindicated in acute stages. Corticosteroids was effective in managing the inflammation. And third option was the vitrectomy, which was recommended for recurrent vitreous body hemorrhages, which is not seen in this patient. The conclusion it's a Eales disease. It is a rare autoimmune condition, which is characterized.
4.5 minutes.
which is categorized by the retinal periphlebitis, ischemia, and neovascularization. Etiology is poorly understood and multifactorial. Diagnosis includes requires comprehensive systemic and clinical examinations, usually diagnosis of exclusion. Clinical presentation is usually bilateral in up to 90% of cases, but it often presents unilaterally. The treatment includes the laser photocoagulation, which is the mainstay for preventing the neovascularization, corticosteroids, intravitreal anti-VEGF injections, and observation. The case outcome of this phase was that the of laser photocoagulation, systemic steroids, topical steroids, along with the intravitreal, and showed successful and halted disease progression, and it maintained useful vision in the affected eye. So the conclusion of the case was that the early and the comprehensive treatment is critical for managing the EELS disease and preserving vision. And these are the references from it. Thank you.
Thank you, Dr. Shruti. I invite Dr. Rashmi Jain to lead the discussion in this case.
Yeah, good afternoon. Well presented, Shruti. How would you differentiate EELS disease of vasculitis?
EELS disease, sorry ma'am, I cannot hear you.
How would you differentiate this from other causes of retinal vasculitis? Am I audible?
Ma'am, yes, ma'am. Ma'am, actually, EELS disease, it usually affects veins. So here that was sclerosed vessels and periphlebitis was C. And other thing, we concluded it was a young male. So EELS disease was the first differential diagnosis that came to mind because he was a young male and he had sudden diminution of vision loss. And ma'am, to rule out EELS disease, we also performed a TB Gold test and Montor test and chest X-ray. But the chest X-ray and the Montor test came out to be negative. But the TB Gold test, which have 100% sensitivity, came out to be positive.
Okay, you mentioned about laser photocoagulation. What are the latest advancements? You mentioned about scatter photocoagulation, right? Any other thing can be done? And which laser was used or what's advisable to be used?
Ma'am, like pan-retinal photocoagulation is done, ma'am. Can be used, ma'am. Scatter.
Any role of targeted laser?
Yes, ma'am. Targeted laser in cases where there is a neovascularization seen, ma'am.
Okay, would you tell me something about staging of EELS disease? Staging of
Staging, ma'am. Okay, the first stage includes ma'am, the periphlebitis stage, ma'am, the inflammatory stage of EELS disease. The second stage includes the neovascularization, starting of the neovascularization stages, ma'am. The first is the peripheral phlebitis. The second is capillary non-perfusion stage, ma'am. And revascularization. The third stage includes the fibrovascular proliferation A, third 3A, and 3B is vitreous hemorrhage, ma'am. And 4A stage is, ma'am, contractional or rhegmatogenous retinal detachment, ma'am. And 4B includes, ma'am, vitreous hemorrhage.
How is this different from
and
the
which
older... How is this different from the older staging?
Ma'am, it includes ma'am, the last three stages are the new one, ma'am, in which they include neovascular glaucoma and tractional retinal detachment also, ma'am.
Okay, you need to read this a bit. Over to any other judges if they would like to ask the questions.
Is there any other question that any other judge would like to ask? Ma'am, otherwise, are you done with your discussion?
Yes, I'm done. I'm done.
All right.
Yeah.
So is there anyone else who'd like to question Doctor here?
Hi, I would not like to ask a question, but I would like to make an observation.
Please do.
For all the people who have presented, that we should very strictly restrict ourselves to time. So if you are given a time for 4 minutes, make your presentation for 3 minutes only, because you never know, you might flounder or do anything. So you can take 1 minute extra. That makes you more confident, and that doesn't put you into a sort of Jeffy to, keep on reading. Another thing
Absolutely.
is, Another thing is, in few presentations, what I saw was they put a lot of theory in it. So if it is a case presentation, we restrict it ourselves to the case, do the DD, how we managed it, and yes, maybe one slide about the theory part in general, but let's not put all the theory in that presentation only, because it is just a case presentation.
So
And
you'd
third
like
point,
them to just speak about the particular topic?
yeah, particular
More
case.
focus more on their findings, their approach, and the way they manage, rather than what the textbooks say about a particular.
Yeah, exactly. Because then it becomes sort of a seminar actually.
Yeah,
And the third thing is, in case you are writing about the right eye and the left eye, it is better to put right eye on one side and left eye on other side, and then write NTA segment, right eye findings, left eye findings, fundus, right eye, left eye, rather than writing right eye, then writing NTA segment and fundus, then going for the left eye, writing NTA segment and fundus. It makes it more comparative. That's my observation.
I think these are very, very important things to be taken into consideration that make anyone's presentation a lot more appealing and a lot easier to follow through for students. Well done, Dr.
Just
Shruti.
one
Well
more
presented.
observation.
I think with
just
this we
one
can
more
come to the end.
One more observation. One more observation.
Could you please repeat your question?
No, not a question, one observation. I
Yes,
fully agree
please.
with what ma'am mentioned. The mobile, it's usually good. There is low and we can't hear the speaker or the presenter very well. So advice to all the presenters, just keep one device on, not multiple devices.
And perhaps also ensure that you have good connectivity, right, to the net. I think that's important too. All right. Thank you very much. Yes. With this, we come to the end of the second session.
With that today somehow.
Sorry, ma'am, were you saying something?
Ma'am, I think she's muted.
Oh, okay. All right. I think, but any which way, we'll have to come to the end of this brilliant second session. I appreciate the contribution of all the students who've taken part, as well as of the judges. Thank you.
Thank you.
Thank you,
Thank
ma'am.
you. Thank you, ma'am. Thank you.
Our next talk will be on the Rare Eye Disease Registry, presented by Dr. Anupama Kiran Kupar. Dr. Anupama has done her fellowship in vitreoretinal surgery from Narayan Nethralaya, Bangalore. She has also trained ophthalmologists in Vietnam through the Vision Mission. Her work has been recognized at numerous national and international conferences, and she has published several papers and also a book chapter. She has received the Amjad Rahi Prize and the Women in Research Award in 2023. Currently, she serves as a consultant at Narayan Nethralaya. We look forward to your insights on this important topic, Dr. Anupama. The floor is yours.
Could I please request all the other speakers to keep their phones on mute? Over to you, Dr. Anupama.
Good afternoon, everybody. I'd like to thank the Mumbai chapter of Women's Ophthalmic Society for this opportunity. I think it's a wonderful opportunity to be able to speak to the postgraduates, because I think that's where you can tap into the youngest minds in our field. And it's an absolutely rare opportunity that I get to do this now. Today, I'll be talking about the RED project, or the Rare Eye Disease Project. Now, before I go into what the Rare Eye Disease Project is, let's talk a little bit about rare eye diseases. Rare eye diseases. So diseases are classified as rare eye diseases when they are about 6 to 8% of the population is affected by them. Having had such a small subset of the ophthalmic disease share, they still are a critical public health problem for two reasons, importantly. One, because it's very difficult to understand their epidemiological distribution. And second thing is, it's very difficult to follow them up, because we, as individuals, have very small data sets. We may have 1 or 2 patients, and really it doesn't give us too much information. Now, the interest in ophthalmic registries has grown over the last year, maybe decade, multifold. And this is because these lacunae, or these gaps in our information, are now very well understood. And there are so many eye disease related registries, especially specific eye disease registries, as well as blindness registries. But when you look at the rare eye diseases per se, the biggest registry is the European Disease Network. There are other disease networks as well, but not too many. There are several individual disease registries. However, if you see the rare eye disease registries, there are none from India. Now, this is a very sad fact, because we have such a huge population. And of course, our access to information is so much more now. This lacunae was identified by Dr. Mohita and team, and a paper was published back in 22 highlighting this. They talked about how a registry is important, and let me talk a little bit about that. So this registry give us help us in improved identification of rare eye diseases, and their benefits are both for the patient as well as for the clinician and researcher. For the patients, it helps in the fact that we can set up support groups for our patients, and we also can have large specific data sets that can then be used to give them access to clinical trials and clinical and newer therapeutics. As far as researchers are concerned, of course, it is a gold mine because you have a lot of dedicated information regarding one particular disease, and it can be used to then direct your research towards newer therapeutics. It also helps us understand some unusual causes of disease that we may not understand with our limited data sets. So keeping that in mind, we set up the Women's Ophthalmic Society Red Eye Disease Group back in 2019. It's basically to establish a registry for rare eye diseases in India, to understand the demographics, clinical course, clinical picture, and so on. The idea is basically to set up a large cloud-based platform for rare eye diseases, to give a common platform to all ophthalmologists. Now, it doesn't matter where you work. You could be working in a single practice setup, you could be working in a government institute, you could be working in a large postgraduate institute. It gives a common platform for us to log in our cases so that we all have information at hand, to find treatment modalities for the and to unify these treatment modalities across board, so everyone across the country gets the same kind of treatment, and eventually, in the larger scope of things, to provide genetic counseling, treatment, as well as rehabilitation. Now, this is how we went about our study. So initially, we identified a couple of diseases that we wanted to study. An ethics committee was set up and formed and clearances were taken. Investigations were enrolled. Now we enrolled 2 team leaders as well as 2 coordinators for each disease group. We set up WhatsApp groups so that these disease groups, these investigators and coordinators could coordinate and build up a proforma. This proforma was basically the proforma that would be used on the cloud-based platform to upload this information. And the team leaders and the coordinators were sensitized as to our aims, to our objectives, and how we wanted to run this study. And then what are the next steps? So now we start with our data entry, and this is where we are at. Each investigator is given a personalized link from which they have access to this online proforma. They can enter their individual patients, and they have access to all of this information, including their images and all of that, in a unified way. Team leaders have access, of course, to all of the group data. The data is compiled and analyzed, and eventually we hope to create a central repository. These were the diseases that we are studying. So we're not only studying rare eye diseases, but we are also studying rarer aspects of more common diseases that have a whole wealth of data to still be analyzed, including myopia and age-related macular degeneration. This is a rough run through of the timeline. So we are identifying patients, then we are getting the data on board. The timelines are now moving a little because, as you can understand, this is a huge study, and there's a lot of coordination that is involved. We did a lot of back and forth, and right now we are at the data entry stage where, again, we encountered a few kinks, but now they've been ironed out. So we are absolutely on the right course. We hope to have preliminary data by October, and probably by the end of the year have some amount of significant clinical data. So this is the link for where you can upload your cases. You need to register with the WOS to be part of this research project. And then you'll be given a username and a password, which will give you access to these templates. You can register for one or multiple diseases, depending on what your practice is. Now, it doesn't matter whether you're a single practitioner or whether you're part of a larger institute. Each practitioner is allowed to enroll individually as well. Beyond this, we also want to expand our study to the genetic aspects of the disease. And why this is because we realize that there's a huge gap in the understanding of genetics, as well as the application and how to go about it in smaller centers or in centers where people are not multi-practice. So in this case, we hope to sensitize the clinicians to how to counsel your patients, how to train them, to train our clinicians as to how samples need to be collected, and to provide a way to store these particular samples. For this, we have tied up with MedGenome. Eventually, this would lead to creating a rather large national repository of genetic samples. We hope to create to provide genetic diagnosis for the currently undiagnosed cases, and initiate newer interventions as well, and provide genetic counseling and rehabilitation to our patients. Now, this is a mammoth task, and we hope that more and more people enroll for it to be more successful. And I think as postgraduates, this is a wonderful opportunity to understand how research is done, When you enroll, you learn to systematically collect data, understand how performers are made, what are the challenges in performing research, and this would probably be a good gateway to the vast world of research, especially for students. So I hope that a lot more of you enroll in this project. Thank you.
Thank you so much. That was really very nice to know that, such advanced research on where it doesn't exist in our country is being taken, is going ahead under the Red Eye Group project. And thanks for giving us the link, and we'll keep an eye. Could you just once more show us a slide of which of the various topics, the diseases that are actually being studied right now? Or just run us through those names again, please? Thank you.
So let me just walk you through that. So these
so
are
that,
the
yeah.
studies right now. So we're doing retinitis pigmentosa, Stargardt's, corneal dystrophies, age-related macular degeneration, normal tension glaucoma, pediatric glaucoma, myopia, as well as ocular tumors.
So what yeah, sorry.
So
Carry
you
on.
can register for either one of the diseases, two or multiple. It does not matter.
Yeah.
Whatever.
My next question, that is going to be my next question. So any of us here or any ophthalmologist in the country who is working on any of these particular diseases can write to you and also be part of the research project?
Yes,
provided
absolutely.
they have the infrastructure to be able to, or you will then counsel them as to how to collect samples and how to send them. And
So
therefore, we can expand your patient base immensely if a lot more people got involved.
Yes, exactly. So this is exactly what our aim is, ma'am. So we have kept our proformas extremely simple, where most of the diseases require very basic investigations, like maybe an angiography at max or a fundus photo or an autofluorescence. Even electrophysiology testings may or may not be mandatory. If we have the demographic data set, we can eventually get back to these patients and get whatever information is lacking. We also have a tie-up with MedGenome for sample collection for genetic testing eventually. So if we have the demographic data, we can get back to your patients. We are also hoping to create programs where we can train clinicians on the basics of genetic counseling so that they can at least do the initial groundwork, and then we can take it over from there. So it's a good learning for clinicians as well.
Okay, lovely. Thank you very much. Thank you very much, Dr. Anupama. It's been an eye-opener for many of us to know that we can also get involved in such amazing research that WOS is carrying out under the RED project. Thank you very much for your time and spending this time with us, educating us about your project. Thank you.
Thank you so much. Thank you for the opportunity.
Thank you. And with this, we come to the beginning of the third session. Over to you, Tanvi.
We are now ready to move on to the third session of the day. I'd like to introduce our new judges for this session. Dr. Modini Pandarpurkar is a professor of ophthalmology at Osmania Medical College and the Regional Institute of Ophthalmology. Dr. Pandarpurkar is also the ARC chairman of the Telangana Ophthalmological Society and General Secretary of the Hyderabad Association of Ophthalmologists. With extensive experience, she has been recognized with the Bhujang Shetty Oration, Rustam Ranji Oration, and Sham Sundar Prasad Oration. She has authored over 20 publications in national and international journals and is a sought-after guest faculty at numerous national conferences. We next have Dr. Professor Lakshmi Singh. She's the professor and head of the Department of Ophthalmology at ERA's Lucknow Medical College and Hospital. Dr. Singh has significantly contributed to glaucoma services, eye bank operations, and ethics committees. She has received numerous honors, including the Distinguished Professor Award by FOTI and the Shrestha Guru Award by OASS. Dr. Singh has over 70 publications in various prestigious journals and has been involved in significant projects related to bioethics and medical education. Our third judge for today is Dr. Pragati Garg. She is the professor and head of ophthalmology at AIIMS Ray Bareilly in Uttar Pradesh with 27 years of experience. Dr. Garg specializes in cataract, oculoplasty, glaucoma, squint, and medical retina. She has performed over 10,000 cataract surgeries and is recognized for her contributions with numerous awards, including the ERA Educational Trust Award and the Distinguished Ophthalmic Professor of India Award. Dr. Garg has nearly 120 publications in reputed journals. We finally have Dr. Ruby Malhotra, who is the professor and head of ophthalmology at Integral Institute of Medical Sciences and Research in Lucknow, with over 20 years of experience in managing glaucoma, cornea, retina, and contact lenses. She has been honored with multiple gold medals in her career and has contributed to various national and international journals. We are thrilled to have these judges with us today, and we now proceed with our third session for the day. We begin with Dr. Sakshi Patel from Nair Hospital, who is mentored by Dr. Gaurav Ghag. Dr. Sakshi, we invite you to begin your presentation.
Yeah, thank you. Good afternoon, everyone. I'm Dr. Sakshi Patel from Nair Hospital, and I'll be presenting a case of interlenticular foreign body under the guidance of Dr. Gaurav Ghag. A 32-year-old male car mechanic presented to the OPD with complaints of watering in both eyes and gradual diminution of vision in the right eye. He did not give history of any recent ocular trauma to eye. On examination, the right eye had vision of finger count close to face with PR accurate. Near vision was less than N36. The conjunctiva was clear with a paracentral corneal scar at 5 o'clock and a corresponding linear iris defect of 2 mm, as seen in the image. The AC was quiet and pupil was round and reacting to light. The lens was cataractous and intraocular pressure was 16 mm of Hg. The left eye was within normal limits. On dilated evaluation, we can see a near total cataract with the foreign body shadow at 5 o'clock position. The fundus was not visible, so we went ahead with a B scan. On B scan, we can see an interlenticular foreign body as a hypoechoic shadow in the lens substance, and the posterior capsule was intact. It's safer to do a B scan in such cases because even a small foreign body with its location can easily be identified. The patient then underwent small incision cataract surgery with intraocular foreign body removal. In this video, as we see, routine steps for small incision cataract surgery were carried out. A continuous curvilinear capsulorhexis was started, but due to raised interlenticular pressure, it had to be completed by capsulotomy. The patient did not have a dense nuclear sclerosis component, and the cataract was quite soft. Therefore, it could be easily extracted by a Simcoe cannula. Over here, we can see the interlenticular foreign body, which was removed for documentation purposes. After the remaining cataractous material was aspirated and irrigation aspiration was done, the posterior lens capsule was found to be intact. Therefore, a PCIOL was put in the back. Over here, we can see a 1 by 0.5 mm metallic foreign body, which was extracted from the cataractous lens. Post-operatively, the patient was doing quite well with a vision of 6/6 and minimal congestion and minimal subconjunctival hemorrhage. As we see here, some of the previously noted foreign bodies in the lens, anterior chamber, and cornea were retrieved by extracapsular cataract extraction. In these cases as well, the posterior capsule was intact, and therefore a secondary intraocular lens could be placed, and the patients were doing well post-op. Our case was different as the finding of the foreign body was incidental and that the presenting complaints were not related to the trauma or foreign body. The fact that a corneal scar was seen with a corresponding iris defect and in a young male with a cataractous lens would raise suspicion of a foreign body. It is therefore important to thoroughly examine such cases.
Thank you, Dr. Sakshi. I'd like to invite Dr. Lakshmi Singh. Okay.
It's still.
All right, sorry.
As we know, ocular trauma is a major cause of morbidity in the working population, and a penetrating injury can cause blindness. Such cases need to be confirmed and thoroughly examined with a B scan, a UBM, or a CT scan. The decision to remove the foreign body should be based on the degree of cataract or any complications like uveitis or a raised intraocular pressure, which need to be concurrently treated. An urgent intervention is needed if the foreign body is metallic in nature or a free floating lens matter is present, especially with an endothelial touch. Thank you.
Thank you, Dr. Sakshi. I'd like to invite Dr. Lakshmi Singh to lead the discussion in your case. Dr. Lakshmi.
Yeah, hi. First, I'd like to congratulate Dr. Sakshi. Very nice presentation. Yeah, and I would like to ask, like if this case was, if this case was missed, like it was an inert foreign body, then what are the complications that you will expect in such a patient? If he say after a 15 days or month, he comes back to you, what do you expect he will present with?
Ma'am, since this was a result, since he was a car mechanic, so most likely the foreign body would be metallic, like iron or steel, which is commonly seen with hammering and power tool use. It could cause siderosis eventually, like if the foreign body would be present long term. It would lead to discoloration on the cornea or the iris, or it would cause anterior lens capsule discoloration as well as cataract. And if the foreign body reaches the retina or the vitreous, then vitreous bands are seen, liquefaction is seen. It can cause hemorrhage on the retina or detachment as well.
Okay, good. Can there be a condition where an inert intraocular foreign body can be, left as it is, and we are not going to touch it? Can you think of such a situation?
Ma'am, an inert foreign body, usually it would just lead to encapsulation because of natural foreign body reactions by the body. But if it's not causing any visual uncomfortable to the patient, if it's not uncomfortable, then, and if it's not caused cataract, then we can wait and watch.
Yeah, that's exactly what I wanted to tell, because this is controversial. Sometimes intervening can be more disastrous to the patient, waiting and seeing how the foreign body is reacting. That also gets important. So you talked about siderosis bulbi. What can you tell me about it?
Ma'am, siderosis is usually caused by iron or steel, wherein the material of the foreign body will dissociate, and it will combine with the intracellular proteins and lead to cell death, which eventually can be seen as different signs as I described.
Okay. And whenever we are suspecting an intraocular foreign body, what are the various investigations that you would suggest? Like, this was a different patient, but in case the patient comes with a history of, retained intraocular foreign body, so how is going to be your plan of approach to this patient?
Ma'am, first of all, we need to know what foreign body it was. If the patient knows, it's well and good. But since it could be metallic, so an MRI would definitely be contraindicated. We'll start with the basics like slit lamp examination first. If it's not visible on slit lamp, we can do gonioscopy in case it could be in the angle or somewhere which can be missed on slit lamp. And further, we can do our regular dilated evaluation. If it's not visible on that as well, we can go ahead with a B scan or a UBM or a CT scan.
Yeah, good. So any other judge wants to take any question?
We still have another minute. If there's anyone else who would like to ask a question. Otherwise, ma'am, if you could, yeah, sorry, carry on.
I don't have a question actually. I want to congratulate you on a very good presentation, Dr. Sakshi. And just wanted to give a message to the residents that when you see a young patient with a uniocular cataract, no systemic things, please search for a foreign body like in their case. It could be an incidental finding. Patient might not remember the trauma. So this is one more to add to your list of complicated cataracts when you see uniocular, especially in a young patient, so that you may avoid unnecessary complications while tackling the case. Thank you so much.
I have a question. Actually, I just wanted to ask Dr. Sakshi, why did you opt for SICS rather than phacoemulsification? Along with as it is, it was a soft cataract. You could have easily gone with a small incision of a phaco rather than going for a large incision of SICS.
Yes, ma'am. Because since this is a medical legal case and we need to see the foreign body and for documentation purposes and to show the patient as well, this is what we've retrieved. It is important.
Yeah. Continue.
I think
that's why, ma'am, it's important to go ahead with a small incision rather than a phaco, because it would just get lost in the. It would be difficult to retrieve.
The rest of the cataract would have been removed by the phaco probe, but the foreign body could have been picked with a McPherson forceps and removed with a small incision also. It was not a very big foreign body. Just my suggestion.
Yes. Okay. Yes, ma'am.
All right. Thank you, Dr. Sakshi. With this, we move to the next talk.
Thank you.
We now invite Dr. Monica Shahare from Cooper Hospital. She is mentored by Dr. Charuta Manke. Dr. Monica, we invite you to begin your presentation.
Yes. Good afternoon, everyone. I'm Dr. Monica Shahare, junior resident at Cooper Hospital. And I will be presenting today a rare case of pediatric hydrocytoma under the guidance of Dr. Charuta Manke, additional professor at Cooper Hospital. Parents of 10-month-old female child presented to the ophthalmology OPD with the chief complaints of painless, progressive, left eye lower lid swelling of 2-month duration. There was no history of trauma or any ocular disorder. On clinical examination, there was single round swelling over the left eye lower lid. There was no tenderness, no redness, and transillumination test was positive. There were no fixation to the overlying skin or deeper plane, and it measured approximately around 3 into 2 centimeters. Right eye anterior segment was within normal limit, with left eye anterior segment also a normal limit. Both eye extraocular movements were normal. So we get to the clinical diagnosis of the venolympangioma or the venolymphatic malformation was made. So we headed to the imaging. We done MRI brain plus orbit, plane plus contrast, and it is suggestive of the hyperintense cystic lesion, well defined at T2 and STR, arising from the lower lid, measuring around 14 to 17 into 16 mm, with partial separation on FLAIR images. There were no diffusion or restriction or blooming is seen within the lesion, and lesion is having the extragonal extension with a mass effect on the lower aspect of left eye lobe with inferior rectus muscle. There were no involvement of the left eye claw, and the imaging differentials were offered: venolymphatic malformation, sebaceous cyst, dermoid cyst, and accessory sweat gland lesion. So, with the clinical diagnosis of venolympangioma, patient underwent the cyst aspiration and sclerotherapy with bleomycin. The first image is at the presentation with the lower lid left eye swelling. And after the first aspiration and sclerotherapy, there were no swelling seen. But within the 1 month of duration, there was the recurrence of the cyst at the same site. So we again went for the second attempt of the cyst aspiration and sclerotherapy with the bleomycin. And post-op there were no swelling at that site. And within the 1 month of duration, the same swelling were recurred at the same site. So at this stage, we were sure that our clinical diagnosis can be wrong, and our two failed attempts of the cyst aspiration are going into the wrong direction. So at this stage, we went for this left eye orbital cyst excision with biopsy. And this was the last image after the cyst excision. Pathological examination, it is suggestive of cyst lined by the double layer of epithelium. The luminar layer shows the columnar epithelium containing a full goblet cell and outer myoepithelial cells. Wall shows the layer of smooth muscle, focal lymphocytic infiltrate seen in the wall. There were no evidence of the atypia or malignancy, and it is suggestive of apocrine hydrocystoma. So we got the diagnosis of the apocrine hydrocystoma from the venolymphatic malformation. So let's get into the discussion.
30 seconds.
Yes, ma'am. These are also called as the cyst adenomas or the pseudoreferous cyst or the mole gland cyst. These are of two types, eccrine and apocrine hydrocystomas. These are just benign, slow-growing asymptomatic tumors, and it occurs around the head neck region, face or scalp, and commonly over the eyelid. It is more common in the adults around the 30 to 70 years of age, and it is very rare in the childhood or adolescent. Prevalence is same in the male and female group. Eccrine hydrocystoma are due to the obstruction of the eccrine sweat glands, and apocrine hydrocystomas are the adenoma of the coil structure of apocrine sweat glands. So we are at the conclusion. My conclusion is that this is the atypical presentation of apocrine hydrocystoma, rare and usually seen along the eyelid margin. Hydrocystomas may occur in the orbit and should be included in the differential diagnosis of the orbital cyst, and it is managed only by excision, and clinicians therefore be aware of this presentation. And in spite of the failures which were tiresome for the patient and also the child, but because of the good counseling and trust in the treating doctors, patient did not lose hope and got the appropriate treatment. So it is important to build a good rapport with the patient and relatives, and will keep trying to get desirable result in the best interest of the patient. And after 1 year of the follow-up, swelling did not occur. Thank you.
Thank you, Dr. Monica. I'd like to invite Dr. Pragati Garg to discuss your case.
Okay. Dr. Suvira, nice presentation. Of course, atypical presentation of hydrocystoma because they are usually very small and rarely orbital hydrocystomas are seen. Why didn't you consider it as a case of dermoid? Because that is very commonly seen. It's such a large tumor in the lower lid in a child. You could have easily confused it with a dermoid. And transformation, I feel, was it actually present because it appears to be quite deep from the superficial surface? What was the main diagnostic criteria for you to diagnose it as a lymphatic tumor?
Ma'am, with the presentation of the first decade, and it is more common in female, and like most common presentation in the first decade and in the child, it can be the congenital. So we thought of having the venolymphatic malformation, and with the clinical features are going into the venolymphatic malformation.
What were the clinical features favoring that?
Ma'am, bluish appearance of the cyst, and the clear fluid, and also the transillumination test was also positive.
And on CT scan, the picture was of some vascular malformation. Why didn't you keep the cystic sarcoma as a differential diagnosis for that?
Ma'am, there were no history of suggestive.
Okay. Actually, I had a recent case like this only, but that came out to be cystic sarcoma, and that was very common in that area, being endemic in India. So I always think that that should be also be kept in mind. Will your treatment be different if the other differential diagnoses were there?
Yes, ma'am.
The management part, apart from the sclerotherapy?
Yes, ma'am. The cyst excision only, the surgical, like we went for the less invasive or non-invasive, less invasive treatment for the child, not the surgical. So we first tried the non-invasive or less invasive treatment.
Okay. Had it been left over there, what all problems it can lead to a child related to vision?
Ma'am, the increase in size of the swelling can lead to the cosmetic malformation, and also the corneal.
It was a large growth. Wasn't it compressing the globe and the cornea? It can lead to astigmatism. It can lead to amblyopia in a young child. I think that was a very easy thing. I don't have any more questions. If any other judge want to ask any question.
We still have another minute of discussion left. If there's any other judge on this panel, I'd be happy to take another question or another point of discussion with Dr. Monica.
May I ask a question?
Yes, please, ma'am.
I would like to congratulate both of you for bringing out the case and being bold enough to go with openly accept that your diagnosis was not correct. That is the way forward, and that is the best way to be a scientist. So that is the best way. I just want to have a small question. Why you did not consider excision in the first floor? It was so superficial, transilluminant, and quite large, sitting on the inferior rectus blue. Why was that not considered? The second question is, when you aspirated the fluid from the cyst, did it add to your diagnosis? Because bleomycin is very toxic, especially in a child below 12 years. It is given with lot of caution. A lot of caution, actually. Was the fluid which you aspirated the color of altered blood or something for you to corroborate your diagnosis of a venolymphatic or a venous malformation? And if it was not, did you reconsider to go with triamcinolone injection instead of bleomycin on the table?
Ma'am, first of all, with the child, 10-month-old, we went for the less invasive technique. And you asked for the another method, like
I beg to differ. Bleomycin is not less invasive, frankly. Very invasive. Yeah, continue. What was the color of the fluid you aspirated?
It is a serous fluid.
Serous.
So
It was
clear.
sanguinous or it was not
No,
not
no.
altered blood. So maybe you could have considered a retention cyst or something at that time with the nature of the fluid and altered your management to triamcinolone instead of bleomycin, which is quite toxic and irritant. I mean, at your stage, and I see a very young, enthusiastic person, Charuta also is quite young. It is a good way to learn, but maybe in the next case, you will also keep your mind open for it is not a venolymphatic or a venous if the fluid is sanguine and serous. You should think of other things. Maybe, yeah, Dr. Charuta, I would love to take your
What
listen to
happened
you.
is, yeah, it was I wanted her to present, and I said, let's present it as a failure because this can happen with
Failure,
anybody.
no, please, it is not a failure. It is a step in learning.
No, because it was we gave two
Step in
injections.
learning.
So, but the first time it was serosanguinous and it was blood tinge. So we became a little more sure that, and we thought that maybe it has recurred, and we used a very so we had an oculoplasty surgeon do it, and we used a very lower concentration of the bleomycin. At that time, unfortunately, the child was not becoming fit for surgery in the municipal setup. And so we went in for this. I do agree that maybe the next time we could have tried triamcinolone, but we got caught in our initial diagnosis.
Yes.
And then
Yes.
when it recurred, we thought that let us just excise it because it doesn't seem to be, what we thought. Because the
Yeah.
next time the fluid was not serosanguinous. So then we and there was no histopathology. So then we did that and we found the real reason. And thank you for pointing out the cysticercosis also, madam.
All right, thank you. That was an excellent case and an even more excellent discussion. Thank you, Monica, for a good presentation.
Thank you, ma'am.
Our next presentation is by Dr. Sariki Maheshwari from DY Patil Hospital. She's mentored by Dr. Sumita Karandikar. Dr. Sariki, we invite you to present your case.
Yeah, thank you, ma'am. Good afternoon, everyone. I'm Dr. Maheshwari, a third-year resident from DY Patil Hospital, Navi, Mumbai. So I'll be presenting about a rare and anomalous case of Frazen syndrome with acute on chronic dacrocystitis. So coming to the case history, it is an 8-year-old female child with mother being as informant, present with the chief complaints of swelling over the medial canthus region of the left eye since 1 month, which is recurrent in nature. The swelling was associated with redness, pain, and gradually increase in size. The child also complained of mucoid discharge from both eyes since birth. On examination, vision was 6-6, eyes was in orthophoric position, central circular reactive in light. On anti-segment examination, there was severe congestion in the left eye and extraocular movements were full and free in all the directions. The child started on topical antibiotics and the swelling was noted. After which the sac syringing was done, which showed a both eye mucoid discharge, regurgitation from the lower punctum. On further examination, there was ocular hypotelorism, complete absence of the upper punctum, telecanthus and small and almond-shaped eyes. On external examination, as you can see in the first picture, there was frontal bossing, broad and depressed nasal bridge, small nares, and small and upturned lip. In the second picture, there's syndactyly, which is a fusing of the fingers of both the hands, clinodactyly, which is an abnormally curved finger of the index finger, and syndactyly and clinodactyly of the right feet. As there were some abnormalities and dysmorphic faces, we suspected a syndromic association. So the following investigations were done. USG abdomen showed evidence of absence of right kidney and hydrocalpus associated with imperforate hymen. CT orbit with PNS was done, which showed a well-circumcised hypodense round lesion along the inner canthus of the left orbit, with adjacent soft tissue thickening and fat stranding, with mild mucosal thinning of all paranasal sinuses, which suggested an acute dacrocystitis on the left side. Initially, gene karyotyping was done, which showed a 46XX normal female chromosome component. Later, a whole exome genetic sequencing was done, which showed heterozygosity for a likely pathogenic variant in the FRSA1 gene associated with the Frazen syndrome type 1. Based upon the clinical examination investigations, we came to the conclusion of a diagnosis of a case of Fraser syndrome with congenital dacrocystitis with an episode of acute dacrocystitis in the left eye. Based upon the examination and investigations, we ruled out other differential diagnoses like Craig-Cephalopolysyndactylic syndrome, Wolff-Hirschhorn syndrome, and frontonasal dysplasia. So, coming to the treatment, the child has been started on topical and oral antibiotics for the acute dacrocystitis in the left eye. And as the acute episode has reduced, we operated her on right eye dacrocystorhinostomy. And after 1 month, as the acute inflammation of the left eye has completely subsided, even the left eye dacrocystorhinostomy was conducted. The child has surgery planned for syndactyly release and hymenoplasty. So coming on to an overview, Fraser syndrome is a rare congenital disorder characterized by severe malformations that are present at birth. It follows an autosomal recessive inheritance. It is associated with gene mutations in FRSA1, FREM1, FREM2, and GRIP1 gene. It is subdivided into 3 types, 1, 2, and 3, based upon the genes and symptoms involved. And the FRES1 and the FREM2 genes are involved to produce proteins, and these proteins play a vital role in development of the skin and other internal organs during the intrauterine growth of different tissues. So, Fraser syndrome is commonly associated with different physical abnormalities like syndactyly, cryptophthalmus, abnormal genitalia, renal agenesis, congenital nose and ear and larynx abnormalities, umbilical hernia, mental retardation, and skeletal defects, based upon which we can divide them into a different major and minor criteria for our final diagnosis. In our case of Fraser syndrome, along with some of the major abnormalities, there is also association of lacrimal drainage anomaly, which is a very rare occurrence in Fraser syndrome, and to our knowledge, it is the first case to be reported in Asia. So, Fraser syndrome can be diagnosed early with a prenatal sonographic diagnosis, but in India, being the knowledge about the Fraser syndrome is less, it is usually diagnosed at birth based upon the signs and symptoms seen in the child. Genetic testing for the mutations in the gene can be confirmed for the diagnosis of the Fraser syndrome, and there's currently no exact treatment for Fraser syndrome. Treatment of FS may include surgery to correct some of the abnormalities associated with disorder, depending upon their severity and also their complications later. These are my references. Thank you.
Thank you, Dr. Maheshwari. I invite Dr. Mudini Pandarpurkar to lead your discussion.
Hi, well done, Maheshwari. It was
Thank
a good presentation, very elaborately investigated, actually, though I know genetic testing is very costly, but in the interest of science, you've gone ahead and convinced the patient. Two things I wanted to ask you here. Why is there a nasolacrimal duct abnormality? Can you throw some light on that? What happens at the embryology stage? Because the learning experience here is you must review your embryology of the NLD formation and what goes wrong in the Fraser syndrome. Basically what happens in the Fraser syndrome? Why do you get a NLD block?
Ma'am, and actually in Fraser syndrome,
where was the block?
Ma'am?
Where was the block?
Ma'am, the block was in the nasolacrimal duct, ma'am,
Yes,
in this patient.
Good.
So, ma'am, we basically think because of, as the patient is a case of Fraser syndrome, there was abnormality in the formation of the nasolacrimal duct. We think even the canaliculi formation was not proper in this because there's absence of the upper punctum. So even there's an absence of one, we feel there's an absence of one canaliculi and there's no proper formation of the duct in this patient.
But you could do syringing. You did syringing
Yeah,
from
ma'am, we have done the syringing.
from
So
upper punctum?
no, there's no upper punctum in this child.
Just got regurgitation from the lower punctum.
Lower punctum, mucoid regurg from the lower punctum.
Okay, of the thing, and you got a acute on chronic dacryocystitis.
Yeah.
Did you find any bony abnormality when you were, can you throw a little light on the embryology, how the NLD forms? Because that is what we need to look at here. Any syndrome can affect the formation of the NLD in a proper way. And in other cases also of NLD blockage, it is necessary to understand the embryology, what type, at what time it happens. So how does the NLD form? Can you tell us? Embryologically. So it forms the maxillary cleft and the frontonasal prominence both come together, grow towards each other, and between those two is the cleft, and which later becomes a NLD. You know that one part is lower part and upper part form separately. The lining is also separate.
Yes, ma'am.
And maximally the blocks are at the NLD level. Especially if you have a sac swelling in your case with this thing, it means that up to sac the fluid is draining and there is no further.
After the initial statement of the NLD, there would be a block.
Yeah. So did you notice any abnormality in surgery when you were doing a DCR? Did you notice?
Actually, because of the
for it to plan your DCR in a slightly different way, intubation or whatever?
Ma'am, actually
कोई और आएगा, मुझे फॉर्मेलिटी में हाय हेलो करना पड़ेगा ना, अभी बीच में बस 10 मिनट का है, मेरा पार्ट खत्म हो गया.
Ma'am, actually,
Could
we
the
have
others please mute their, could all the others please mute their mics? Please carry on with the discussion.
Ma'am, actually, we have done a previous ENT people have done an endoscopy for her to know the room in the nasal structures. They have told us that there have been decreased space in the nasal thing, and while doing the surgery, we have faced that the nasal bone was very thick in the patient, so it took us very long time to create an opening in the nasal in the lacrimal bone of the lacrimal crest, and there was a pretty much bleeding in the patient. I think so in the child, and there were like the vessels also were not properly formed in the child. And we thought if there is a recurrence again, we can use a silicone intubation in this patient because the next time any recurrence happens again.
Why didn't you plan it at the first go? Because it's a child and saving another GA, or did you anticipate any abnormality in the bony thing? And
Ma'am, we thought there could be any abnormality, so we wanted to put a second chance. That's why we did not plan a silicone intubation in the first chance.
all right. Yeah, any other judge, any other comment?
We still have about 45 seconds. If there's anyone else who'd like to say something, thank you.
Am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah. Yeah. Sariki, so congratulations. It was a wonderful presentation.
Thank you, ma'am.
Only question is that did you perform cryocystography or something, a study of the
No,
tract?
ma'am. DCG and
Nothing like
DSG
that.
were not available at that time. So we
Yeah.
tried to perform a DCG, but
Yeah.
it was not available at that time, so we couldn't do it.
Okay. So that was one, because that would help in locating
Yeah,
the
DCG
actual
helps us
tract, and
to, yeah, yes, ma'am.
during surgery also it would be helpful. And the second thing, as ma'am suggested, was very right, that intubation would have been a good thing to do in the
Silicone tube
first go. As
intubation.
it was in a small child, there are chances of failure.
Yes,
But
ma'am.
otherwise, on the whole, it was a nice presentation. So congratulations.
Thank you.
Dr.
Thank
Maheshwari,
you.
can I say something?
Sure, ma'am. Please
Yes,
go
sure,
ahead.
ma'am. We are waiting.
Okay, nice presentation, Maheshwari. And it was actually a diagnosis was very nice, a very unique one of Fraser syndrome.
Yes, ma'am.
Actually, I would like to suggest you something. If you're going for the publication of this case report, go for the mention the other phenotypes which were also there on the face. As I could see on the picture, there was a broad, there was a flat nasal bridge, there was telecanthus. Point out all the facial phenotypes, all the body phenotypes. That will actually be helpful for the other researchers to collaborate it with this syndrome. May or may not be present in other cases.
Sure,
But
ma'am.
actually, you should go for all the phenotypes. Go through the books. What are all you can look for?
Yes, ma'am, sure.
And then present it.
It will be helpful for the diagnosis in the future also, ma'am.
Actually, yes.
Yes, ma'am.
Thank you.
Based on that, your side, was it a child of a consanguineous union?
No, ma'am, it was a non-consanguineous marriage.
It's autosomal recessive.
Our
So
first query was that because Fraser syndrome is very much associated with consanguinity, but in our case, it was a non-consanguineous marriage.
Being autosomal recessive.
Yes, ma'am.
All right. So I think with this, we come to the end of the discussion. Thank
Thank
you,
you,
Dr. Sariki. Great discussion, great presentation. Let's move to the next, Tanvi.
We invite Dr. Priyanka Menon to present her case. She's from Levi Patil Hospital and is mentored by Dr. Archana Tadwalkar. Dr. Priyanka.
Yes, ma'am. Good afternoon to everyone. I'm Dr. Priyanka Menon. I'm going to walk you through a holiday that completely went wrong. Sorry, ma'am. Yes, ma'am. A case of a retinoblastoma masquerade. A 5-year-old male child was brought to the casualty by his parents with complaints of redness, swelling, associated with pain, watering, photophobia. There was no history of any fever, trauma, or injury. On examination, this is how the right eye looked. The right eye had vision of PLPR inaccurate. The lids were edematous. There was severe congestion, chemosis. Hypopion was present. Rest details were not appreciable, and the intraocular pressure was digitally raised. At this point, the left eye seemed, however, normal. We admitted the child and continued further investigations with respect to blood parameters and ultrasonography of the eye, which revealed few vitreous echoes and few hemorrhagic calcifications in the right eye. And this was not conclusive of any diagnosis at that point. We started the patient on topical medications and systemic medications as well. The plan was to conduct the examination under anesthesia and fitness under general anesthesia. The child was, however, referred to a higher center for further management, where also the initial examination was performed. A complete detailed birth history was taken. The initial treatment at this stage was again to deal with the anti-glaucoma treatment in view of dealing with secondary glaucoma, and steroids were also started in view of dealing with the picture that presented with the orbital cellulitis. 1 week later, the child looked like this. He was normal, he was better, he was cooperative, and the child was taken under examination of under anesthesia for the due course of the treatment. In the first examination of under anesthesia, the right eye showed a disorganized globe. The cornea was hazy. There was no view possible. Intraocular pressure, despite anti-glaucoma medications, were quite high, and the left eye showed a small lesion. At this point, we were dealing with a painful blind eye with a suspicion of tumor. There was no visual potential. Biopsy was risky. We underwent with radiological investigations. We did serial MRIs and CT scans. There was no optic nerve involvement whatsoever present. At this stage, we decided to conduct the second examination under anesthesia. The left eye showed the lesion that was present in the left eye was dealt with a cryo application. The right eye, however, was not responding to any treatment. There was a strong clinical suspicion of intraocular malignancy, and the decision would be diagnosed only on enucleation followed by a histopathology. So we proceeded with the enucleation of the right eye. On enucleation and histopathology of the right eye, we found tumor cells with rosettes, with necrosis and degenerative changes of the tumor cells on the histopathological slides. It was also found at the area of the optic disc. There was a focal point present. However, there were no tumor cells found at any orbital fat, optic nerve, soft tissue, or any iridocorneal angle, which ruled out high-risk areas. The diagnosis was retinoblastoma mascarade. It was bilateral. Right eye was group E, left eye was group A. The further management, however, was supposed to be enucleation was already done. For the left eye, we planned no adjuvant chemotherapy as there was no high-risk area involvement. There were subsequent EUAs conducted. In one of the EUAs, the lesion in the left eye showed increase in size and presence of fluid, and cryo could not be performed. At this stage, a tumor board meeting was conducted, and they decided to proceed with adjuvant chemotherapy. 6 cycles of vincristine, etoposide, and carboplatin was given to the child. The child tolerated it well. This was the timeline of the course of management of the child, and with each cycle of chemo, the lesion in the left eye seemed to be reducing. This is the last cycle of the EUA that was conducted after the chemo. The lesion in the left eye is now flat, and there is no presence of any subretinal fluid at present. Thank you.
Thank you, Dr. Priyanka. I'd like to invite Dr. Ruby Malhotra to lead the discussion in this case.
So congratulations, Priyanka. It was an excellent presentation. And as you know, and all of us know, retinoblastoma, it's a burning topic, one of the most deadly disease that nobody wants in the children, but still the most common malignancy. So my question was that because it was a case of bilateral retinoblastoma, would you like to throw some light on the genetic influence and what is the Knutson's theory related to your genetic retinoblastoma?
Yes, ma'am. Ma'am, retinoblastoma is the most common primary intraocular malignancy in childhood. Basically, according to the studies, 94% of the cases of retinoblastoma are basically found to be sporadic, and rest of the 6% are attributed to be familial. So there is Knutson's two-hit hypothesis, which states that for the germline mutation of retinoblastoma, you need at least 2 chromosomes contributing for the same. And the 6% of the cases that involve familial pattern basically have a RB1 gene mutation, and that is located on the 13q14 chromosome arm. We actually tried doing a genetic test for the child, but it did not come positive.
So it was not positive in this case, but in most
No,
of the cases, the genetic thing is positive, and only a single
Yes,
mutation can affect in your familial.
Yes,
The reason to, I'm sure, know why. So another question of mine was that because it was presenting as a masquerade syndrome, which is not very common, do you know which type of retinoblastoma mimics masquerade syndrome? Some sort of inflammation? Which type of...
Ma'am, atypical retinal.
Rather than atypical, I would say that it is, there is an exophytic type, there is an endophytic type, and then you have the diffuse infiltrative type.
Ma'am, mostly diffuse infiltrative type goes into, yes.
So that is why, because your most probably your case must have been the diffuse infiltrative type. That is why in your radiological investigations also it was not very clearly coming. So that might have been the case. Another question that I have for you is that how will you differentiate? In your case, the cornea was very hazy. So you were not able to make it about actually look into the inflammatory part of your masquerade. It was more a
pseudo-hypopion.
Yeah, so pseudo-hypopion. My question is more practical. How would you differentiate a pseudo-hypopion that you see on examination? Pseudo-hypopion is something that you see in cases of anterior involvement or anterior uveitis mimicking retinoblastoma, but you have posterior uveitis mimicking as well as pseudo-orbital cellulitis type also.
Kind of.
So, how would you differentiate the hypopion from the pseudo-hypopion clinically on examination if your media would have been hazy?
Ma'am, given that the media wouldn't have been hazy, the hypopion normally seen is usually yellowish in color. It is more fixed. The pseudo-hypopion is usually whitish, dirty looking like hypopion, and it could be diffusely spread. It doesn't show the ma'am, except one of the cases that I went through, there was a case reported, which is a 17-year-old male who reported with a pseudo-hypopion, which looked like a hypopion fixed, and the child was found to have a retinoblastoma.
Very correctly, you said that it is more moving and it is whitish in color.
Whitish
most of the cases, but then again, we cannot exclude just by the color. So we should ensure whenever we come across a child, especially in this age group of 1 year, 2 years, it should be. Now, what about the vitreous infiltrates? How will you differentiate the vitreous infiltrates of retinoblastoma? Just in case the patient has posterior uveitis masquerading as posterior. So how will you differentiate? Can you throw some light?
Ma'am, in retinoblastoma, usually the vitreous seeds are more depends on the group. In the group C, the vitreous seeds are more localized, and in the group D, they are more diffuse. They usually are along the vessels or the subretinal fluid that accompanies it, as compared to other diseases like Coats disease, where the vitreous seeds are more diffusely spread, and you cannot really make out the vessel along it or the
so they are more aggregated into clumpy deposits into the vitreous. Those are and then apart from that, of course, you'll have calcifications if in case they are visible.
Yes,
so very nice. I would like to open it for others also. Any other respected judge with any questions?
Sorry, I seem to be intruding on everyone's thing.
No, you're most welcome, ma'am. You're most welcome.
It's a burning topic and it is a very, very lethal tumor in childhood, and we would like to, did you not consider neoadjuvant chemotherapy in the first go? Because as you said, other eye also was affected. So could you have done the enucleation after the neoadjuvant chemotherapy? Why did you not think of a retinoblastoma, especially with so many calcific spots in your B scan? That is the hallmark. So could you have tried for neoadjuvant for the other eye? There was I'm not sure if I'm correct, but there was a little delay in treating the other eye or looking at the other eye. That is something which has to be corrected and which has to be dealt with on a war footing. It is a very severe, it's a malignancy.
Yes, ma'am. Yes, ma'am, if I may. Ma'am, actually, this case through and through was a debate between the radio team, the onco team, the pediatrician, and the ophthalmologist. Basically, the practical problems were that we were dealing with a very painful blind eye, and the radiological.
ये बच्चे लोगों को तीनों खाना दो इसको आईवी का.
I'm so sorry, ma'am. May I?
Carry on, Priyanka.
Yes, ma'am. So basically, ma'am, what happened is that the first thing to do was basically deal with the painful blind eye, and the other eye, the left eye, basically had a lesion which was of a group A category, which could be dealt with a local therapy. So we did not at that point think of a adjuvant chemotherapy. A tumor board meeting was conducted, and they were also of the opinion that 6 cycles of chemo would be a lot to subject the child to, and we can maybe enucleate the right eye and go for the local therapy with the left eye. And that was what was done until in one of the EUAs we found that there was subretinal fluid, cryo was not possible, and the lesion seemed to be increasing in size. That's when again a tumor board was conducted, and neoadjuvant chemo was considered.
I think
All right.
SRF and calcifications are red flags, and maybe tumor board was, and each institute has its own pattern of dealing with it. But I think maybe a referral otherwise with all the time lapses here. And I beg to differ that painful blind eyes because of retinoblastoma, the treatment, yes, definitely you can give anti-glaucoma and steroids, but surgery is the primary management there for the right eye. And the left eye, chemotherapy, maybe intraarterial chemotherapy also would have worked, because one-eyed patient, you can't really, I mean, I'm very, very sensitive about retinoblastoma.
Yes.
Thank you, ma'am. Thank you, ma'am, and thank you, Priyanka, for a good presentation.
Thank
Brilliant discussion all. So with this, we come to the end of the third session, and we are about to commence our fourth and final session of the afternoon. Tanvi, over to you.
Thank you all, and bye-bye.
Thank you, ma'am. Thank you.
so much.
Bye-bye.
Thank you. Bye-bye.
Thank you to WOS, and thank you everybody for providing this wonderful opportunity. It was an excellent academic platform.
Thank you, ma'am. Thank you.
We now begin with our fourth and final session for the day. It is my pleasure to introduce our esteemed judges. Firstly, we have Dr. Subneshwari Ganesan. She is a senior consultant and professor of ophthalmology at Sankara Nethralaya. She specializes in vitreoretinal and ocular oncology services. She holds fellowships from Sankara Nethralaya, the National Cancer Center in Japan, and Kindai University in Japan. With 15 years of experience, she has published 59 articles, authored textbook chapters, and served as a co-investigator in international trials. Dr. Ganesan has delivered 60 invited talks globally and is a prominent reviewer and thesis guide. We next have Dr. Sujata Lakhtakia. She's an associate professor of ophthalmology at SS Medical College, Rewa. She has completed her MS from Kanpur and a short-term fellowship in medical retina from HV Desai, Pune. Her areas of interest include glaucoma and medical retina. She has published over 50 articles, presented numerous papers, and received awards for her contributions, including the Best Female Presenter at the MP SOS Conference. Thirdly, we have Dr. Alka Gupta, who is a professor at the LLRM Medical College in Meerut. With 40 years of experience, Dr. Gupta focuses on cornea and eye bank services. She has been recognized by DBCS for her work in blindness prevention and has published over 50 scientific papers. She has also supervised more than 100 theses and presented 180 scientific papers at various conferences. And lastly, we have Dr. Bhavna Sharma, who is a professor and head of ophthalmology and dean of examinations at AIIMS Bhopal. Dr. Sharma specializes in cornea, ocular surface, and cataract services. She completed her training at Dr. RP Center in AIIMS Delhi and has over 100 publications, including a reference textbook on corneal emergencies. Dr. Sharma has received numerous awards, including the Shishir Samman, and is active in various editorial and review boards. We are delighted to have these distinguished judges with us. Let us proceed with our fourth session for the day. We begin our session with Dr. Venya Sharma from MGM Hospital. She is mentored by Dr. Shivangi Singh. Dr. Venya, the stage is yours.
Thank you, ma'am. So I'm Dr. Venya Sharma, PG third year from MGM Navi Mumbai, and I'll be presenting my case on basal cell carcinoma with lateral cancer's presentation and its management. It's called Cornered by Cancer, and under the guidance of Dr. Shivangi. So a 54-year-old female came with the chief complaints of small mass growing at the corner of the lower eyelid over 2 years, with gradual progression in size and painless in nature. Occasional bleeding was present, but there was no associated discharge or diminution of vision. On ocular examination, the head posture was normal, facial symmetry was present, EOMs were free, full, and painless in all gazes of both eyes. Best corrected visual acuity for distant was 6.6 and N6 for near vision for both eyes. And IOP was 14 mm of mercury for both eyes on GA. The lesion itself measured 15 mm horizontally and 5 mm vertically with pearly, shiny margins and rolled out margins with central ulceration, madarosis, and telangiectasia was associated. And the lesion itself involved the lateral canthus. On palpation, the lesion was firm and non-tender and immobile. Anterior chamber was quiet and of normal depth with a clear lens, and the pupil was round, reactive, and regular. On posterior segment examination, it was unremarkable with a healthy neuroretinal rim, 0.4:1 CD ratio, and a normal macula. The regional lymph nodes were palpated and were found normal. The investigation that was done was of MRI orbit and MRI brain, where there was no orbital involvement or no cranial extension of the lesion. So according to the history, the clinical picture and investigation, a diagnosis of basal cell carcinoma was made, and the management was as follows: complete surgical excision using more surgery, lid reconstruction using Hughes technique, and then the histopathology of that particular lesion. So in this, the lesion was first excised using a 15 number blade and with free margin, and the entire lesion was sent for frozen section. Once it was confirmed that the margins are tumor free, then the defect was measured and then the lid reconstruction was started. Here you can see the lesion being excised. So tarsoconjunctival flap was made of the same size as the defect in the upper eyelid. The skin of the lower eyelid was undermined, and the tarsoconjunctival flap from the upper eyelid was sutured onto the remnant of the lower tarsal plate. And then the anterior lamella was sutured to the neighboring skin and onto the tarsoconjunctival flap. After this reconstruction was made, the patient was kept on oral antibiotics and topical antibiotics and was on a regular follow-up with us for 6 weeks. After 6 weeks, the flap was divided into two so as to form two separate eyelids, the upper and the lower eyelid. The lower anterior and posterior lamella was sutured together to form a proper eyelid margin, as you can see in the video. This was the post-op status after the first surgery, and this is after the second surgery. The histopathology of the lesion showed epidermis with marked hyperkeratosis with clefting and nests of basaloid cells with peripheral palisading, which is characteristic of basal cell carcinoma. The patient is kept on a regular follow-up and has a healthy surgical site. As you can see, there's a comparative photo on the screen. Thank you.
I now invite Dr. Sugneshwari to discuss this case.
Good afternoon, everybody. I would thank the organizers, Dr. Suvira and all, for having me here. And it's an excellent session. I really enjoyed the way how the postgraduates are doing. It's phenomenal to see them doing a lot of oncology work in the previous session also. Yeah, so it's really nice to have them here. So that's an excellent work and a very well diagnosed, or rather a very well worked up and a perfectly managed case. That is what I would say. So my question to you, doctor, would be like, what are the risk factors that you would think for a carcinoma to be there on an eyelid? We all know malignant skin lesions are more common. Eyelid is very rare. And so the first question is, what are the risk factors? Can you enumerate on that?
Yes, ma'am. The risk factor most commonly of carcinoma being on an eyelid would be the UV exposure, the sun exposure. It is, and especially on the lower eyelid, as it is more exposed to the sun than the upper eyelid, because there's a protection of the brow there. Other than that, there can be some ionizing radiation that the patient might have gone through, or some sort of scarring that may be present due to some trauma. Cigarette smoking can also be associated with certain carcinomas. And
yeah. So that's good. You have, clearly enumerated the points and also said why the lower eyelid is more important rather than the upper eyelid. So is it only that the exposure to UV radiation where the lower eyelid is not protected by the rim, do you think is there any other reason also beyond that for the lower eyelid to be a common site for all carcinomas? We all know that.
I'm not very sure.
Usually the gravity.
Okay.
So gravity, that is why the lower eyelid is more common than the upper. So my next question is like, is your carcinoma, the basal cell carcinoma which you're talking about, how aggressive this disease is?
Ma'am, there are variants that are aggressive, but most commonly that the nodular type of basal cell carcinoma is not very aggressive. The morphiform or the sclerotic type of carcinoma, which is also a very rare variant of BCC, is extremely aggressive, and it is also associated with the mortality rate that has been studied in cases of basal cell carcinoma. Other than that, there is also infiltrative type or micronodular type, which is considered of a higher risk and tend to metastatize. There is a 4 to 9% chances of metastatizing, and mostly it is seen in micronodular or the morphiform type of basal cell carcinoma.
So if I'm going to ask you about like if a basal cell carcinoma, to put in summary, is it a locally aggressive tumor or is it a systemically aggressive? So
Ma'am,
what
it is a sorry,
Yeah,
ma'am, it is a locally aggressive tumor, because if suppose there is morphiform type of basal cell carcinoma, it is seen that it is locally infiltrative, as in it may involve the orbit and the adnexal tissue as well.
Correct,
But there is no metastasis.
Yeah, basal cell carcinoma is a very, very locally aggressive tumor. So once you resect it completely, your margins are clear, then there is nothing to be too much worried about. So would you prefer doing a frozen section for a basal cell carcinoma, or would you prefer a paraffin based analysis? What would your call be on these two, if you have an idea on these?
Yes. Ma'am, frozen section is preferred over paraffin based, because frozen section will have a short term, because we get to know the confirmation of the tumor free margin in just some time, so the patient does not have to undergo several sessions of surgery, and then the reconstruction can be done then and there with just waiting for a few minutes. So that therefore frozen section is preferred over paraffin, ma'am.
Yeah, in basal cell, definitely frozen section is always preferred, because you just want to have a clear margin. Once a clear margin is there, you don't have to be worried too much about it. And what is the origin of the basal cell carcinoma from?
Could this be the last question, please? Thank you.
Ma'am, it is based from the basal cells, the stratum basale of the epidermis of the skin. That's where it's originated, and there occurs a mutation in the precursor of the keratinocyte precursor progenitor cells, due to which there are abnormal cells that are generated.
So very good discussion. Thank you. Yeah.
Thank you, ma'am.
Thank you so much. Thank you so much, Dr. Signeshwari. And thank you, Venya. That was a great presentation. You can stop your screen share. I now invite the next speaker, Dr. Simran Verma, to give her presentation. Simran, you're on.
Thank you, ma'am. Good afternoon, everybody. I'm Dr. Simran, second year PG resident from MGM Navi Mumbai, and I'll be presenting a case on malignant melanoma of left lower eyelid under the guidance of Dr. Shivangi Singh. A 27-year-old housewife presented with complaints of swelling in the left lower eyelid since 10 years, with gradual increase in size over the last year. There was no associated history of redness, pain, crusting, bleeding, infection, trauma, surgery, diminution of vision, or any systemic illness. Best corrected visual acuity was 6 by 6 parts in both eyes, and extraocular movements were free, full, and painless. On examination, a pigmented swelling on the left lower eyelid measuring 2 into 2 into 1 millimeters, 12 millimeters from the medial canthus, involving full thickness of the eyelid was noted. The lesion was solitary with well-demarcated margin, irregular surface, and dispersed pigmentation.
Vascularization and central excavation was also noted, while skin around the lesion was healthy. Here we can see full thickness involvement of the eyelid with central excavation and dispersed pigmentation. The lesion also involved the posterior lamella with a sharp edge posteriorly. On palpation, the swelling was firm, non-tender, non-pedunculated, fixed to the base with no regional lymphadenopathy. On further examination, pigmented itchy lesions at the back of her right neck was also noted, which had also increased in size over the past 1 year, for which a dermatology reference was sent. Based on our clinical findings, our differential diagnosis were malignant melanoma, acquired melanotic nevus, verrucous epidermal nevus as per the dermatology reference sent, seborrheic keratosis, and basal cell carcinoma. The features that were suggestive of malignancy were vascularization, excavation present at the center, full thickness mass fixed to the underlying tissue, and dispersed pigmentation. While there were few features in favor of benign lesion, those were normal skin around the lesion, well-preserved glands and lint contour, no loss of eyelashes, and sharp posterior margin. Considering the potential of malignancy, our provisional diagnosis was malignant melanoma of left lower eyelid. The patient was planned for left lower eyelid mass excision with lid reconstruction under local anesthesia, and a wedge excision with 2 mm clear margin was done with primary closure. The mass was then sent for histopathology. On histopathology, thinning of epidermis was noted. The dermis showed melanotic cell nests. The cells were uniform, round to oval, with nuclear hyperchromatism, prominent nucleoli, and coarse melanin granules. Pigment-laden macrophages and lymphocytic infiltration was also seen in the deeper dermis, which was suggestive of malignant melanoma. Immunohistochemistry was then advised for confirmation, which was suggestive of focally positive melan A and HMB45, weakly positive S100, and low index of Ki67, which was hence confirmatory for malignant melanoma. Malignant melanoma of the eyelid is a rare but aggressive form of skin cancer, accounting for approximately 1% of eyelid malignancy. The disease can present as a pigmented or non-pigmented lesion and is often initially mistaken for benign conditions, leading to potential delay in diagnosis, which is why it is a silent threat. Early detection and treatment are crucial for improving prognosis and reducing the risk of metastasis. I conclude with a happy post-operative picture of the patient with a healed surgical site. Thank you.
Thank you, Dr. Simran. That was an amazing presentation. I now reach out to Dr. Sugneshwari once more to carry out her discussion.
Yeah, thank you, Dr. Suvira. And that was a very nice presentation. So,
Thank you, ma'am.
yeah, that was a very well managed, though a tough call to take. What are the crucial points we talk about when we talk about malignancy? We talk about ABCD. So, what is that ABCD? Can you highlight on that, please? See, if you know it, you can tell. If you don't know, you can. You don't have to really, break your mind over it. You can always say, "I don't know."
I don't know, ma'am.
Okay, so if when we talk about ABCD, so like you described everything. Okay, but it is just that it's a mnemonic for everybody to remember the PGs out here. A is for asymmetry, and B is for border irregularity, C is for color variation, D is for diameter. So this is what we say ABCD when we talk about lid tumors. So now what are the types of the malignant melanoma of the eyelid that you are aware of?
Yes, ma'am. So malignant melanoma, initially there could be a pre-malignant lesion, which is known as lentigo maligna, and there could be nodular malignant melanoma, and
yeah. So there are 4 types of malignant melanoma. So there are another 2 more also. So would you be able to tell that?
yes, ma'am. Superficial spreading melanoma, lentigo melanoma, and nodular melanoma, and then there is acrolentigenous melanoma.
So there are basically 4 types of malignant melanoma. And
Yes.
what is their growth pattern like? And which one is your melanoma which you're talking about?
So, ma'am, if it's malignant, then there would be a spontaneous sudden increase in size, and they usually spread radially, and then they become nodular. So this is most likely a nodular melanoma.
So see this, the basic picture what you're talking about, it should be based on the type of invasion what you're seeing and the type of cells. So what cells that in your histopathology was the reporting done? So did they talk about atypical melanocytes or did they talk about epithelioid? So what did they tell about it? You did read about it, isn't it?
Yes, ma'am.
So what is the cell type in your thing?
Mostly, ma'am, those were spindle-shaped cells.
So when
melanotic
you are talking about spindle shape, then it is not coming into the category of nodular, isn't it? Because nodular is of epithelioid. Your spindle is very characteristic is lentigo. So that is, yeah. So that is what one thing which I wanted to highlight. And the second thing is, when would you do about an SLN biopsy? When would you ask for SLN biopsy in a case of malignant melanoma of the eyelid?
Ma'am, if like in our case, there was no regional lymphadenopathy. On examination, if there is a regional lymphadenopathy or on histopathology, if the lymph nodes are involved, then we'll do SLN biopsy.
Yeah, very good. So what is SLN full form stands for?
Sentinel lymph nodes, ma'am.
Yes, so that is very crucial because why that is important when we ask about malignant melanoma? So like I asked the previous speaker, isn't it? Whether it is locally invasive or systemically invasive. So what is your category of tumor?
So, ma'am, SLN usually rules out any regional metastasis. Since there was no regional lymph node involvement in our case, the tumor was localized. It was not metastasized.
Yeah, so yours is a very systemically aggressive disease. So you need to have a longer follow-up. That is what we highlight. So anything that if the lymph node is, if your tumor size is itself less than 1 millimeter, then without regional lymph node, they in general do well. So do you also have non-pigmented variety of melanoma? What is that called as?
Amelanotic melanoma,
yes,
which are hypo or non-pigmented.
So how easy or how difficult it becomes to pick up if you have a amelanotic melanoma?
Ma'am, it is usually difficult to pick it up because since there is no pigmentation, then we would not consider it as a melanoma. And
so that is where the difference is. Actually, amelanotic does not necessarily mean that your tumor will be non-pigmented. It will be pigmented. But only thing is that the amount of melanocytes can be less when you do a histopathology. So that is what I would like to bring it. So I think with that, I think we'll conclude this part of the thing. And it is an excellent talk and good cases. Thank you.
Thank you so much, Dr. Signeshwari, for a brilliant discussion on the last 2 cases. And thank you, Dr. Simran, for your presentation.
Thank you, ma'am.
We now invite Dr. Nuvera for the next talk. Dr. Nuvera.
Yes, ma'am. I'm sharing. Good afternoon, everyone. I'm Dr. Nuvera Mustafa from TNMC Medical College. I will be presenting a case of orbital cellulitis with central retinal arterial occlusion. 6-year-old male child brought by the parent with the chief complaint of diminution of vision and prominence of right eye since 3 days, which was sudden and progressive in nature, associated with swelling, discharge, and fever. Father also noticed restriction in right eye since 1 day. Patient had history of fever and myalgia since 5 days, taken treatment from the local practitioner. There was no URTI. On examination, patient was febrile, conscious, and irritable. Extraocular movement in right eye was restricted in all direction of gaze. Lid was edematous. There was unilateral abaxial proptosis with 26 mm on Hertz. There was superior sulcus fullness, 2 mm of lack of increased retrobulbar resistance, tenderness, and erythema. There was no palpable mass, no change in proptosis on bending forward on an Valsalva. There was no bruit, no palpable theory. Vision in the right eye was finger count 2 meter, which was not improving further with pinhole. There was exposure keratopathy of 2 into 2 mm in the inferior cornea. Pupil showed RAPD grade 3. Fundus examination showed early changes of CRAO with choroidal fold. Left eye vision, anterior segment and posterior segments were within normal limit. So the provisional diagnosis of orbital cellulitis with CRAO made, urgent ENT referral was done, and the patient was advised CE, CT and MRI brain plus orbit to rule out sinus involvement. On CE, CT, there was pansinusitis with 5.1 into 3.7 into 4.3 centimeter mass causing bony erosion extending to medial and inferior extraconal compartment and adjacent intraconal compartment of right orbit involving medial rectus. And findings were confirmed on MRI. So the final diagnosis of orbital cellulitis with CRAO secondary to sinusitis made, and the patient was urgently taken for FES under general anesthesia, and pus was collected and sent for culture, which showed growth of MRSA. Histopathology showed granulation tissue with no fungus growth. Then the patient was started on antibiotics ceftriaxone, vancomycin, and metronidazole respectively. Eye drop, moxifloxacin, and lubricating started for exposure keratopathy. Along with FES, endonasal endoscopic medial wall decompression was done to relieve pressure on optic nerve by ENT surgeon. During this process, complete sphenoethmoidectomy done to expose medial orbital wall. On post-procedure day 3 examination of the patient, right eye showed grade 2 RAPD with improvement in extraocular muscle. Fundus examination showed decrease in choroidal fold with retinal pallor. On post-procedure day 7 examination of the patient, right eye BCVA was 612, sluggishly reacting pupil. EOMS was full and free with improved perfusion of retina on fundus examination. So the conclusion is the orbital cellulitis with CRAO is very rare in pediatric population. Urgent orbital decompression in the orbital cellulitis with CRAO can save a patient's vision if done immediately. Thank you.
Thank you, Dr. Novera. I invite Dr. Bhavna Sharma to lead the discussion on this case. Dr. Bhavna Sharma. Do we have Dr. Bhavna Sharma with us? Would any other judge like to take up this discussion? Dr. Alka Gupta, Dr. Sujata, Dr. Sugneshwari.
Yeah, no problem. So it's a very nice case, Nuvera. Can you stop sharing the screen, please? So when you are talking about MRSA related orbital cellulitis causing a central retinal artery occlusion, what do you think is the cause for the pathogenesis? I mean, how does the central retinal artery occlusion occur in an orbital cellulitis?
Ma'am, it's because of the retrobulbar mass. That mass pushing the posterior pole of the retina, and it caused the compression of artery. So
when the artery gets compressed, what exactly happens?
So there can be occlusion and
So is it only the direct compression that can cause, or do you think there can be any other mechanisms that can be involved also? Would there be a part of an angio invasion also in this? If I say so, am I right or wrong?
Yes, ma'am, there can be angio.
What is the cause for the orbital cellulitis in this child?
Ma'am, the child had history of fever. He had sinusitis. So the orbital cellulitis occurred after sinusitis, ma'am. So the cause of orbital cellulitis, sorry, was sinusitis.
So was there any pre-existing focal lesion like sty or something on the eyelid for this child which was there? Or only that this cellulitis occurred just as a part of the episode of fever?
After fever, he developed orbital cellulitis. There was no sty or no.
Pointers to start with. Okay, what was the level of CRP in this child?
CRP was raised, ma'am. It was around.
Because when you talk about septicemia in a child, don't you think CRP is very important and crucial for us to monitor also? So now coming to central retinal artery occlusion management, what are the things that you would like to do? If you tell that is a CRAO, what are the clues on the retina to diagnose a central retinal artery occlusion?
Ma'am, there will be retinal edema. The transparency, there will be loss of transparency of retina. Retina will look pale. There can be disc pallor and the cherry red spot and
So you're right. That is, they will have translucency that is there. Like for instance, when you talk about cherry red spot, why do you get a cherry red spot in a central retinal artery occlusion?
ma'am, cherry red spot we get at fovea because the fovea don't have ganglion cell layer and it's thinner than the rest of the retina. That's why we get cherry red spot there.
So if you have a if you have a central retinal artery occlusion, which is not of a compressive nature, like your case, it is compressive nature. What can be the other causes for a central retinal artery occlusion?
Other causes can be, ma'am, trauma, metabolic disease like Niemann Pick, Goucher, and Tay-Sachs disease, and it can be seen in mucormycosis.
We have 30 seconds more for this discussion. Thank you.
Sure. So whenever we ask you what are the causes, you must always try to stratify it, classify it. Okay, you're talking about storage diseases and all these infectious causes. You will have to classify a central retinal artery occlusion on the basis of Virchow's triad. That will make it easy. Okay, thank you.
That's a brilliant discussion, Dr. Signeshwari. Thank you so much for stepping in. Thank you. Thank you.
Thank you, ma'am. We next have Dr. Vishakha Kashit from Government Medical College, Aurangabad. She's mentored by Dr. Archana Vare. Dr. Vishakha, we invite you to present your case.
Is my screen is visible, ma'am?
Yes, it's visible.
Good afternoon, respected teachers. I am Dr. Vishakha Sunil Kashik, second year PG resident. I am presenting a case of corneal tear with anterior chamber foreign body with traumatic cataract under the guidance of Dr. Archana Vare ma'am and Dr. Mahesh Sonpetkar sir. A 28-year-old male, stonecutter by occupation, resident of Bharat Nagar, Chhatrapati Sambhaji Nagar, Aurangabad, rushed to emergency department with the history of trauma with stone to right eye while working. The patient was recently right 1 day ago. He had accidental injury to right eye while cutting the stone. After that, the patient experienced excruciating pain and sudden diminution of vision in right eye. Negative history, no history of previous ocular disease or surgery, no history of floaters and flashes of light, no history of headache, no history of nausea or vomiting, no history of double vision, no history of any topical medication use, no history of protective eyewear use while working, no history of ENT bleeding,
No history of unconsciousness and giddiness. Family history and personal history were not contributory. General examination was within normal limit. Systemic examination was within normal limit. Ophthalmic examination, head posture, facial symmetry, and eye alignment were normal. Extraocular movements were free and full in all directions of gazes in both eyes. Right eye examination, visual acuity was finger crowding close to face. Eyebrow was normal. Eyelids, minimum edema was present. Eyelashes, matting was present. Interpalpebral fissure, vertical 8 millimeter and horizontal 29 millimeter. Conjunctival congestion and circumcorneal congestion was present. Cornea and oblique, linear, full thickness corneal tear of size 6.5 millimeter in length from 11 to 7 o'clock, paracentral in location, extending from pupillary margin with stromal edema was present. Anterior chamber shallow with Van Herrick's grade 1 depth with triangular foreign body inferiorly of size 3 by 2 by 0.5 millimeter at 6 o'clock position with apex towards the pupil and base towards the limbus. Iris color pattern was normal. Pupil central circular sluggishly reacting to light. Pupillary aperture whitish reflex was present. Fundus no view was seen due to cataractous lens. Left eye examination, visual acuity unaided by 6 by 60, best corrected visual acuity of 6 by 6 with -2 diopter sphere. Anterior and posterior segment examination was within normal limit. Ophthalmic investigation, Siddle test positive for right eye, B scan, posterior capsule dehiscence noted, rest posterior segment was within normal limit. According to this, my provisional diagnosis is right eye full thickness corneal tear with foreign body in anterior chamber with traumatic cataract. Left eye within normal limits. Management. After all necessary preoperative workup, corneal tear repair with foreign body removal with lens aspiration was planned. Intraoperative posterior capsule dehiscence was noted. Anterior vitrectomy was done. Intraocular lens was not implanted. Patient planned for secondary iode implantation. This is a picture showing intraocular foreign body nearly about 3 by 2 by 0.5 millimeter in size, which is removed from the patient's right eye. A patient is stone cutter by occupation, so most probably this is the foreign body stone. This is the picture showing the post-operative day 21 patient's right eye. Where the 5 corneal sutures were seen. Thank you.
Thank you, Dr. Vishakha. I request Dr. Alka Gupta to commence the discussion for this case.
Yes, coming.
Yes, ma'am.
Good afternoon. Yeah. Dr. Vishakha, as you told, it is a traumatic corneal opacity with cataract, with perforation of cornea. So, how do you remove this foreign body? It's a metallic, it's a stone foreign body, you said, no?
Yes, ma'am.
What else?
Yes, we made a separate incision, like small incision cataract surgery from the superior side, and we have removed that foreign body with the Macpherson forceps. And after removing that, we have lens aspiration was done, and after that we have sutured the cornea.
Why don't you have put IOL at that time, at first sitting only?
Ma'am, it was a open globe injury, so that keratometry and IOL power calculation was difficult, and if we have done that, the patient might have experienced the refractive surprises, and so that after corneal suture removal, we have planned for secondary IOL implantation.
So, what other investigations you would like to do? What complications can occur because of this only? Because of trauma, blunt trauma, or you can say perforating injury to the eye? What else can occur?
Yes, ma'am.
What complications
Yes, ma'am.
can occur?
firstly, the investigations. We will do all routine investigations of the patients, and then ophthalmic investigations like B scan. I will like to do in this patient for checking any posterior segment involvement and complications like suture related complications like any loose sutures or any tight sutures or any astigmatism, and due to this penetrating trauma we can see endophthalmitis or sympathetic ophthalmitis we can see.
What do you expect in ultrasound? If you do ultrasound, what do you expect in that case? In such
B
cases,
scan was
huh? You have not done B scan, no? B scan was
Yes,
not done.
we have done, ma'am. Posterior
You have
capsule.
done.
Yes, ma'am, done.
Done.
Yes, ma'am.
Okay.
Posterior capsule disease was noted, and in this case, the posterior segment was normal. But in penetrating trauma or any blunt trauma, we can see vitreous hemorrhages, retinal detachment, or tear. We can see.
What about glaucoma, intraocular pressure? What about intraocular pressure in post-operative period? Is it normal
in this case, it was normal, but the patient can get raised intraocular pressure after these surgeries because if there is a remaining blood clot or there is any hyphema present in the anterior chamber, it can cause blockage of the trabecular meshwork, and it can cause raised IOP post-operatively.
So the cornea is badly damaged. You have sutured the cornea.
Yes, ma'am.
In follow-up period, how much vision he get? How much vision was there?
Ma'am, it is just day 21 of the patient. We have done we have calculated the vision of the patient by 10 diopter lens. It was around 6/36. After 6 weeks, we will plan for secondary IOL implantation.
You will plan secondary IOL, but cornea is opaque, opacity is there. What else you can do? What else you can do?
The time for the discussion is up. Just finish this last question, please.
Maybe ma'am, you can ask your last question. We'll end with your last question.
Okay,
Beta, you can answer this question. Thank you.
Okay.
Ma'am, if the cornea is opaque, we can plan for penetrating keratoplasty in this patient. If the patient does not get good vision and patient get permanently corneal opacity after this.
Okay, thank you. Good.
Yes, thank you, ma'am.
If the time permits, I would just want to put in few comments, my observation,
Certainly.
points actually. Yes.
Certainly.
So, when you're presenting a case of ocular trauma, you must first indicate the type of injury, as it is, whether it is a penetrating or a blunt injury. You must indicate the type of wound, that is whether it is in the zone, what is the severity grade, that is the grade of injury, and in addition, you are able to put up the other intraocular features with respect to the ocular trauma score. That is at the level of the PG. And management would depend on your diagnosis first. Diagnosis could have been better in this particular case, in the sense that mentioning the type of injury, the grade of injury, the severity, and what would be the score. And the second thing I would like to also comment here, that once you have said that the suturing was done, you must be aware of the suturing technique which you're doing for such patients. What is the suturing technique we follow for suturing of the corneal wounds?
We have done interrupted sutures.
Okay, what is the principle of that? You must know about the Rouse-Hayes technique.
Yes, Rouse-Hayes technique, Eisner principle, and keratorefractive principle.
So that is good. You must know about that. Then, of course, you must know about the traumatic cataract, the morphology, and how would you manage. The principle of management of traumatic cataract in corneal tear varies. It would not be uniform for others. Thank you.
Yes, ma'am. Thank you, ma'am.
Thank you very much. Tanvi, we can move to the next.
We next have Dr. Mohini Kukde, also from Government Medical College, Aurangabad. The mentor is Dr. Archana Vare. Dr. Mohini, we invite you to please begin your case presentation.
Dr. Mohini needs to unmute herself, I think.
Dr. Mohini, please unmute yourself and start again. Start with the beginning. We start your presentation. Unmute, introduce, and start.
Yes, ma'am.
We can hear you now. I
Good
think.
afternoon, respected teachers. Good afternoon, respected teachers. I am Dr. Mohinanil Kukade, second year PG resident of GMC Chhatrapati Sambhajinagar. I am presenting a case of choroidal rupture caused by blunt eye trauma under the guidance of Dr. Archana Vare ma'am, head of the department, GMC Aurangabad.
Is to fill in this college history.
A 28-year-old male patient, security guard by occupation, resident of Chhatrapati Sambhajinagar, came to the emergency department with chief complaints of diminution of vision in left eye, swelling over the left eye, and redness in the same following a physical assault to left eye by fists and blows 4 hours ago. Patient was apparently all right 4 hours ago when he faced a blunt trauma to left eye secondary to physical assault. After this, patient noticed sudden diminution of vision in left eye which was progressive in nature. Patient also developed swelling around the left eye which was sudden in onset, progressive in nature, and associated with redness and dull aching pain. There was no history of previous ocular trauma, no history of giddiness and vomiting episodes after assault, no history of previous ocular disease or any surgery, no history of floaters and flashes of light, no history of headache, no history of double vision, no history of nose and ear bleed, and no history of any convulsions. Past history, personal history, and treatment history were not significant. General examination was within normal limits, and systemic examination was also within normal limit. In ophthalmic examination, head posture, facial symmetry, and eye alignment were normal, and extraocular movements were full and free in all directions of gazes in both eyes. In anterior segment evaluation, visual acuity of left eye was 20/200, eyebrow was normal, eyelids showed periorbital edema with ecchymosis present over upper eyelid, and eyelashes were normal. Conjunctiva showed subconjunctival hemorrhage present over the bulbar conjunctiva with mild conjunctival congestion. Cornea was clear, anterior chamber was of normal depth, iris had normal color and pattern, pupil was circular and normal reacting to light, and pupillary aperture was clear. On posterior segment examination of left eye, on distant direct ophthalmoscopy, glow was seen. And on indirect ophthalmoscopy, media were clear. Disc was normal with distinct margins and cup disc ratio of 0.3. Blood vessels were normal with arteriovenous ratio 2:2/3 and foveal reflex was seen. Also, left eye fundoscopic examination revealed 2 blot hemorrhages along inferotemporal trunk of vessels with a white crescentic vertical streak of size 5 mm in length and 0.5 mm in width, 3 discs diameter away from the optic disc and concentric to disc, not involving fovea, and which was slightly obscured by choroidal bleeding. This is the fundus picture of diagram of my patient of left eye. Investigations done were B-scan and X-ray orbit, which both were within normal limits. So my provisional diagnosis is right eye within normal limits and left eye choroidal rupture secondary to ocular burn trauma, not involving fovea. The treatment given was left eye drop nepafinec 4 times a day and injection subtenon triamcinolone 2 mg under topical anesthesia. And patient was called for monthly follow-up. On 3 months follow-up, left eye visual acuity improved to 20/40 and rest anterior segment findings were within normal limits. Left eye posterior segment examination revealed resolved previously present hemorrhages were resolved. Scar was seen of size 2 clock hours, circular in shape, black colored, located nasal to the disc, which was apparent earlier and mostly a post-traumatic scar. Then the choroidal bleed, which was present earlier, got resolved with decrease in vertical size of the choroidal rupture. And there was absence of any choroidal neovascularization, which is the most dreaded and avoidable complication of choroidal rupture. Thank you. Great presentation, Dr. Mohini. I request Dr. Sujata Laktakia to please commence the discussion for this case.
Thank you very much, WOS, for giving me this opportunity to be part of this. Good presentation, Dr. Mohini.
Thank you.
What I would like to ask is, why did you give triamcinolone acetonide for your patient? What was the indication of subtenant?
As it is an inflammatory reaction because of choroidal rupture, there was bleeding also, and bleeding was there, so there will be an inflammatory process there. So in order to avoid inflammation, we gave subterranean steroid, and main reason was to avoid the most dreaded complication of choroidal rupture, that is choroidal neovascularization.
I don't know. I haven't read of subtenon steroid being given for choroidal rupture. As far as I know, choroidal rupture is best left alone, kept under observation. And are you aware of some other treatment modalities which have been put up in literature but have not been like universally accepted?
Ma'am, previously photodynamic therapy or argon laser photocoagulation was used, but because of the its side effects, it has not been used nowadays, and especially in subfoveal and juxtafoveal rupture, we avoid those therapy. Now the most common therapy which we use is antivitreal injection of
Intravitreal anti-VEGF is indicated only if you have the formation of choroidal neovascular membranes. For that also, most of the cases of CNV after choroidal rupture, they are supposed to they usually involute on their own. 20 to 30 cases in which there is recurrence of CNV. For those patients, you can go in for intravitreal anti-VEGF. If I remember correctly, some time back, I was reading choroidal rupture and I came across certain case reports wherein they had given intravitreal tissue plasminogen activator and expansile gases for the treatment of choroidal rupture. But again, that is not very well documented and very well accepted throughout. So what I know is that it is basically wait and watch. And one more thing, can you tell me why is choroidal rupture concentric to the optic disc most of the times?
Yes. Yes, ma'am. Because whenever a blunt injury occurs due to bell mechanism, protective bell mechanism, our eyeball gets shifted medially and downwards, and so the optic nerve also gets shifted to medially and downwards, and the tethering force of the optic nerve, which is spherical, puts more resistance on the temporal side, and hence we get a concentric crescentic shape in the temporal side.
Is it always on the temporal side? You can have a choroidal rupture on the nasal side also.
Ma'am, according to the research, 82% times, means 82% there are temporal ruptures, and only 18% is for nasal.
So can you tell me the difference between direct choroidal rupture and indirect choroidal rupture?
Ma'am, direct choroidal rupture means where the trauma has occurred, that is near the ora serrata, and the difference there is that it is parallel to the ora serrata, while indirect rupture is due to the contour-coup forces, where the injury is on one pole and the presentation is on the opposite pole, that is on the posterior segment.
Okay, that's good. Can you tell me other manifestations of blunt ocular trauma? What are the other manifestations that you can come across in a case of ocular blunt trauma?
Right, starting from anterior segment, we will get eyelid periorbital edema, ecchymosis, laceration, abrasions. Then coming to conjunctiva, we can get subconjunctival hemorrhage, chemosis, or any conjunctival chemosis. Then cornea, we can get lacerations or full thickness corneal tear if the is strong enough. Then in anterior chamber, we can get hyphema, then iridodialysis, and iridodialysis, then lens subluxation. Coming posteriorly, we can get lens subluxation. Angle recession can also occur. Then in vitreous hemorrhage can occur. Retinal tear, choroidal rupture, then retinal detachment, or or even in worst cases, optic nerve avulsion can also occur. Thank you.
Okay, just one more question. You talked about hyphema, which is not present in your case. In fact, your case had no other manifestation of ocular blunt trauma apart from the choroidal rupture and
Yes, ma'am.
few hemorrhages, retinal hemorrhages that you talked about. Can you tell me the the indications for surgical evacuation of hyphema? If you have a hyphema, when do you go in for surgical removal of the blood from the anterior chamber?
Ma'am, grade 4 hyphema is one of the indication. Then if the IOP increase is beyond within a period of time, within 6 hours, if the IOP has increased to a more level than the baseline, then we can go for surgical intervention.
No, what I know is that if there is corneal staining occurring, then you will go in for surgical evacuation, or if the raised intraocular pressure is not responding to the topical anti-glaucoma medication that you're giving, and is been more than 30 millimeters for a period of almost 7 days, or maybe more than 50 mm for a period of 5 days, then you go in for surgical evacuation. It was nice. Thank you. I would like any other judges to please be part of the discussion. Sugneshwari ma'am, if you could add to our knowledge about ocular trauma.
Please go ahead. We'd
Thank
love
you,
to hear
Dr.
from you.
Yeah. So basically for choroidal rupture, the thing is no anticipatory treatment. That is number one. We don't treat. Yeah, we don't treat if you don't get a neovascular membrane. So there is no role of intravitreal steroid because the thing is it is not an inflammatory mechanism. The mechanism is a breach. There is a tissue loss. That is why you get a choroidal neovascular membrane. So using an intravitreal triamcinolone would pose the patient to glaucoma. The reason being the patient will already have angle recession, other problems post-trauma.
Ma'am, if I could just interrupt you for a second, they didn't give intravitreal steroid. She gave tenants.
I would not prefer subtetheral steroids
ma'am.
also.
Steroids are all together.
Steroids
Exactly.
are contraindicated. When you have a trauma, you're not going to do it because one is you will never know what is the angle status going to be. And then if the child or the patient has an angle recession, that is going to pose another threat. So adding on into an adjacent one is got no role. So your role of steroid was to here is to prevent a CNVM. Unless and until you have a CNVM, the role of steroids is not there. Number one, anti-VEGF can take care of it, and the CNVM which occurs will usually invariably occur from a period of 6 weeks onwards, not immediately. That is also there. And number two, PDT is not available in India. For the past 4 years, it's not available. Very sparingly if somebody gets a dye, but so it's not being used for the past 4 years. Number three, the thing is about hyphema evacuation. So nowadays, we don't practice hyphema evacuation. If the patient is having a constant raise in pressure, you must always understand if you do an ultrasound and the patient is having a posterior chamber hemorrhage, then it has to be a vitrectomy combined. Otherwise, the patient tends to re-bleed again. So that is what is the most important thing. If you are going to rule out any other cause, I'm talking about purely trauma cases. If you have additional bleeding diathesis, the rules are different. But in trauma, it has to be no hyphema evacuation alone is never sufficient because invariably you will suffer from a rebleed. So it's always combined with a vitrectomy. And even we do, if the IOP management is not getting better, like Madam talked about rule of 30 and all those things, not better, we even do a trap so that the patient, see the trap will immediately control the intraocular pressure, but it may not work for very long. That will work only for a shorter time, but still it will control the pressure combined with vitrectomy. This is how the management is the present guidelines is. Yeah.
Thank you.
Thank you.
Thank you. Are we happy with the discussion of this case? All my most amazing judges, are we happy? All
yes.
right.
Yes, Dr. Subira.
Thank you, Dr. Moini. That was a good presentation. Now, with this, we come to the end of our 19 participants at the Maharashtra State Meet. I hope all of you are around. Everyone come on board, and I think My one lesson to you all would be, if all my judges and all those hosting it can have their cameras on, it's a very good idea to keep your camera on. It actually shows that you're there, you're engaged, and you're involved in what's going on. Putting off your camera means you're just walking around, you're going to come back in. Not nice, I would think. So since we have some time while we assimilate on the marks and figure out who my grand winner of the state of Maharashtra, who's going to represent Maharashtra at the WOS annual is, I'd like to re-invite my very dear friend, Dr. Sharmishta Raja. And if all of you students are there, hi Sharmishta, are you on?
I'm on. Hi, Dr. Savira.
Good. So that's you and me. How do you feel about taking a question and answer session? Be it the judges, be it my mentors, be it the students, or be it my most amazing faculty out here who's helped me with it. Anyone for any questions to be discussed with Dr. Sharmishta? She's right here with you for a few more
I'm
minutes.
just sending the photograph.
Could the others please be on mute?
I'm sorry.
Not at all. If anyone has any questions.
Dr. Savira, thank you. And while we get into questions, that was a good input. We must get a picture, and I'll invite everyone to join us on camera. The whole world was virtual for almost 2.5 years, and this is our only window to the world. And I would love to see all the participants, judges, faculty members, senior doctors, everyone. It'll be great to see all of you. I understand, Dr. Savira, I already have received two two confirmations from the participants for their one-on-one coaching sessions. So let me reiterate that all the participants get a free complimentary one-on-one coaching session with me. I had shared the link on the chat. If not, I'll share it again. So all the participants, you get one conversation with me absolutely free, and the winners get two. So do take the opportunity to kind of connect, and whatever's on your mind that you'd like to either get coached on, I would love to help you in that journey. So yeah, I'll just put that link in, and Dr. Sriva, I'll let you take the questions.
So does anyone have any questions as yet? It could be absolutely anything. We were discussing in the morning how we need to be bold and upfront and share whatever we feel we'd like to get some clarity on. Sharmishta's here, the other seniors are here. Anyone? Any of the mentors would like to say anything? Or my judges?
Ma'am, I'm Dr. Archana Vare. I'm a professor and head Department of Ophthalmology at Aurangabad. I must congratulate you all, ma'am, because this was a very, very nice learning session for the mentees also and for the mentors also, because I'm attending this session since morning, and I have also learned a lot, and this is a very nice platform for the presenters to present their cases, ma'am.
Yes. Sharmishta, there don't seem to be too many questions. So would you like to give us a few more pearls on anything that my young students who are training to be ophthalmologists, who are going to go out there in the world, face whatever life throws at them, both professionally and personally? Is there anything else you'd like to share with them? Anything at all? Stage is yours.
Sure, thank you. I connected a little early on in the morning, and I was a part of the last presentation as well. This noble and blessed profession of medicine, the more we say, the less it feels. But thank you for your service. Thank you for what you do. But in our experience, we all know that, patients have had different experiences with different medical fraternity members. And I personally, and Dr. Suvira, you and I have personally shared experiences of how it has been working with other doctors for my daughter. The one thing that I really like to share is as a parent, and today, now I speak as a parent. My daughter is 7 years old with progressive myopia. She's got -6, -7 number, and she has a lazy eye. So it is challenging to have a child this young with that high power. And I went door to door everywhere to find a doctor who could really not just treat her, but really help us understand how do we support our child, and not just with the treatment, but also mentally. And one of the things that stands out, and I will not embarrass Dr. Suvira, but the care that is provided along with the treatment, it goes beyond the treatment. especially supporting the parents or supporting the caregivers of the patients. I think that is over and beyond what is expected from a doctor. But as a human and as a living being, understanding, empathizing with another living being, that character is very few. That character is very few in very few doctors that I've seen. And that is, I think, what sets them apart. So while all of them have competence, no doubt about that, it's your character that will make you memorable. It's your character that will leave a legacy. It's the character and your sense of service for humanity that will earn you that. I've been studying a lot about karma, and that is your extra good karma that you get, is that along with your support of your technical abilities, your competence, how are you as a human being serving others? So I'd like to say that that goes a long way. And that sense of service we see in professions in the military, we see in the field of medicine, we see in any profession of giving care and support. But I often wonder if it's the same in the corporate world, right? I'm sure you must be also wondering, since I represent the corporate world in this forum at this point, it is rare. It is even more rare in the corporate world. So character holds their character holds importance everywhere. But again, when it comes to personal growth or the growth of the company and clients, I know how people have made those decisions. So stay true to yourself. Empathy goes a long way. Sense of service is what's going to earn you much more than what you could imagine in terms of good karma. But on a lighter note, Dr. Suvira, for all the students here, I'd love to hear from the students how was their experience. And they've got the gyan both in terms of the technical gyan, and I think somewhat little bit from me from a personal standpoint. But I'd love to hear from the students. Go ahead and share on the chat if you had any questions, anything that you liked in the presentation. I have the presentation deck with me as well. I'm not sure if people had the time to do the Wheel of Life exercise. If not, we have a few minutes. It will take
Yes.
about 2 minutes. We can do
Please
that
go ahead and
exercise.
do it. I've got about 30 students here. So please
Awesome.
go ahead.
And this is open for everybody else also who's still here and joined us. This is the Wheel of Life exercise and gives you a glimpse of where we are at, consciously, unconsciously, in our life. Okay, so the Wheel of Life exercise, do I have rights to share my screen? So the ones who were not there in the morning session, I can present it again.
I believe you do. Just please see.
Yeah, I do. Let me... So this is the Wheel of Life that represents every facet of your life. And this assessment will give you a glimpse of where you're at and where you wish to be, giving you the gap. Now, wherever the gap is where we need to kind of prioritize and work. So I've shared the link in the chat. Please click on that. It's a free assessment. It will take about less than 30-40 seconds. You could quickly, it's just 16 questions. And then it'll give you this wheel. Each of you will get a wheel depending on your responses.
I would actually encourage you all to do this. We still have another 5 minutes before we can announce the results. Let's do something meaningful.
Yep. And as you take this, so I'll take a pause, I think, to let them read the questions and answer it. Yeah. Please let us know in the chat once you're done. Yes. Someone has asked, should we do the exercise right now? Yes, please. Thank you, Dr. Sudhata. Thank you, Namika. Dr. Namika.
फोन करें. You're not doing anything right now? Help me with this. So first is whose? May you tell me which college? And
Okay,
second.
Dr. Suvira, you're not on mute, so we can hear you. Thank you. We'll keep the results for the end. Sunday well spent. Oh yeah, absolutely, Dr. Naina. Absolutely. And I find myself extremely blessed to be here in your company, especially women doctors and supporting each other. Nothing better than Sunday than this. All right. So do we have a few folks who've already finished it? Do you have your wheel?
Could you put it in the chat, those who've done it, please?
How does your wheel look?
Which college?
Let your responses be quick. Yeah, don't think too much about it. It's just a self-assessment to see where you are. Done, Dr. Naisha. Thank you. Anisha? Thank you, Dr. Iti. So a tip here, everyone who's finished, please go ahead and then book the call with me. This opportunity is available for the next 30 days. You can book an appointment with me absolutely free. There is already a discount code that I've applied, so the tool will not take you to the payment page. It'll just kind of close it out. So have your Wheel of Life assessment with you, and we can actually take, if you have any questions around that, and there's a specific area that you want to work on, we can do that. Else, anything that's on the top of your mind, we can take that opportunity to discuss with me. I myself am on the journey of coaching and helping leaders find their path and redefine their life at whatever stage they are in. So I'd be happy to help all of you as well. Okay. Anyone surprised? Anybody like, oh my God, this is an ignored section, or like, did anybody have any light bulb moments?
I think I have some very shy bunch of doctors here who are not willing to actually come up and speak. Maybe the way I see it is, Sharmishta, they will come and speak to you more freely when they're at that one-on-one session. That's
I
my
see. Yeah,
That's
I
what
see their mentors. Yeah, their mentors, their seniors, everybody's there. So yeah, I can understand. I see that. I see that. Okay, spirituality came as something that is all right. There'll always be an aspect here in one of the, it's like the first question is like, should all of that be full, right? Should the whole wheel be full? Ideally, yes, in full in a way that you want to. If there's something that you've under-indexed on, check what you're over-indexing on. And if that can be bad, if that is something that you want to do, you want to balance it out. But there is the truth that if we are over-indexing on one of these aspects, and another aspect is going to get impacted. Question is, if you're okay with it, fine. Like, for example, I over-index on career, my fun and recreation is low. Fine. If that's the case, I'm okay with it. I find my fun and recreation in my work. All right. But however, when it comes to family, it's a different case. So there is no good or bad report. There is no like, should it be a certain way? It is what it is. The activity basically gives you a reflection of where, firstly, have you consciously thought of rating yourself of different aspects of life? I'm not sure when you must have thought of, when did I have fun last, right? So what do I rate? But the whole exercise kind of makes you think that, yes, these are also other aspects of life that we want to kind of ponder. Having said that, I would love to take some questions. I think we have one of the judges.
Any questions?
Yeah, I'm Dr. Naina here.
Yes.
What is the ideal wheel of life according to you?
That's the Dr. Naina, great question. As I said, there is no ideal. It is what you decide. This is the brilliant part of being a human. And so the us versus animals, right? We have two big gifts, if I may share. The two big gifts that we have from God is the freedom of choice and a golden box. Do you want to know? Does everybody want to know what the golden box has? There's a golden box all of us have.
Wisdom.
Yeah, wisdom. Okay.
Wisdom.
Okay. And anything else?
Speech.
Speech, okay.
Thinking.
Thinking, okay.
Power to analyze.
Okay, great, fantastic. Okay, they all come under one bucket. Choice, yes. So yes.
Freedom of choice.
First, freedom of choice. So first gift is we have freedom of choice. Second is we have a golden box. Now, with your permission, there's a short story. It's just a story, fictitious one, not real. You may or may not believe in God, but we'll use God as a reference here. Is that okay? So God decided to create human beings. By then, there were only animals on earth. So then God decided that, okay, let me just take some inputs from the other animals. Like what qualities should I take and imbibe, and how do I work with it? So then God took a few of the characteristics of different animals and then added a few more things from his end, and then gave these 2 extra gifts, right? Saying freedom of choice, I will give human beings to decide how they want to live. And the second is this golden box. Now God tells all the animals that I don't want this golden box to be easily recoverable or easily, the human beings should not find this box very easily. I want to make it difficult for them to find this golden box. But it is something that each of them have. They all have their unique golden boxes, but I want to make it difficult for them to find it. So then God says, okay, let me just ask the animals. Now, so then the whale comes, said, God, why don't you hide the golden box in the depths of the ocean? Humans will not be able to find it. God said, no, they will innovate, they'll make machines, whatever, they'll go to the depth of the ocean. The eagle comes, says, put in the mountain. God says, no, they'll reach there too. Then the cheetah comes, I run very fast, I'll go in the middle of the forest, a dense forest, and hide it there. God said, no, they'll find it there as well. Then the lion comes, and the lion says, God, why don't you hide the golden box inside the human being? Because that's the last place they will look. That is the last place they will look. That golden box, you want to know what is in it? That golden box is infinite potential. Infinite potential that we have, each of us. The question is, do we know? Firstly, it exists. Secondly, where is the key? The key is in our hands. Rather than looking outward, we look inward. Open that golden box. See what's in it. Sometimes there might be things that we may not like to, as we said. There could be vices. There could be personality traits that we have that we don't like. But that's us. That's potential for us. The gifts that we would want to hone and make into our, to work for us, or we have opportunities to develop ourselves, our vices. But each of us has that golden box. My message to all the students, everybody, all the faculty members, judges, mentors, everyone, is that continue your process of learning. Today, you all took the time to be here on a Sunday, and I know weeks of work, months of work must have gone in getting your cases together. Continue learning about yourself, right? I think the most interesting subject I have studied is myself. Not to be narcissistic or self-centered here, no. It is for service for others. The more I do this work for myself, the more I'm able to help and support others to do this work for themselves. Who is it that I offer every time in my relationships, in my interactions? It starts with me. So my favorite subject is me. Your favorite subject should be you. Study yourself, give opportunities to yourself to challenge yourself, to grow, to work on things that you need to work on. And that's the gift of God.
Fantastic.
I hope you like the little story.
Oh my God, you're just amazing, aren't you? You're amazing, Shamishta.
Thank you.
Thank you so much for being there here with us. It's actually been absolutely amazing. Anything else you want to just tell anybody? Otherwise, we're pretty
There
ready.
is a question, Dr. Name. Wheel of Life, what does 1 represent? 1 is at the lowest. It's a rating that you're giving from 1 to 10. 10. 1 is the lowest, 10 is the highest. So if you're rating 1, it'll come right at the center here near the center of the circle. And as you go up, it's 10. It's how you rate it. Good, bad, how good, how bad, Dr. Ramika, that's how it is.
I sincerely hope that all 20 of you are going to take advantage of this half-an-hour session that you're going to have with Dr. Sharmishta. Please, all of you, I'll also, Sharmishta, in case any of them are not here right now, once more, I'll put it on the WhatsApp group as well, wherein I can let them know. And a quick question is, they need to register with you by tonight? When would you like them to figure out their schedule?
They can, yeah. So they need to book in by tonight, and it just helps me plan. But I'll throw in a little breather. I know it's been a long day for them. I'll throw in another day. So by end of day tomorrow, please book in your slots, because my slots get free and I have to move a few things. But they can book a slot with me for the next 1 month. So till the 25th of September, my calendar is available to all the participants, all the 20 participants here to book a slot with me. And whoever the winners are, they get 2. So whatever you've booked, plus another one for the winners. Yeah.
Thank you. Thank you so much for jumping back in and helping me end this program. I'd like to thank you for being part of this. I'd like to thank all the students for taking the effort of actually preparing and presenting and sending their work on time. I'd like to thank the mentors for supporting their students and encouraging them, being their rock solid support as they present and while they get ready. I'd like the other head of departments for giving them the permission for doing so. I'd like to thank WOS for giving Maharashtra State the opportunity to put up this brilliant program. And come here, all of you. Here's my team. I don't know whether you can see them. Come here, all of you. Here are my most amazing team of people. I don't know whether you see them. Okay, maybe you don't. We'll have to put a picture of all of them. Doesn't matter. Leave it. There's Tanvi, Vaibhavi, and Veena, without whom none of this would be possible. Biggest round of applause for Dr. Tanvi, who has worked seamlessly at making this. I would just throw ideas, and we all sat and tried to make a good show out of this. So I'm very proud of all of you girls. And now, is everyone ready to hear who the winner of the Maharashtra State chapter is? Do I have all the participants and their mentors in? At least say a yes, because I'd like to know.
Yes, judges are there.
Yes, ma'am. All right. Okay.
Yes, ma'am. Yes, ma'am.
So I wish I could have had more than one winner. At least 3 would have been lovely. But what I've been allowed at the level of Maharashtra State is just 1 winner. And the winner of the 2024 Maharashtra State Resident Competitive Session is, do we tell them, Tanvi? All right, I guess we won't keep them waiting any longer. It's Dr. Iti Jain from KEM Hospital. Heartiest congratulations to you, Iti. She has worked under the guidance and mentorship of Dr. Avinash Ingole, and she has presented her case on the delayed presentation of a case of a keratoconus fistula. Where are you, Iti? Well done. A big round of applause to all of you. And Team KEM and your mentors and your teachers who all have been there supporting you. And I think you delivered your talk very well. You spent the correct amount of time. You answered the questions well. And you're a worthy winner of this, who will now represent proudly our state of Maharashtra at the annual meet at the WOS in Delhi on the weekend of the 4th to 6th of October this year. Well done. I will personally call and thank you and congratulate your mentor tomorrow. I won't disturb him today. And well done to you. And for the rest of you, are the rest of you here too? I guess you are, right? Well done. Let this be more than just a competitive session, an experience in how you could, practice the way you presented. We had a mock round yesterday. You got to be very clear that all your technical jargon is taken care of, and so that you're relaxed and not stressed about all of that. Always remember, there's a very thin gray line between confidence and arrogance. Make sure that you're confident in what you do, but don't seem arrogant. Of course, and the examiners always want their own answers that they want to listen to. But when I trained in England, I realized beyond anything else, they'd be very happy to understand of course, this is for an FRCS, how do you manage your cases in your way and how you're not going to disturb them over a weekend. So with this, I think I'd like to thank every one of you for spending your morning and half of your afternoon. As I promised, I'd try and end it by 3 so you could all have a most amazing rest of your Sunday. Thank you very much, all of you, once more for being part of this event with us. It's been an absolute pleasure and a huge learning for all of us seniors as well, with the kind of cases you came up with and seamlessly presented one by one. Thank you very much. If there's anything else, anyone else in terms of the senior faculty of the students who would like to speak, please unmute yourself and speak now. Right. So I think if this then marks the end of the session today. All right. Have a lovely rest of your Sunday. And thank you once again. And heartiest congratulations to you, Iti. Well done and well deserved. Bye, everyone.
Thank you,
Have a
Dr.
nice
Suvira,
day.
and bye-bye.
Bye-bye.
Thank you, Suvira, for the one Sunday
Thank you so
well
much.
spent.
Yeah. Thank you.
It's extremely nice. Lots of learning for all of us.
Yes.